Commissioner Carrillo, Commissioner Carnevale, Commissioner Chambers, Commissioner Chen,
Present.
Commissioner Cortese, Commissioner Danovich, Commissioner Gordon, Commissioner Mitchell, Commissioner Robinson,
Here.
Commissioner Rolette, Commissioner Tamplin,
Here.
Vice Chair Alvarez,
Here.
Chair Madrigal-Weiss.
Here.
Madam Chair, you have a quorum.
Thank you, Jeff. We are now moving to Agenda Item 2, Announcements and Updates. At this time, I would like to make a few announcements. The July 2023 Commission meeting recording is now available on our website. The next Commission meeting will take place on September 28th in Los Angeles, California. The meeting will focus on substance use disorder programs and highlight opportunities for the Commission to expand promising programs. The day before the Commission meeting, on Wednesday the 27th, there will be a site visit for Commissioners to interact with consumers and program staff who are serving individuals with substance use disorders. Staff will be sending out more information in the coming days. The request for applications has been released for the Children and Youth Behavioral Health Initiative Round 4, which will provide grants to youth-driven programs and the RFA for Round 5, early intervention programs. They will be released in the coming days. These grant projects are a part of the $4.7 billion investment in the mental health of our most vulnerable children and youth. Vice Chair Alvarez has been designated by the full Commission to work with staff on this process. Vice Chair Alvarez, would you please say a few words about the Round 5 RFA for early intervention services?
Thank you, Chair Madrigal-Weiss. Good morning, everyone. I'm excited to announce that the Commission has released the Round 4 RFA, as the Chair recently stated, and these are specifically supporting youth-driven programs, and that this next round, Round 5, will be released in the coming days. To remind folks of the Round 5 specifics, this round of grants will support early intervention programs and practices and is intended to increase the number of coordinated specialty care clinics that address first episodes of psychosis, but also can support things like youth mobile crisis response teams, as well as school-based programs. So many of the priorities that the Commission has focused on over the last few years and that our stakeholders have pushed us here at the Commission, as well as the state on, this round will have an opportunity to support those initiatives. Together, the rounds 4 and 5 will distribute up to $150 million to support programs for children and young people across the state. I want to emphasize how pleased we are to see the effective collaboration that's taken place between our Commission staff. So huge thanks to Tom and the team that he's leading, as well as the Department of Healthcare Services under the leadership of Autumn Boylan. And that partnership has happened throughout this process. We really can take bigger steps towards the accomplishment of tasks that bring lasting change and a positive impact in the lives of our young people when there is greater collaboration and partnership across state agencies. And so we want to express, again, continued appreciation for the effectiveness of that partnership thus far. The Round 5 RFA does reflect the input received during work groups and listening sessions conducted by DHCS, as well as stakeholder feedback that we've heard during our Commission meetings over the last few months. Each of the 6 rounds of funding through the CYBHI has an equity focus and calls for programs that, quote, reduce health disparities by improving equitable access to services for parents, caregivers, and children in California that are culturally and linguistically responsive to the needs of the populations of focus. We are proud to be a part of this effort and are excited for the impact that these resources will make because of the leadership of our community. So looking forward to hearing about the results of this funding at a future meeting. Thank you.
Thank you, Vice Chair Alvarez. You have all been emailed a copy of the Commission's Transformational Change Report covering our work for the first half of 2023. The report highlights the breadth and depth of the Commission's work, including updates and status reports on all initiatives and more in-depth features on community engagement, innovation, FSPs, EPI+, new advocacy grantees, our strategic planning process, and modernization. We have also included a hard copy of this report in your packet for easy reference. Please reach out to Andrea if you have any questions or would like any additional hard copies to take with you today. The Research and Evaluation team will be holding a Mental Health Services Act Research and Evaluation Committee Workgroup meeting on Friday, September 22nd from 10 a.m. to 11:30. This workgroup provides expert guidance to Commission staff regarding MHSSA evaluation planning and implementation. In September, the workgroup will hear from West Ed, the Commission's MHSSA evaluation partner. West Ed will present a plan for conducting robust community engagement to ensure that community partners, and especially youth, are involved in guiding the planning of this evaluation. We hope that you can join us and lend your voice to this very important initiative. And today, I am grateful to have Brian Sala with us. Brian served as the Commission's Deputy Director of Research and Evaluation from 2016 to 2023. He built the fiscal tracking system for the Commission that continues to help mental health consumers and their families, policymakers, advocates, lawmakers better understand how funds are spent at the local level. The creation of the fiscal tracking tool, Brian, why don't you go ahead and stand up while I'm saying all this? Thank you, Brian. The creation of the fiscal tracking tool and its publication led to the identification of some $350 million in unspent MHSA funding. The tool led to the expansion of services to high-need mental health clients and resulted in staffing the statutory changes, revisions in state and county fiscal practices, and elevated public understanding of the essential nature of the Mental Health Services Act funds for the California's public mental health system. Brian was also instrumental in elevating approaches to support county engagement, collaborative learning, and capacity building at the local and community levels. I am thankful and appreciative of the compassion and unwavering contributions Brian provided during his time at the Commission. Please join me in welcoming Brian. I would also, join me in welcoming Brian. I would like to add that from the moment I started at the Commission, any question I had, Brian was always willing to explain things to me. As you all know, I come from the world of education, so I had a learning curve in a lot of the language, acronyms, and just the systems in general, and Brian was always helpful. And he has done a lot for this Commission, a lot for the team, the staff, everybody. So Brian, you've made great changes just for not only the staff and the Commission, but really the entire system. So I want to thank you for that, Brian. So I would like to open it up to any commissioners or commission staff who would like to say a few words. And then I have a resolution that I will be sharing with Brian. So please, I welcome commissioners and then staff, please, if you'd like to say a few words. Please, Commissioner Tamplin.
Thank you, Chair Madrigal-Weiss. Brian, I just really appreciate this opportunity to share and express my gratitude for your leadership, for always being welcoming and supportive. Every time we needed you, I know, my experience was that you were always there. Your commitment and dedication to this work and to really seeing the overall, our state of California moving towards recovery of people struggling with mental health challenges and substance use challenges was always at the forefront of your work. And we all benefited from your leadership and involvement. And so it's seen in the team that worked with you closely on a day-to-day, and then for us that had the honor and pleasure to work with you through the Commission activities and engaging with you. And I know the stakeholders always had access to you too. So much gratitude and appreciation for everything you brought to us and continue to do. So thank you.
Please, Commissioner Gordon.
Brian, thank you for your dedication to the mission of the Commission, and thanks especially for your work on the school mental health issues. This was something new for the Commission to focus on, and you took great pains to learn, including making trips to to various places to see how the school systems work. And I think you can see how it's paid off now. There's both tremendous interest in the area, but also tremendous movement and initiatives on the part of the governor's administration, and it's moving in a direction that will lead to much more prevention rather than treatment going forward. So thank you for all of your contributions. It's been a pleasure to work with you. We'll get a picture of you.
Would you like to say a few words? Sure. Thank you, Brian. Sorry. No, you're right.
Chair Montervice, Vice Chair Alvarez, all the commissioners, thank you so much. It's been a long journey. I didn't accomplish everything that I really set out to do when I joined Toby over here at this team, but I really believe in the mission of this organization. I think transparency and accountability are at the core of serving the people of California, and particularly consumers and family members across the state. This is a critical mission. It will be a critical mission regardless of what happens with the reorganization or the governor's plans. I understand that there's a panel today on research and data. I'm very excited about that. This has been my passion my whole career, of thinking hard about how you make governmental institutions function in lieu of real competitive environments that you get in the marketplace. And governmental institutions that drive transparency and accountability are at the core of service to the goals of those organizations and the people. So I applaud you on the work you're doing, and I really appreciate being here today. Thank you so much.
Thank you, Brian.
Chair, can I add one last comment?
Please, Commissioner Mitchell.
So Brian, when I started in 2016, you were one of the first people who I really worked with. And so it would be remiss if I didn't, honor that, because you were always so helpful in trying to just introduce me to the commission, to the work, and just always there to answer questions, and just very, very welcoming, because it was new. And, I'm that parent that sits on the commission of a child with a severe mental illness, and now he's 25, so he's not a child, but still, it was a lot of emotion in all of that. And you were just very, very warm and helpful with everything. So just thank you, because I have missed you, but thank you so much. I just want you to know that it did not go unnoticed.
Thank you. Thank you, Brian. I want to welcome everyone again into today's meeting. The plan is to end at about 4 o'clock. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. It is now time for Agenda Item 3, General Public Comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for everyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. We currently have 3 public comments. First, we have Stacy. Your line is open.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Thank you for making the news available about round 4 and round 5 of the CYBHI grants, one released and one to be released within a few days. I'm hoping to remind the Commission that it is in writing that community-defined evidence practices, or CDEPs, are eligible to apply for every round and should be given equal consideration as evidence-based practices for awards. I am asking the Commission to ensure that at least some organizations that utilize CDEPs will be awarded in the rounds that you are responsible for administering. Further, if no programs that utilize CDEPs apply by the deadline, the Commission should reopen the RFP and recruit organizations utilizing CDEPs. Finally, if no organizations apply that utilize CDEPs for the program for the CYBHI, I ask that the Commission be concerned and ask itself why no such programs applied, make an investigation and discuss this at a regular meeting. The agency, CHHS and DHCS, have indicated to our communities that they are committed to CDEPs and want to see them awarded in every round. So I hope the OAC has a similar commitment to these practices that reduce disparities and are often preferred by BIPOC and LGBTQ communities. Thank you.
Thank you, Stacy.
Next, we have call-in user. Your line is open.
Hi, this is Mark Carmetz, and I have some announcements, and that is that Project Victorian Peer Support Network is going to be doing the training on certified peer specialists starting on September 5th, going through about the 16th of October, and that will take place. I think it's going to be in the evening, but I'm not sure. So look it up and have consumers apply who want to be certified peer specialists. Yeah. And also, Doors to Wellbeing is going to have their webinar on next Tuesday, and I think it's going to be on, I don't know exactly what, but take a look at their website. And I thank you for letting me know that the next commission meeting is going to be here in Los Angeles. I'd like to know exactly where so that I can spread the news. Thank you. The National Models for Peer Support Certification. That's Tuesday, August 22nd. That's 11 a.m. Also, the California Technical Assistance Center in Florida is going to be doing something on peer-run crisis support centers, endorsing those. So please get people onto those webinars so they can learn about these support centers. Even though we have some of them going now in Los Angeles County, we need to have more in all over the county, all over the state. So please put that news out. And I will do myself best to do the same. That's my announcement. Thank you, Mark Carmet.
Thank you, Mark.
Next, our last public comment, we have Steve. Your line is open.
Thank you very much, Chair Madrigal-Weiss and the Commission. So what a great surprise to see Brian Salam. I just wanted to reiterate the comments of some of the commissioners. You know, when I first ever contacted the OAC, I think it was by email, and I got a return response quickly and was very helpful, which, as you all know, doesn't always happen from different state agencies. And so it was very refreshing, and it helped set the tone for what became greater involvement of participating and following the meeting. So it's good to see Brian, and I hope he's doing well. I would ask that you all maybe ask to see a review of Cal Mesa's peer certification process of the 5,000 scholarships, how many actually are awarded, how many have been implemented. They do have a registry that allows you to look up, if you put your county name in, you can look up and see how many people are registered in your county. And, but you can't see the state view. And when I look at LA, Orange County, Riverside, and San Bernardino, the numbers are relatively small for 45% of the country. I mean, the state, I'm sorry. So if this is a big part of SB 326, federal funds participation, using peers that can bill Medi-Cal, I think it's important to pay attention to how they will be included and how we're going to include just peers who have mission and purpose to help other people get further along that maybe don't bill Medi-Cal. I feel we're getting sort of conflicting signals, and with that, my son has gotten a peer. It wasn't directly a peer that has what he has, but it was a family peer. It's been very helpful. And having participated in a lot of support groups and led and facilitated support groups to help people access services, I know how important it is to have someone walk alongside you on these journeys. So I would just ask that, at least as a management review, maybe a single-page report from Cal Mesa on what's going on. And because we are 1 year after the start date, and right now we're just getting into specialty peers a year after the start date. So timing and urgency is so important when people are getting sicker progressing each day. And I would just like to add implementation and timeliness to the review of what happens, the great aspirational programs that are coming down from the state. So thank you very much.
Thank you, Steve. Appreciate you bringing that to our attention. I think we have staff already working on that, so more to come, but thank you for bringing it up.
That was our last public comment.
Okay, thank you everyone for your comments. The commission will now move on to agenda item 4 and consider approval of the minutes from the July 27th commission meeting. At this time, I would like to invite commissioners to offer comments or ask questions. I see no comments or questions here in the room. Anything online? All right, so then there's now time for members of the public to request to make a public comment on agenda item 4 by clicking the raised hand button on your computer or the app, or if calling in by phone, pressing *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Also, please limit your comments to 3 minutes or less. Are there any public comments? Please raise your hand now as the queue will be closing. Mariani, please open the line for public comment on agenda item 4, and we can start with comments from in the room if we have any.
I have none from the room, and I don't see any online.
All right, I would then ask to entertain a motion to approve the July 27th commission meeting minutes.
So moved.
Second.
Thank you, Commissioner Robinson, and second from Commissioner Alvarez. We have a motion and a second. Are there any, there were no additional comments or questions? Seeing none, Jeff, could you please take the roll?
Of course. Madam Chair, before taking the roll on this item, I'd like the record to reflect that Commissioner Mitchell has joined the meeting and that Commissioner Bunch is also present. We had audio issues with her when taking roll the first time. On the motion, Commissioner Bontrager.
Aye.
Commissioner Brown. Commissioner Bunch.
Abstain.
Commissioner Carnevale. Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon.
Aye.
Commissioner Mitchell.
Abstain.
Commissioner Robinson.
Aye.
Commissioner Rolette. Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Aye.
Madam Chair, the motion passes.
Thank you. Let's move on to our next agenda item, agenda item 5. The Commission will hear a panel presentation and discuss the use of data as a lever for transformational change. Before I turn it over to staff to introduce the panelists, let me say how excited I am that we are having this discussion on data. In the education field, data is fundamental to how we monitor, track, and trend our students and review the trends our students are demonstrating. When we pay attention to how our students are doing, what their educational outcomes are, we can then make good decisions about how to support our teachers, our school staff at every level, and how we can support our districts. I'm thrilled that we are going to hear more today about the opportunities data can offer toward increased accountability for our mental health system. I'd now like to pass it over to Commission's Chief of Research and Evaluation, Melissa Martin-Mallard, to introduce the topic and our esteemed panelists.
Thank you, Madam Chairman Weiss. Is my audio okay or am I echoey?
I like it because you said my name and it sounded like I was in a big auditorium. Like, I'm teasing. Yes, there's something going on with audio. So let us fix that and see what it is because there's an echo.
Okay, how is that?
That's better. I'm no longer in the stadium.
Okay, great. Good morning, everyone. The purpose of today's agenda item on data and metrics is to discuss some of the opportunities and challenges related to using data for decision-making, transparency, and accountability, with an emphasis on accountability for public systems. Each of the panelists today will share their unique and specific perspective on using data for public governance. After the presentations, we will open it up for commissioners to ask questions and have a discussion with the panel. Then, of course, we will open it up to public comment. I'm pleased to present the panelists for today's session on data and metrics, starting with Dr. Emily Putnam-Horstein. Dr. Putnam-Horstein is the John A. Tate Distinguished Professor for Children in Need at the University of North Carolina, Chapel Hill, and the faculty co-director of the Children's Data Network. Dr. Putnam-Horstein's current research focuses on the application of epidemiological methods to improve the prevention of non-fatal and fatal child abuse and neglect. Her analysis of large-scale linked administrative data has provided insight into where scarce resources may be most effectively targeted and informs understanding of maltreated children within a broader population-based context. I'll now turn it over to Dr. Putnam-Horstein.
Perfect. Thanks so much. Let me just make oh, did you want me to I was going to share my slides, or do we want to do it this way?
Either way.
I'll
stop sharing.
Okay, perfect. Thanks. Just 1 second. I think I'm all set up here. Almost all set up here. Not all set up here. Perfect. Sorry about that. I just want to thank you for the opportunity to speak today. And before I dive in, I also want to just say that I am a member of the Brian Salas fan club. So it was fun to be on this morning and hear him honored. I can't even remember when I first met him, but he has been such a leader across so many different agencies. And I want to kind of channel what he was really reinforcing, which is the potential to use data to promote transparency and accountability in our public systems and for the people of California. So as you heard from Melissa, Emily Putnam-Horstein, I've had the privilege of working closely with a number of different state departments in California going back almost 2 decades. And so I'm going to keep my remarks very brief this morning, but what I'm going to do is present 4 just examples of how data have been used to generate new insights, drive important policy and practice conversations. And I will close with an example where I hope to reinforce that I also think we don't need to rely on data that is retrospective, but can increasingly bring more data to bear in our daily decision-making in a way that will serve children and families and all individuals in California. I will also say that because almost all of my research is very focused on the child protection system, you will not be surprised that my examples do focus on child welfare, but I have tried to bring a mental health lens to those examples and select them based on that. So I will go ahead and get started. Just very briefly, the Children's Data Network is a project housed at the University of Southern California in partnership with the California Child Welfare Indicators Project at UC Berkeley and the School of Social Work at UNC, where I now am. And for the last 10 years, we've been working closely to demonstrate that there's a lot one can learn from individual data systems that serve children and families, but that much more that one can learn when you connect those different data systems. And so the examples that I will present emerge from a multi-year effort where we have been partnering with the California Health and Human Services Agency to carry out what we affectionately call a record reconciliation. We probably should have come up with a more exciting name for it, but what that looks like is that Starting back in 2018, we have had an agreement whereby the departments within HHS have sent us a census of all the clients that they have served in that calendar year. And we have used probabilistic algorithms to match up those clients so that we can see how many clients, for example, had an open child welfare case and were also receiving developmental service supports. This is the trajectory in terms of the different records that have been included. And I'm happy to report that we are partnering closely with the Center for Data Insights and Innovation within CHHS to transfer back to them a lot of this linkage work. So we treated this as very much a demonstration project of what's possible when we create kind of that huge Venn diagram that helps us understand the different public benefit and systems that individual clients are interacting with. And we will now be kind of returning to the state everything that they would need to carry this forward. So that takes me to kind of the first example that I will provide, which is a very, very simple one. But the question we were seeking to kind of address was simply, what is the overlap of children across some of our major public benefit programs? These data that I'm presenting here reflect all children who were receiving benefits or services from each of the programs listed on the x-axis. The data are from 2017. We've continued to update it annually, but I'm just showing this for more illustrative purposes than anything else. And all we did was look to see how many children who were interacting with one particular program were also receiving services from others. And so I want to draw your attention to that fourth bar where it's labeled child welfare. And what you will see is we were able to look at all children in California who had an open child welfare case for services in 2017. That meant they were either receiving kind of court-ordered services in the home, or they had been removed and placed in foster care. And what you will notice about that bar is the portion that is the kind of the bright turquoise is much larger than any of the other bars. And that's because nearly a third of children who had an open child welfare case were receiving services or were kind of eligible for services from at least 5 other CHHS programs. And you can contrast that with some of the other bars. But what did this provoke? Well, it really provoked kind of an appreciation that care coordination is incredibly important for this population, both because they likely have higher needs, but it was also a reminder that while we tend to think about programs in very siloed fashions, a whole bunch of programs and departments within CHHS were serving a population of children who they thought of as child welfare, but were also their children. The second example is an example where what we did is we were able to link up Medicaid or Medi-Cal records for children throughout the state and try to answer a question as to how many of those children both had a diagnosed mental health disorder and how many of those children had some child protection or child welfare involvement. So this study involves all children in the state who were Medicaid eligible for at least 1 month in 2014 and 2015. We were then able to look at their kind of claims to identify all those who had a mental health diagnosis. And then using those linked records that we'd been working with the state on, we were able to document how many of those children with a mental health diagnosis had some involvement with the child protection system, either currently or in the past. So we were going all the way back to the late 90s to look at this. And I want to kind of call your attention to a few things. First of all, what's not shown on this chart is that fully 50% of kids with a mental health diagnosis in our state had some level of CPS involvement. 50%. In contrast, for children who were Medi-Cal eligible and had no mental health diagnosis, that number was 23%. So a really, really striking difference between Medicaid eligible kids with a mental health diagnosis versus without. But what you will see here is there was also tremendous variability in terms of the likelihood or the proportion or percentage of children who had a mental health diagnosis and had CPS involvement. So this chart shows that, for example, at the very top, for children who had been diagnosed with bipolar disorder, 75% had had child welfare involvement. At the other end of the distribution would be learning disorders, where it was 29%. But I think really importantly, it's a very large number overall. And what you will see that I have highlighted in the kind of text I've pulled from this paper is I think it's really important that we remember that the vast majority of children who have mental health disorders and have child welfare involvement never end up in foster care. In this population, it was 87% of these kids we were looking at were remaining at home, which is great. But then the question is, how are we ensuring that we've coordinated the proper array of services for both their mental health needs and anything that may have given rise to child protection involvement? So that is example number 2. Example number 3 is another paper where what we were doing here was trying to take a look at how much there was a discrepancy between what we kind of are maintaining in one case management system versus another. And I think this speaks to the importance of continuing to link data as opposed to simply thinking that if we add more fields to our existing data systems, we'll get the information that we need. And so in a nutshell, what we did is we simply looked in the child welfare data from California and said, if we treated that data as accurate when it comes to a kind of mental health diagnosis, which in the official files is called an emotional disturbance. I realize that's not ideal language, but that's the language that's used in the AFCARS files. And if we simply looked in the child welfare data, we would go to our legislature, we would enter into policy discussions claiming that 13% of children in foster care have some kind of mental health diagnosis. But when we actually link up those children who are in foster care to their Medicaid records, what we see is that that 13% is a huge underestimate. We found that almost half of children in foster care had a mental health diagnosis. And so I share this because there was kind of national congressional testimony that was given, not just about California, but about all sorts of states that in some ways really misrepresented the extent to which mental health challenges and concerns and supports were needed because they relied simply on one data system as opposed to looking at the data system that really is the source information, which would be coming from that which provides mental health and healthcare services. And then my final example before I turn it over to the next panelist is one where I want to kind of just reinforce that. What did I show you? I showed you some data from 2014, 15, 2017. I showed you data from years ago because that's what researchers do. They wait for data to become available. They come up with an analysis they want to run. They write a paper, and then they hope that a handful of policymakers and others will read the paper and that there will be translation and there will be impact. But increasingly, we do not need to do that. There are ways that data can be harvested in real time and used to improve practice. And so this is an example where I will not walk you through the full picture, but what I want to reinforce here is that in our child protection system, we make a series of decisions from left to right. Calls come into the hotline. We're making a decision about whether we investigate or not. And what we have been doing in partnership with Los Angeles County is to start harvesting information from the case management system in real time so that supervisors are presented with information as to the kind of risk and protective factors that may be operating so that they can better tailor and target their time to make sure that they are connecting children and families with preventative resources and interventions when warranted. And so I just want to kind of reinforce that I think there are tremendous opportunities to continue to promote accountability and transparency through linked data, through administrative data. But I also think that there are real opportunities to start thinking about very kind of cost-effective tools that can be used as overlays to our case management systems so that we are helping frontline staff do a much better job serving children, families, and others throughout the state. Thank you so much.
Thank you so much, Dr. Putnam-Hornstein. Our next panelist is Daniel Webster, who serves as the principal investigator of the California Child Welfare Indicators Project, which carries out quarterly production, dissemination, and technical assistance on performance measures in support of the state's outcomes and accountability system. Dr. Webster has provided consultation to child welfare agencies in jurisdictions across the country on understanding and applying longitudinal data to promote continuous quality improvement, and has co-instructed courses with colleagues from Chapin Hall at the University of Chicago on advanced analytics for child welfare administrators. So I will now turn it over to you, Dr. Webster.
Thanks, Melissa. Can you hear me okay? I just want to do a sound check. Great.
Yep.
We're not in the stadium. Okay, great. And thank you to the members of the commission for giving me the opportunity to speak with you today. It's always great to go after Emily. Those are tremendous examples that Emily gave. I'm going to share my screen and bear with me. Share. And I'm going to take a step back and talk about my experience working with the Child Welfare Indicators Project and give the commission my thoughts on key foundational pieces for ongoing use of data in the use of system accountability and transparency. And this is based on my, as Melissa was saying, 20 plus years of experience working with the Child Welfare Indicators Project at UC Berkeley in partnership with the State Department of Social Services. We get quarterly extracts of the state's administrative data system, child welfare data on all the clients who are members or who are touch the system from the first maltreatment report all the way through coming into care, or length of time in care through different placements, exits from care and returns to care. And then we post it on our public website. We've been doing that for over a decade or close to 2 decades now as part of the state's outcomes and accountability system. And I'll say a bit more about that in a moment. But I'll start with, when I say the necessary preconditions for transformational change using data, I think that the first step that's necessary for that is a change in mindset. And it's kind of a cheeky a cartoon I'm throwing up here, but I think that in human services, certainly in child welfare, and I would imagine in other human services as well, there is a mindset where folks think that, well, I came into this work to help people. I'm a people person. I'm not a data or a math person. And so you end up running it. If you're trying to use data to improve your system, look for areas where it needs to be improved, you can oftentimes run into these different stages of reactions from the folks that you work with, from from complete dismissal all the way up to, on the right where people think, well, I'm just going to use whatever data I come up with to support the position I already have. And so with apologies to Dr. Kubler-Ross, we think of adding on a whole new layer of this to where we feel that we want to impress on the workforce from the top down, all levels of the different agencies in the systems, that data are not something that are another component or something that only geeks do, or the data people do, or the data quality or data assurance people do, but it's something that the entire system does, the entire agency does, in order to improve its work with helping the clients that it's charged to help. So a different mindset. Then barriers, challenges that we have had to encounter and overcome are, I've listed a couple here. Transparency. Certainly human service systems are used to, if you read the paper, being assailed by sensational stories. And so there has been a tendency, certainly in child welfare, for some time ago to be a little bit more insular, closed, not sharing our information. And yet that doesn't help to fostering a discussion either across systems, across counties, across jurisdictions within our state, as well as across larger areas across the country, to be able to monitor how child welfare systems or our system is functioning by being closed. And so you have to have the intention to be willing to open up your information so that we can have a conversation, not only within our system, but with other stakeholders. And the important work that Emily was sharing before, being able to share our information so that we can see the overlap between our systems, because in many cases, a lot of the clients that are in the child welfare system or in the mental health system are also in the educational system, and they also then go on to be in other systems as well, in the adult systems, for example. So you have to have the intention. You have to have then the sharing of the information. And Emily, spoke about that important reconciliation work that the Children's Data Network was doing at the state. That's key. Sharing, making those permissions, linking the data on an ongoing basis is clear. And there are certain, technical and resource issues that go along with allowing that and doing that on an ongoing basis to support the work. Then finally, masking. Once you present the data, you have to be concerned about client confidentiality. And so whatever mechanism you do to disseminate that information, you have to be always mindful of protecting confidentiality. And so there are masking concerns that you have to be mindful of. Centralized access. This is where my project at Berkeley is, I think, is a really important model, and I'll speak to that in a moment. Is that you have to have a place where everybody can come and see what the certain measures are that you're agreeing to track for your system for mental health, for example. If it's only if it's in some database that not everyone can get a hold of, then it makes it very difficult to foster conversations about examining places where we have to, or places of strength and places where needed reform must take place. And then ease of access. It has to be central, but then it also has to be intuitively presented. If you have a great website but nobody goes to it, then that doesn't serve people. If a tree falls in the forest and nobody's there to observe it, it really doesn't make any difference. So you have to have, it has to be easily accessible, it has to be intuitively presented, and then you have to have responsive technical assistance if people have questions, because at a given time, people could go to a place, look at certain measures and not be clear on what those might be saying. And you need to have mechanisms in place to help folks to be able to understand what they're observing, whether that's through quick email responses or a phone call, a telephone number they can call, that sort of thing. And we try to do that at Berkeley. We're extremely responsive on those kinds of things. Then there's developing of the core metrics, right? So you want to have the intentionality, you want to present your data, but then you have to have metrics that you want to pursue as a system. And so developing consensus on those metrics is a very key point that you want to agree on. Like, what are the certain things that we want as a system are interested in tracking? Because it's not what we want to be tracked, but what actually gets measured is what gets done oftentimes. And so agreeing on, having a consensus about what are our system goals is absolutely key. And along with that, as you decide on your system goals, you have to be mindful of coming up with methodologies, measures that you develop that don't take you in a garden path or in an easy direction that looks like you're answering a question, but in fact, it might have inherent biases in it. And so, for example, in child welfare or in any system, if you do a point-in-time count, it's the easiest measure that one can do. How many children or how many clients are receiving specialty mental health services, for example, on a given day? That's a great measure. It's very important to give us a sense of the census count on a given day over time. But if you then expand your questions for system performance, like how long do my clients get specialty mental health services? If you just use that point in time count, you are going to get a very biased answer in terms of the length of time that those clients are getting the services, because, and I will go into it, this is, come to my class on advanced analytics and we can talk more at length about this, but if you take a point in time count, you end up oversampling on clients who have been in the system for longer periods of time. And so you get a longer estimate of how long your overall client population is receiving services. So you have to avoid the garden path. And finally, you have to be mindful of unintended consequences. As you develop your core metrics, you can say, we want to decrease a certain number of things. That could be one system goal you have, but you have to be mindful that in monitoring that goal, you might have unintended consequences that affect other parts of your system. So for example, if we want to decrease the use of high-level congregate care facilities, the highest level psychiatric congregate care facilities, and that's our goal, that's terrific, but if we can't just monitor the decrease in that, because as we deflect clients off of that highest level of care and we're putting them into lower levels of care, we want to be tracking those clients who are formerly in this high level of care and looking at their needs and making, because they could have an effect on, for example, placement instability, levels of care in these lower levels of care that we need, and so our availability of those other levels of care, we need to be tracking that as well, placement disruptions, those kinds of things. So unintended consequences and counterbalance measures are another important part of developing our core metrics. And finally, I'll go back to workforce. You have to train your workforce to have the attitude that data are important, but then you also have to build the skills in your workforce from the top down. Most agency managers and deputies are really good at this, but like as you get down to program manager and down to the your line staff, they too need to be good consumers of the information. Understand that entering of the data is important so that we can, as a system, track our performance and help use it to help us do a better job. Moving to my next slide, which is around the incentives. Okay, these are examples are all from child welfare, but what I mean to do is to show you some examples of federal and state instances where we've had policy. It's not a silver bullet, but certainly a policy can help mobilize a shared responsibility and shared interest and efforts. And certainly we have observed this in the child welfare field with a federal review and a state review that's built on a federal review of our system. It really motivates people, mandates people to be tracking these things, and it actually gives us the infrastructure and the motivation to have public reporting and ongoing tracking of our data. And I've put some other examples here. Extended foster care is another one where we're using linked data now to track the transition age youth as they go into different systems, that sort of thing. That's also on our project at Berkeley. And Family First, which is more safety, but the same kind of a motif. And then I'll close with saying promising models. I don't want to toot my own horn, but certainly I think that certainly for child welfare, we've had a lot of success, as I mentioned, with our partnership with the state and with philanthropy in a public reporting portal with measures on an ongoing basis that we report every quarter, refresh a array of system trends and outcomes. And then there are other great projects such as Emily's project, the Children's Data Network with the linkage work, and then some others at University of Michigan, Kansas, and at Chapin Hall, University of Chicago, where the use of data is an ongoing enterprise to then help help the system to do a better job. So I'll close there and turn it over to the next panelist. Thank you very much.
Thank you so much, Dr. Webster. All right, our next panelist is Serene Olin. Dr. Olin is a principal at Health Management Associates. At HMA, she works with states, counties, health plans, providers, and consumers to improve behavioral health care quality in real-world context. Within California, this includes conducting behavioral health needs assessments, as well as implementation of CalAIM initiatives, the CARE Act for the seriously mentally ill population, and the Children and Youth Behavioral Health Initiative. I'll now turn it over to Dr. Olin, and let me get the slides up.
Thank you so much, Melissa. And thank you for sharing the slides. I really appreciate it. Great. So thanks for the opportunity today to share the work that was conducted actually while I was at the National Committee for Quality Assurance a couple of years ago. And this work was actually funded by the California Healthcare Foundation, where we were asked to really essentially conduct a landscape of behavioral health quality measures. And so this white paper with the same title is actually available on both the NCQA as well as the CHCF website. So just wanted to refer people to that in case you wanted to dig into the details. So next slide, please. All right. So today I'm going to highlight a few things from this work. I wanted to share some of the insights that we gained as we conducted this kind of national overview, if you will, about behavioral health quality measures and the challenges associated with the existing accountability measures. I then want to show you a behavioral health quality measurement framework as a potential path for behavioral health entities to embark on the quality journey. And then finally, really walk you through a roadmap for how we might get to joint accountability for whole person care. So next slide, please. I think we can skip over this one. All right, so I think this is just background, just wanted to highlight a few things. I think all of us on this call know that individuals with behavioral health conditions really have, it exacts a very heavy toll on individuals. They have higher morbidity, poor health outcomes, and much lower life expectancy than the general population. And we know that effective treatments are available, but the care is not evenly distributed. The other thing that we also know is that behavioral health conditions are a huge driver of cost and healthcare spending overall. And this is true across both the commercially insured lives as well as publicly insured lives. And there are studies showing how the outsized impact on cost with very little being spent on behavioral health services. And so, where does this leave us? So I think we're all aware of national efforts that are evolving to pay for value rather than to pay for volume. And I think the reason why Melissa asked me to talk about this, to speak to you all today, is to really try to think about how quality measures could be used to guide value-based payment to support more equitable access as well as outcomes for individuals with behavioral health conditions. So the next slide, please. All right, so why measure behavioral health quality? I think both Emily and Daniel alluded to this in their presentation. We really can't improve what we don't measure. And so quality measurement essentially is the process of using data to evaluate the performance of health plans and providers against recognized standards and performance. And measurement essentially helps create transparency to care. It also could help foster accountability and drive improvements in care. And so typical metrics that we see focus on structures of care, processes, outcomes, also might include things like looking at functionality, quality of life, and safety. So the figure on the right is essentially a preview. I'll walk through this in more detail later, but essentially shows how in healthcare, including behavioral health, different levels of the health system essentially uses quality performance measures to hold entities accountable for care delivery and outcomes. It could also be used to create incentives to drive practice change and to support a more functional system of care that's more coordinated. So I will illustrate this later on as we go on through the presentation. So next slide, please. All right. So as I mentioned, the impetus for this work, for the California Healthcare Foundation was really to understand how quality measures can help get us to high quality behavioral health care. We really wanted to understand, and so we actually first started to do this by looking at the federal landscape. We really wanted to understand how federal dollars were being used to drive behavioral health care through reporting. And so here's what we found. Not a pretty picture, right? So across the 39 active federal programs that we looked at, we found over 1,400 measures that were required for reporting. So that's a whole lot of reporting. And what we found from our analyses of these measures is that most federal reporting programs actually require a mix of both physical health as well as behavioral health and what we call cross-cutting measures like care coordination. So there was lots of that going on, combination of all these measures in most reporting programs. And this to us signaled a concern about whole person care. And I think that's, where I think all of us in behavioral health are really concerned about. We also found, a heavy reliance on homegrown metrics. And this was particularly true for behavioral health quality measures. Now, we did find 35 standardized behavioral health measures that are being used across different federal reporting programs, but very few were being consistently used across them. And I think the challenge with existing behavioral standardized measures is that they tend to be very narrowly focused on diagnoses like depression and also on very narrow care processes like screening. They also tend to leverage administrative claims data, which I think, as Emily alluded to, it's useful for accountability, but really quite limited if you're trying to use data to improve real-time care delivery. And then finally, we did identify a few innovative programs that the federal government was supporting that focus on integrated behavioral health and physical health services. And in those programs, we found lots of homegrown measures. They were very common. And I think that's because many of the standardized measures that exist right now do not include key aspects of whole person care or behavioral health integration, that are important to folks, to stakeholders delivering this care. So these insights, to us really pointed to a big challenge in shifting to paying for value in behavioral health. So consider the implications of CalAIM and other California efforts for payment reform. Without standard measures, we're really not able to generate reliable or valid information that can help payers figure out what to pay for or who to direct their populations to. And for the providers, it's also challenging to figure out how to show if they are successful in delivering whole person care. So, so next slide, please, Melissa, I wanted to share. So, I wanted to also, so the other thing that we really wanted to do was we knew that there was a ton of reporting going on across the nation. And we also wanted to learn about the impact of all this reporting. And so we actually did interview a variety of stakeholders across different levels of the behavioral health system in 5 exemplary states. California actually was one of the states where we interviewed a variety of stakeholders who were providing behavioral health care across different levels of the delivery system. And, what do we learn? So I don't think it's surprising for folks to hear that California probably has one of the most complex assortment of funding streams for behavioral health care. There's a lot of piecemeal funding to cover important aspects of care, often social needs that influence health outcomes. And each funding stream comes with its own reporting criteria, which are often comprised of fairly rudimentary measures that are not considered particularly useful for improving care delivery. And what we also heard from folks is that the enormous reporting burden drains resources for innovation and for measuring what matters. Additionally, the one thing we did hear across the board was folks felt that behavioral health integration is really key to combating stigma and to improving care access for those with behavioral health conditions. But there was little agreement on who should be held accountable for behavioral health integration and how to measure what successful behavioral health integration would look like. And finally, we heard unanimously that behavioral health data infrastructure and data sharing issues are really significant barriers to using quality measures to drive care improvement. So next slide, please. So, so the other thing that we really pondered on, given what we heard about the limitations of the existing measures out there, we really wanted to try to get a sense of what mattered to different stakeholders. And essentially, this table summarizes what entities at different levels of the delivery system were interested in measuring. So you see the state, managed care entities, as well as providers here. And what we see here is that they agreed on a few things, right? So they agree on how to track both improvement in behavioral health symptoms as well as functioning. So not just symptoms, they wanted to also understand how individuals with behavioral health conditions were functioning. The other piece that they did agree on was a focus around equity, both in terms of outcomes as well as access to behavioral health care. And they were concerned about honoring patient goals. But you also see here that there are key differences, and the key. So just so you're aware, the goldenrods are where there were commonalities, and for the rest of them, you see some key differences. And wanted to point out to a couple. One is that states who are responsible for population health are often interested in larger social outcomes like kindergarten readiness, crime rates, employment, etc. Whereas providers were quite adamant that they should not be accountable for things like cost, social outcomes, and integrated care outcomes. Not because they didn't think that these were important, but because they currently do not have the right levers or resources to influence the larger outcomes. And so we see that with rare exceptions, these are not what we are currently measuring in our accountability programs. So next slide, please. Thank you. So a key takeaway was this: so despite the wealth of measures and metrics out there, we still struggle in behavioral health to distinguish high value from low value care. And what measures exist are not particularly valued by providers. And we see this reflected in the vast array of homegrown measures out there. So with this insight, our team really grappled with this question: how can we create a framework for organizing a more responsive and rational delivery system? And I think this is particularly relevant for California at this juncture, which is, it's a state that is undergoing historic policy and payment transformation in behavioral health right now. And the opportunity, I think, is before us. It's really tremendous, and yet it can be quite daunting. So what I wanted to do over the next few slides is to offer a framework and a roadmap that might be helpful. So next slide, please. So what you see here is a framework actually drawn from collaboration with Dr. Mary Applegate, who is a medical director in Ohio State's Medicaid system. And at the time, we were collaborating actually with several centers of excellence across the country as part of a pediatric quality measures program funded by the Agency for Healthcare Research and Quality, as well as the Centers for Medicare and Medicaid Services. Our charge there was to reflect on lessons learned to implement quality measures for children's healthcare, including behavioral health. And those who are interested in this, the publication, the reference is actually listed at the bottom of the slide. But this framework really, I think, was really influential for us at NCQ at the time in thinking about coming up with a framework that could be more helpful. And so this essentially is based on a population health approach to managing care that works from both the top down as well as the bottom up. And the key here is to identify priority populations and engage stakeholder participation at each level to drive reporting on a set of core measures. I think to Daniel's point, really honing in on a set of core measures. So starting from the bottom of this figure, you'll see what we call a microsystem. And so this represents entities who are responsible for providing care and services like clinics, hospitals, community organizations, etc. So there's lots of measurement that's occurring here, but each entity is not responsible for all of them. At the middle level, which is the green bar, the mesosystem, this represents entities that oversee care delivery by providers. So these are large health systems, managed care plans, specialty health plans, accountable care organizations, etc. And these entities are sandwiched. So they need to respond to provider or consumer needs from below, as well as regulatory demands from above. And at the top are entities such as the state and the federal government with the broadest regulatory authority and responsibility for reporting population health metrics. And ultimately, that's where we want to see population outcomes. And so the goal for this framework is really to not replicate measures across levels of the system. The goal here really is intentional coordination, focus on a bundle of parsimonious measures that collectively drive population outcomes. And these measures may be bundled in different ways. It could be bundled across the system, right? So from the state to the managed care levels to the providers, or they could also be bundled horizontally to incent collaboration across different entities who may be working with and who actually oftentimes are working together to support better outcomes for common populations. And so anchored through, this, is really the needs of the population and their experiences and what matters to them. And to date, we have not done a great job, I think, of really capturing those as well to support high quality care. So the next slide. So, so with this framework, what I wanted to share now is, what do you do with a framework, right? We have a framework, that's great. How do we apply this? And so this slide depicts a roadmap for how we might use this framework and put it into action. I think step one, is to establish key population health goals and priority populations. I think California has done that in a meaningful way. The second step is really to look at measurement tools and transparent reporting structures. And these are key to guide strategies for improving care quality and health outcomes. And to do this, we need to invest in data infrastructure, we need to leverage technology, and we need the support of policies and payment to promote and sustain the alignment of these efforts across the system. So next slide. So over the next few slides, I wanted to help make this a little bit more concrete with an illustrative example of how quality measures might be used here. So the first step, we talked about identifying population goals and priority populations. So we might all agree, for example, that a priority population goal in behavioral health would be to reduce suicidal events and deaths. And so to do that, we really need to move beyond a very narrow focus on behavioral health diagnoses and to look upstream to identify people at risk. And so this might include high-risk populations with behavioral health needs as shown on this slide. Next slide, please. So the second step is really it's about stakeholders coming together to develop bundles of meaningful quality measures at each level of the system. And this slide shows an example of quality measures that includes, outcome process structure measures that might be used to drive the population level goal of reducing suicide. So I wanted to just highlight just one bar, which is the outcome bars, the very top bar in each of the sections, dark blue, the green, and the light blue on this slide. So if we start looking at the outcome bar for states, which is the dark blue section at the top, their responsibility and priorities around population outcomes. So they might track, for example, suicidal events and mortality. To support this outcome, states might develop contracts with managed care entities and focus managed care entities' performance metrics on individuals who show up in the emergency room with behavioral health crises. And that's because we know that such crises are reflective of unmet need for behavioral health services in the community. And in turn, that middle level, the meso level, where the managed care entities live, they might then develop contracts with providers, their network of providers, that prioritize the outcomes associated with the interventions that are being delivered. So in this case, this may include things like timely access to evidence-based prevention and treatment services that have been shown to lower self-harm and suicidal ideation. And then in the last level, the light blue section, the providers, they might focus on metrics related to treatment engagement, metrics related to improvement in symptoms and functional outcomes. And to do so, providers would need to ensure that they have capacity to support or coordinate a full range of services, including crisis response. And the bidirectional arrow on the left that you see in this figure indicates the role of public reporting of key metrics by each entity. And I think Daniel alluded to that. And, this data sharing is so important. The public reporting is so important to help inform efforts by different players who can collectively contribute to the population goals. So you see how, at each level, you can create quality metrics that each entity is uniquely qualified to track, and they can do so quite independently. And I think to Emily's point, we don't have to wait, for claims data to come through. There are things we can be doing today to use data that you collect in real time to inform the care that we're delivering. And so in the next slide, I wanted to finally highlight, the larger system supports that are needed to facilitate the use of quality measures for driving outcomes. And so these include updated policies around behavioral financing to support adequate evidence-based care. And we know California is in the throes of doing that. We also need data infrastructure to support the use of metrics to track outcomes. And then finally, we really need to also, focus on policies that support coordination and information exchange across the system. And finally, I think we all know there's also a strong need for workforce with capacity and training in evidence-based practices and culturally competent care. So the next slide, please. So here's what I hope you take away from this presentation today. So if you are an individual in the audience, wherever you are in the care delivery system, here are the things I would like you to be thinking about and how you can contribute to the larger behavioral health transformation efforts in California. So number one, what's your role? How do you contribute to building a full continuum of care for behavioral health treatment and recovery services? We know that a key goal of CalAIM is to transform and strengthen Medi-Cal by reducing complexity across delivery systems. So consider how you might use this framework to reduce all the noise out there and focus on the key structures, processes, and outcomes that are relevant to you and your role in the ecosystem. And then secondly, I really wanted folks to think about the tools as well as the strategies that you might use to help you stay on track. So this might include selecting coordinated quality measures that could be used and that are tailored to your role and responsibility, but are aligned to the larger systems goal. The goal here really is to use data to support transparency, inform strategies to improve the care that you deliver, and to demonstrate your success. And this is going to be increasingly important as we move into the value-based world. Many of us who work with in behavioral health work with highly challenging populations. We've heard repeatedly that increasingly Individuals who present with behavioral health conditions have become more acute and more complex. So, now more than ever, I think the question is, how do we leverage the historic investments and resources that California has put into the behavioral health delivery system? How will you coordinate and collaborate with key partners across the system, both vertically, so across the state, managed care, and providers, as well as horizontally with your peers? How do you leverage resources, your own and that of others, to create outcomes so that the whole is larger than the sum of its parts? And, I know, accountability can be a scary word, especially in behavioral health, because we have been so hampered by the lack of good data. But with the right set of tools and strategies, and I think strategic leadership and alignment, we can start to take steps to transform the system. And I think what I wanted to do is to end with a couple of examples. If you don't mind, Melissa, to the next slide. I want to actually, end on a couple of examples in my new role here at HMA. So, part of my excitement about joining HMA really was the opportunity to put the framework that I had the privilege of developing while I was operating at a national level at NCQA. And so, wanted to share actually two concrete examples at a very high level of how we're actually putting this framework, or at least pieces of this framework, to in action. So this is an example here is from a state client who actually, even before I came to HMA, was using the behavioral health quality framework to tackle challenges in access to care. And in this case, the state combined two frameworks. They combined the care access domain based on the Urban Institute's Medicaid access to care framework, as well as NCQA's behavioral health quality framework. And so they essentially harness aspects of both frameworks to try to get to metrics that could guide their efforts to improve access to behavioral health care. And this is a work that's in progress. The other example that's not here that I wanted to quickly mention, because it's a California example, is some of the work that we have been doing at the managed care level. And here we've been helping a client develop a tiered provider payment model based on the comprehensiveness of the care continuum. The goal here really is to try to promote a more seamless continuum of care so that it can be a more client-friendly system. And so all providers are being held to benchmarks on 5 types of key performance indicators. We also work with them to suggest a pathway for how clients could, how this client could help their provider network get there by starting with where their providers are at and helping them get to using data to drive care. And so, we can talk, and I'm happy to talk to folks about how we are applying this framework in some of these real life situations. So with that, I'll turn it back to Melissa, and thank you again for the opportunity.
Thank you so much, Dr. Olin. All right. Our next presenter is Marlise Perez, who is or has been a division chief with the California Department of Healthcare Services since May of 2013, and at the state level in behavioral health since 2001. Currently, Ms. Perez leads the Community Services Division, which is charged with policy development, oversight, compliance, and monitoring of approximately $10 billion in behavioral health prevention, harm reduction, treatment, recovery services, housing, and infrastructure projects. Ms. Perez is also California's single state authority on substance use disorders for the Substance Use and Mental Health Services Administration. I'm going to turn it over to you, Marlise.
Thanks, Melissa. Can you hear me all right?
Yep, sounds great.
Perfect. Awesome. Well, gosh, I feel so lucky to be a part of this panel. Just the expertise that I'm following has just been incredible. And I just want to applaud the other panel members and just for the OAC, the commission, to be having this really important discussion around data. I've learned a ton already. I hope you folks have as well. I was asked to make this presentation today just to give you kind of some small looks in on some of the data that we have around behavioral health at the Department of Healthcare Services. I'm going to go on record right now, sort of like some of the previous doctors have talked about. I am not a data expert. I'm a policy expert. However, it is so important to have these bridges come together and have key members that really understand data, and also those that are making the policy and make those connections together. So I just want to applaud that you have this important topic today. And so, as you all most likely already know, DHCS oversees several behavioral health funding sources, and we have various data systems. We, of course, as has already been talked about by HMA, we have our managed care plans that oversee some of our mental health data for our mild to moderate population. We, of course, have our Medi-Cal behavioral health system that is overseen by the counties for substance use and for mental health. We also receive federal dollars through the Substance Abuse and Mental Health Services Administration, and that comes down through block grants. So that is for substance use and also mental health. We also receive other grants. We have settlement funds. We have this various grouping of behavioral health funding sources. And I do just want to point out that with that various funding, we have various requirements when it comes to data. Some of those are generated by the federal government, depending on if that funding is coming from them. We have data requirements if it's a settlement agreement or grants, and then sometimes we also receive state general funds that may have data requirements. So they're all a little bit varied, and we have quite a few data sources and data systems at DHCS that track all of these different data elements. And so what I wanted to do is just give you a few brief examples, just to give you a little context. And it's really great following this last speaker, because some of these really highlight her model. And so, as I mentioned, we receive a lot of these federal and state grants. And so depending on what these grants are for, it really depends on then how the data is collected. And so we have, hopefully most of you are aware of the Behavioral Health Continuum Infrastructure Program. And so with this funding, we are building infrastructure for mental health and substance use disorder, so actual facilities. So this type of data is obviously it's linked to the grant, so it's gonna be collected in a different way than per se service data. And so we created a dashboard. I'm gonna show you some examples of that, but basically for these grant funds, what are some of the highlights? And for us here, it's facility capacity, it's where are these facilities located, regional facility type, things like that. So that's a different type of data than service data. Now, of course, as I mentioned, we do receive other grants from the federal government. And so we have data that is linked more towards services. And that's with our SAMHSA, or what we call our substance abuse block grant and our mental health block grant. And that is actual data that the counties provide us on individuals, and that will have demographic data, that type of data that really shows, what kind of services that individual has been receiving. So very different depending on the grant source. And then of course, we have a lot of Medi-Cal data, which I'm sure you're familiar with. And this is more around patient outcomes, core measures, service data. And so one of the examples I'm going to walk you briefly through is a behavioral health dashboard. And this is with specialty mental health services, has performance measures. This also has, once again, that demographic data, and then also some measures. And once again, some of these are required by, you'll see here, we have listed AB 470. So some of these may be state requirements. Some of these may be federal requirements. And then some of it is just through our stakeholder engagement as we're designing these data systems, information that is really important to collect for those that are providing the services. And so our example here, I just wanted to briefly show you with BCHIP, back to the grants. So once again, we have different data, this, and infographics and charts, so obviously data can be displayed in many different ways. This one is just depicting where we have funded with our current BCHIP rounds 1 through 5. And of course, we have so much more data than this. I do have the link above here if you're interested, if you haven't viewed any of this, but this will give you once again kind of a feel for like grant type of data that we collect. The next example I have here is around the Medi-Cal services. And so this is what I was talking about with the dashboard. Once again, if you haven't seen these yet, there's a link here that you can go and spend more time with. But this is our mental health plan dashboard. And you'll see here we kind of have a mix of some graphics, really seeing what is, for this one here, it's an access measure. And so what is the measure? So having enough detailed description to help the user understand what they're looking at, because we are not all data experts. I know I'm not. So it's really important as you're thinking about whatever data system you're establishing to think of those of us that are not the data gurus. So anyway, but you'll see here we have listed out for us, because this is Medi-Cal data, also all of the counties information below. So you'll see here, of course, the counties listed, the fiscal years, what type of service, the measure. So we have a lot of this type of data available. And this is really to assist us at the department. So as we are setting policies, or as was mentioned, we've been doing a tremendous amount of work under CalAIM, and we'll continue to do so around streamlining, really looking to see how the program is also, we do a lot of monitoring. How are they doing here in Alameda County with this, measure around time and distance? Because we have a lot of other requirements around network adequacy. So this is just kind of a little window into the type of data that we can use then at the state level for our monitoring and oversight and policy setting, but also that the local level can use for other counties to see how are other counties meeting these measures and learning from each other. So a lot has been discussed already about, we have so much system transformation going on in the behavioral health space in California, which is really, really exciting. And so one of those areas that I think you guys are talking about later on today is around reform. And so I just wanted to pop up really quick here. There is in SB 326 a law around outcomes, accountability, and transparency around behavioral health data. And so just wanted to just highlight some of this. There is a tremendous amount listed in that bill in particular around data and behavioral health data, not just our MHSA that you folks help oversee, but also around all those other data sources and other ones I didn't even mention. But really having some accountability for how are the state and the counties, how are they spending the behavioral health funding? And then what are metrics that are going to be aligned across all of these funding sources that need to be developed, quality metrics. Really looking as those metrics are being developed, looking at behavioral health disparities and making sure that we can see how these metrics and this data, so we can reduce those disparities. So lots and lots of information in that bill. So a lot of, depending on where that bill goes and if it gets passed by the voters in March, be a lot more change coming out, but very positive in the sense that more accountability, more transparency, because as a lot of the previous speakers spoke about, that's really fundamental in really understanding for the ultimate goal is the individuals that we're serving in behavioral health. Are they getting better? Where are the gaps? And how can we assist in their long-term recovery? And with that, I'll turn it back to Melissa.
Great, thank you, Marlise. And thank you for coming in representing DHCS today on this topic. We have one more presenter, but they will not be here until 11. So I think I'll turn it over to you, Madam Chair, to start the discussion and questions from commissioners.
Thank you, Melissa. And thank you to our presenters thus far. Emily, I think it's Daniel, Dr. Olin, Ms. Perez. Are there any questions or comments at this time from fellow commissioners?
I have a question. I really appreciate the presentations. Thank you, Melissa, for coordinating and leading this effort. And thank you, Dr. Olin and Ms. Perez for your presentations. I'm curious if Dr. Olin's presentation around aligning across the systems to drive improvement in population goals, your step 2 slide, I know you focused on the managed care section, obviously the state managed care, and then the providers. What's the collaboration with the counties, and how can we get this collaboration increased, or is there any? Can you talk a little bit about that, or if DHCS, Ms. Perez, if you can also, like the collaboration would be great. I think the information that we're hearing is needed and feels like it needs to be inclusive of the counties too, and the wisdom shared and the learnings, because I think we're sounds kind of siloed still to me, so maybe I'm wrong, but would love to hear more about how that collaboration includes counties. Thank you.
We can't
I
hear
can start.
Dr. Olin.
Oh, sorry. It's always that awkward. Who's going to go first? Yeah, it's a great point, and I'd like to expand it a little bit beyond. I'll start with county collaboration, but just even with Dr. Serene, and I really loved your framework because there's such varied levels of data, because it's not even just the counties, but it's not all counties are county operated providers of behavioral health services. So really thinking about providers as well, and really looking in at every level needs a different type of data, but they're all interconnected. And so I think it's extremely important to have collaboration, not only with the counties, but with the providers, because without that, you're going to have a missing link. I also think it's really, really important to consider how do you streamline that, because our providers in counties are extremely busy with actually the provision of services. And so how do you make that data and or that performance measure meaningful to them? And we have some incredible counties that have like really incredible data systems already developed with their own performance measures, with their providers that are pretty incredible. But how do we then draw that up to what we're doing at the state level? And then how do we also mirror that and mesh it with what maybe some of our federal partners are requesting us to do? So I think it's a bit of a dance between all of that. But if you don't have all of those collaborative partners at the table, then I don't think you're going to have successful measures or successful data systems. So I think collaboration is key. So thank you for bringing that up.
And if I could add to what was just said, I think what struck us, because we interviewed 5 states across the nation, and what struck us about California, the county system, is that the counties in California have multiple roles. They manage care and they may also be the providers. And I think clarifying what those roles are and what you're responsible for may be helpful in thinking about what metrics may be most relevant to you, given what hat you're wearing, and making sure that they are in alignment and not conflicting. And so I think, at the provider level, what we found is that folks were just so overwhelmed with the reporting requirements. They essentially said there's no air in the room to even think about why they were measuring what they were measuring, right? And so I think having that deliberate connection, I think, as Marlise mentioned, is so critical. And I think California is particularly tricky because of that dual hat that the county behavioral health agencies wear. And we're talking to folks who are like, well, are we a bank or are we a provider? and sometimes your belt, right? And so what does that mean in terms of the performance metrics that might be relevant to you in those instances?
Thank you. Any other questions or comments? Please, Commissioner Mitchell.
I don't know if this is a question or a comment, and I think I'd really like to hear from, I think it's Mr. Webster, but totally, I absolutely appreciated this presentation. Being I'd say not only a provider, working for a provider, but also a client. Outcomes for me are really, really important. And so when I look at, data, and again, this is not necessarily a question, I just want feedback on it, because the data and the outcomes are so important, but it is so important also to coordinate what we are reporting on. And so that's why I really appreciated Mr. Webster's comments, because we need standardization of quality measures and so that we can get better health outcomes. So how do we do that with the county, with the state, with the federal government? And so I can appreciate FFPSA because it's a great attempt toward that kind of standardization or requirement of standardization. So can Dr. or Mr. Webster kind of give us some feedback or suggestion on how do we get this standardization of reporting and what to report to get the outcomes that we need, or to address those outcomes that we know are going to be poor. They ultimately affect the healthcare system, the education system, the systems with or interactions with law enforcement. How do we coordinate that measurement where everyone within this system of care can actually coordinate those outcomes? I really want to know, is there some global perspective? Is there some suggestions as to how we do that? I believe FFPSA was a great start at that, and I'm sure that there are other things out there, other bills that are coming through. But can you speak to that? Because what is predictable is preventable.
Yeah, that's a terrific question, and do my best to answer it from our perspective, certainly in child welfare. And then you mentioned FFPSA. It's great. I said it's not a panacea. It's not a silver bullet to have policy, but I do think that is a good anchor point for mobilizing people's responsibility and their efforts by basically puts people on the hook for a shared enterprise, right? If you just leave it to let everybody kind of measure what they want, then I totally agree with Serene, one of Serene's points about you end up with measure fatigue. You've got everybody measuring a million different things going in all these different directions, and invariably they're going to measure the thing and report it in a way that casts them in the best light. And so by harkening back to my slide about shared goals and shared responsibilities or shared consensus on system goals, I think that anchors everybody towards going in a similar direction. And policy helps us to do that. FFPSA, as you mentioned, is a good one, though it's always double-edged. It has some requirements. You have to have evidence-based practices, for example, which puts a lot of limitations on the kinds of things interventions that we can implement. So I would point to, as an example, another thing on my slide, which was Assembly Bill 636, which was the second bullet in my slide, where I mentioned the Federal Child and Family Services Review, which is like FFPSA, it's a federal initiative that says all states have to be measured on certain metrics. And the feds mandated those, and there are 7 like system indicators that they look at using data like Emily and Serene and Marlise and I spoke about. But there are other measures as well that they look at. But that system requires all states. There's a process to look at these measures. Here are the ones they specify, and they specify the methodologies for what to look at. And from that flowed the Assembly Bill 636 in California, which, since we're a state-run but county administered system in child welfare, we have 58 different counties, and so we have this state legislation that says, okay, all the counties have to use the same measurement methodology when they're tracking these core system outcomes, and that is a great way to unify everybody, not just the counties and the systems doing the work, but the other stakeholders. And I really needed to interject. We need lived experience. We need the people, our clients, with whom we are working, to be part of the conversation as we're developing these measures and how we're looking at things, what we're missing, that kind of thing. That really need to lift up that part of the conversation as well. So I guess the short answer is I think Assembly Bill 636 in California has been, I think, a great success. It's not, the whole enchilada, but it's certainly, and forgive my horrible metaphors, but it has been helpful, I would say. And I think we have seen progress in the measures that system has implemented. But invariably, you're going to come up with measures, and you'll see traction in those measures, but you've got to be continually building in other measures, like I said, counterbalance measures, because as you improve in certain areas, you're going to have other areas that you're going to need to focus on that may not have been part of your initial system that you put together. And you've got to, in the best continuous quality improvement, be monitoring that and building in the capacity to track these new areas of concern. So hopefully that answers at least part of your question.
Thank you. Commissioner Rolette.
Well, let me acknowledge for the commissioners that this was, from my perspective, a very fascinating and multifaceted conversation. Though I acknowledge that I'm a provider of service, and so often felt referenced when the presenters were talking about service provision, as always, wanting the people that the organization that I'm a part of, that we are privileged to serve, to get optimal care and to be a part of not only the genesis of measures that determine whether or not the care that they're receiving is effective, as the last presenter just said, but help us develop measures that make sense to them. Again, I don't need to know everything that my cardiologist knows, but I need to know if my heart is healthy. And that fundamentally is one of the unique challenges I think that we have as a behavioral health community. So I go back to now just 2 very specific questions, and I think this came from Dr. Olin, and if I'm mispronouncing the name, please forgive me. It's the slide that had few behavioral health measures are consistently used, and you found that 35 standardized measures were used, and I paused and wondered, was those standardized measures used across California or across the states that you queried? So that's one part of the question. And then second, if you looked at specific providers or even managed care organizations that were or counties or government that's providing those services, did that include services that were not evidence-based or community-defined practices? And did you find that the entities that were really advocating and effectively utilizing community-defined practices had measures that were standardized? that was part one of the question, or number one of the questions that I had. The second question is related to infrastructure. And when you, again, my interest is across the states that you queried or across California, where there is a funding mechanism for community-based services, did you find that there were specific set-asides for infrastructure? Because my own, again, subjective experience is that in California, non-government entities or CBOs develop infrastructure themselves to measure whether or not they are effective, because they're going to be asked about effectiveness. But there's no standardization, and there's no even standard funding mechanism associated with infrastructure. We're expected, in my instance, to utilize part of what is described as the indirect administrative dollars to do that. So again, should we prioritize this in addition to that, or should there be a standardized way we go about advising organizations that provide services to set aside dollars for infrastructure? And I assume your answer would be informed by your experience of looking at what other states are doing and what other communities in California are doing. And then my last point is, I only know of one county in California, is 58, and I could be wrong, that set aside dollars for infrastructure for those entities that they contract with. And is that a practice that the OAC should start endorsing or supporting, because we need outcomes to inform the trajectory of service delivery?
All right. Thank you. Thank you for your questions. There were quite a bunch, and I was trying to, I'll try and see if I can capture all of them. And if not, please.
If I could just interrupt, there were quite a bunch because your presentation was amazing. And so it was, it's impossible to digest everything that all of you presented to me.
It's a lot.
Thinking about this, it was a lot. So that's why there's so many questions.
Sure. No, I'll do my best. I'm not sure I can get to all of them because our sample was limited. But I will tell you, I think your first question related to whether or not, I may have gotten this wrong. I've already forgotten the first question. That's not good. You were asking about, across the nation, states, MCOs, and individual communities, were there standardized measures for community-defined practices? Did I get that right?
You did.
Okay. And so what I will say is that the programs that we looked at were at a federal level. So at a federal level, the push for standardization is essentially par for the course, because they are looking at apples to apples comparison. They are really pushing towards being able to set benchmarks that will allow for fair comparisons. And so I think, to your point, when you trickle down from the federal to the state and all the translation that goes down to the community level, what we saw was quite a bit of variation. And I think because, to your point, community providers on the ground do not have the same level of resources that, say, health plans, managed care entities, or states might have to support the level of standardization that's required. I think, as we all know, as providers, when you're on the ground, your primary responsibility is service delivery, and oftentimes measurement comes as an afterthought. And so, the lack of standardization happens a lot at that micro level, as I think you saw in that pyramid that I showed. We did see, though, there was a really nice example from California where the local entity worked together with their partners to come up with a set of standardized measures that they all agreed to report on. So if you have an opportunity to go back, so we did this, the talk that I just gave was also part of a national webinar that NCQA put out a couple of years ago. And in there, we did highlight a community in California that was really proactive, who really reached out to their community partners to come up with, I believe it was 6 measures that they all agreed to get behind on to guide how they deliver care for a very targeted population. So it has been done, but they are again bright spots and not consistent practice across the country. I think your second question related to funding mechanisms and specific set-asides for infrastructure. I think within the California landscape, given some of the innovation funds that may be available to counties, I wonder if there are opportunities to support providers in developing the much needed infrastructure. Unfortunately for behavioral health, I think we did not get on the bandwagon over a decade ago with the HITECH Act. And so we, in many ways, are playing catch up. And I think, California does has, I think I mentioned before, and Marlise also mentioned, there's just historic investments. And how do we use those investments in infrastructure funding mechanisms to begin to build out that infrastructure? I've seen people do it on Excel spreadsheets. They don't have to be fancy. I think we all have to start someplace. And I think, like I mentioned before, one of our clients actually is essentially starting from scratch. They're trying to meet providers where they are, helping them build, paying for reporting, and then eventually build a path to paying for performance. But I think we all have to start someplace, and trying to lay that foundational step is going to be really critical. And I think you had mentioned that there's only one of 58 counties that set aside infrastructure fund. I'm not sure I could comment on that, but perhaps someone else would like to jump in. So I hope I got to most of your questions.
You did, and thank you.
I understand that. Commissioner Gordon, please.
Yes, thank you. I also enjoyed your presentation, Dr. Olin. What I was wondering is that we've focused so much on treatment in our current system rather than prevention. And one of the things, I serve on the First Five Commission, and I've been watching this for years, and serving as a school superintendent. When a lot of young people reach us at age 4, 5, and 6 years old, they have deep-rooted deficiencies which don't stem from the child alone, but in many cases they stem from the fact that the young people haven't had the benefit of the medical system working with them from birth on. And that seems to have been a big indicator of trouble down the line when they get to school and beyond. So just looking at some measures like well baby examinations, the requisite well baby examinations at the prescribed age levels. We're looking at 70% only get those. So 30% of young people don't even get the well baby checkups. Now that speaks not just to deficiencies in the children, which are undetected, it speaks to the fact that no one is bringing them, even though they have access to medical care, no one is bringing them forward for those services. So what I'm wondering is, are there these leading indicators of things that portend problems down the road, which are pretty simple to actually access? Your MCOs can tell you what proportion of young people meet the well baby care checkup standards, and really trying to focus on those early age levels where school-based screening is fine, but it's awfully late for a lot of our young people. So I wondered if you comment on, have you seen anything like that on a major scale, either in California or elsewhere?
So in response to your questions, I believe, I haven't looked at the core set measures in a while. It is actually one of the core set measures across the nation to track well child visits. So to your point, I believe that there is data both nationally as well as the state level in terms of the percentages of children who actually receive well child visits at any point, at any given time point. So the data is there. I think I think to your point is, how do we use that data to inform strategies or apply incentives to encourage, I think, caregivers to bring, to your point, babies don't bring themselves to treatment. It's the caregiver who does. And so how do we incentivize and support that? And I think, you know, I was following California's dyadic services benefits. I mean, that is such huge progress in terms of having those services available. But I think to your point, how do we get A, raise awareness of those services, B, support? Oftentimes, you know, the caregivers who are challenged in accessing those services have a multitude of challenges that they're dealing with. And so how do we support these caregivers so that they can meaningfully access these services that are available? And so, you know, we could probably think of other ways. And so to me, the leading indicators, as you call them, are a way to identify where some of the attention needs to be focused on, and then, you know, diving in deeper to understand the kinds of barriers that we may need to address to help get them to the care that they need.
Thank you.
So I understand that we have our next speaker. There was one more speaker on this panel, so we're going to go ahead and invite that speaker forward. I just wanted to make, I think it's more of a comment and maybe a question. And as we were working on the prevention early intervention report, I remember one of the first things that we tried to identify was going through all the PEI programming across our counties, across the 58 counties. And so we had one of our staff members start to look at all the PEI reporting that was done. And so you would think, you know, we're going to start counting apples, oranges, bananas. And then we started to see, well, there's peaches, and here's a passion fruit, and a guava. We couldn't, because the definitions varied based on what county you were in. Everybody had their own definition of what PEI looks like. So I guess this probably to Ms. Perez, as we start to work forward with BHSA, what that looks like, I appreciate everything that I heard from Emily, Dr. Webster, Dr. Olin. I didn't see anywhere where we talked about definitions. So if we don't define it the same way, measuring seems like so much higher level, next level. And so it's just something I thought about as we were going there. So how do we make sure that we're all on the same page so we can start to talk about intentionality in the data? I think we just need to be really intentional in how we're defining that we're doing, you know, defining the same thing. So I just wanted to say that it was very concerning that what prevention looks like in San Diego County looks vastly different in Yolo County or Marin County. So how can we, you know, you're going to get out what you put in. And so how can our measurements ever be truly accurate if we're not on the same page? And in education, that would never fly. I think of the competencies in SEL, self-awareness, self-management, responsible decision-making, relationship skills, and social awareness. There is no wiggle room. We will count that. We know it. It's exact. We have to be that exact when we're talking about the mental health of Californians, and we have to get this right. So so maybe it's not a question, I'm commenting. So thank you. Please, Melissa, let's invite our next speaker so we can continue to move forward. Thank you.
Great, thank you, Madam Chair. We're going to hear from two presenters from McKinsey. They're going to offer some closing remarks on our data agenda item today, and then we'll move to public comment. I want to introduce Samir Chaudhary, who specializes in healthcare and business technology. He has particular expertise in working with health insurance organizations to achieve operational excellence and optimize cost baselines. He'll be joined by Kana Enomoto, who's the Director of Brain Health for the McKinsey Health Institute, a nationally recognized expert in mental health, substance use, social determinants, and trauma. Kana advises the full gamut of healthcare stakeholders on reducing the burden of mental illnesses and substance use disorders in the US and beyond. Welcome, Samir and Kana. I'm going to turn it over to you.
Thank you, Melissa. Appreciate the opportunity to share our thoughts, experiences within this forum. Gabby, if you can pull up the slides.
Let me make sure. Can we give Gabby co-host privileges? Great, thank you.
Yeah, there you go. Can everyone see the slides here? Okay, fantastic. So before we get started, I just wanted to say that there are few things as personal, as intimate, or essentially human as our mental health. And yet, as our use of data to drive transformations evolves in our societies and in our lives, we find ourselves asking the question, what does this mean for the future of mental health? We think it's important to consider the basic tenets of transformation and transformational change and the vital role that data plays in that. So what I wanted to start by going through was just the elements that are helpful in bringing about sustainable transformational change. And what we found is that these elements can usually be bucketed into four broad categories, as you see on the page. So I'll start with the top left. It's about, as you are embarking on a journey to change or to embed innovation in the way that that people think about their projects, their initiatives, it's important to make sure that they see that in the language that's being used around them. And they see that being role modeled by the leaders that they work with. So it's important that that the leaders within these entities, organizations, actually make that a part of how they communicate, how they interact with their teams, so that the employees, the staff, the overall organization sees that it is an urgent topic, it's an important topic for the broader organization. The second one is just making sure that as you embark upon that change, that there is enough communication and enough understanding about what the common goal is. Where are we trying to move towards? And then what is the individual's role in it? There needs to be forums where, if there's questions, if there's not enough clarity, that folks are able to ask questions about specifically their individual roles. And that understanding will then create the conviction to make sure that change sticks. Third is, as you start thinking about moving in a particular direction, as you're talking about data, for example, it's important to make sure that there is training, there is upskilling, there is capabilities that are provided to the organization, to the employees, to the individuals who are going to be playing a key role in that transformation. And then lastly, it's about surrounding all of this with formal mechanisms to make sure that there is a governance structure that helps everyone stay in touch with what the progress has been, where the issues are, and what challenges need to be resolved in a collaborative manner. So making sure that there are all these processes, all these systems that become a part of the fabric of how the organization is overall moving towards that change. Now, if you then start thinking about what the implications are for each of these elements that are required for transformational change on the underlying data and infrastructure, we can look through each of the elements, and each element actually has a data thread or theme going through it. So as we look at role modeling by the key players, key stakeholders, it is important if the leaders have to be effective role models for transformations and database decision making. A along with integrating data analytics and technology into how things are done, they also need to make sure that they are actually highlighting the importance of data. If leaders demonstrate an integrated approach, more likely that others in their sphere of influence will start doing the same. If we look at understanding and conviction part of the quadrant, ensuring that there is clear understanding of everyone's roles and overall objective, encapsulating those in a few key metrics, KPIs, will cement not just individual teams' objectives, but also how it ties to overall goals for the community and the organization. As we start thinking about developing capabilities and skill, as I already mentioned, embracing data analytics, latest technology will be essential for the transformation. And therefore, this needs to be embedded into the overall talent strategy as well. So it's not just about training the employees that you have right now or training the broader teams. It's also about making that a part of your talent strategy going forward. And then lastly, the reinforcing with formal mechanism, this takes the shape of introducing dashboards, introducing reporting, having the right data and technology infrastructure to be able to allow the effort to keep track of progress as we go along. As we introduce OKRs or key metrics or KPIs, that everyone is informed about what is on track and what is sort of falling behind, so that corrective measures can be taken. If we switch to this next page, what we also wanted to do was just share a few examples of how data has been used to drive change across the globe. So one example that I can share is in Singapore, the Ministry of Health incentivized the population to register the steps that they walked each day, along with a few other lifestyle metrics to encourage people to be more active. That team now that's working on this initiative is now combining this lifestyle data with medical data for citizens to identify thresholds for level of activity that can have meaningful impact on health outcomes, on reducing health risk, on perhaps bending the health cost curve. And for this initiative, data is the backbone on which all of this is getting built. And they are now starting to venture into analysis of how do we figure out what the reduction in incidence of chronic disease could be as it relates to the amount of activity that an individual goes through during a day or during a month. So they are trying to start to figure that out, right? So this is the kinds of things that data can enable. I will pass it on to my colleague Kana to take us through a couple of other examples of use of data in public sector.
Great, thank you, Samir. And it's wonderful to be with this august group. And I am just so appreciative of your focus on data-driven transformation. As I know the Commission has been tracking closely, there are a number of national priorities, including the transition to 988, where data has played a really critical role in ensuring that our country was prepared to manage the changes that came upon us in a relatively short amount of time. So the second example here is Vibrant and 988 and the work that they and SAMHSA did to ensure that our country was prepared for this watershed event. First, there was considerable efforts looking at modeling and projecting the estimated impact of launching 988, trying to base off of current data or past data now, what we might anticipate in terms of increases in call volumes, chat, text volumes. At the time, there were several different scenarios and landed on, where there were in FY21, 3.6 million contacts. I think the estimate was that there might be a 30 to 50% increase in volume as of July 2022. And so Vibrant wanted to understand from the network, how can we ensure that we have the capacity that's necessary so that we don't miss calls, that nobody who is in need doesn't get their call answered, and that we experience the tragedy of making a resource available that doesn't have the capacity to serve people at their most vulnerable moments. And when Vibrant surveyed the contact centers nationally, they found that only only 1 out of 8 contact centers said that they would be able to handle the 30% increase in volume, which was at the low end of what was anticipated, with their current staffing. And more than 2/3 of contact centers said that they could handle the 30% increase if they could increase their staffing. So, armed with these data, as well as other data points about capacity and specific capabilities, SAMHSA was able to galvanize over $1 billion investment from Congress, from the administration, and to disseminate that to states and contact centers to prepare for the transition. And they continue to this day. Vibrant makes the contact center data available, or the state data available, in terms of meeting the goal that SAMHSA set for having 90% of contacts answered in state. And so we are seeing very transparently the progress toward that. And so by July 2022, there was, in fact, a 46% increase in volume year on year between 2022 and 2023. So not only was the Lifeline able to successfully manage that substantial increase in volume, but they were able to reduce the average speed to answer across all modalities by 74%. So what was taking 2.5+ minutes to get a call answered went all the way down to taking 40 seconds to get a call answered, which is just tremendous evidence of the impact of data and how that can drive transformation in such a meaningful and immediate way, which is we're also glad to see. Another example is in the state of Rhode Island, where we know that California is also incredibly committed to the issues of health equity. Rhode Island was able to approach this issue from a very tech-enabled, community-centered way that was looking at data at the zip code level and converting it into insights that allowed community leaders to target specific local concerns, and also for policy leaders to make the case for increased investment. So maybe next page. If we dive a little bit deeper in their approach, you can see, so Rhode Island Department of Health convened partners from diverse sectors, including businesses, governments, academia, community members, obviously health equity zones. And they spent a couple of years actually with the Community Health Assessment Group and the Department of Health to develop a consensus set of statewide health equity measures, and then implemented that in implemented that in this tech-enabled, community-driven way, so that there was that buy-in at the local level, and the state encouraged members of the public to use these measures to assess the progress toward health equity in Rhode Island. And so you can see that they were able to raise $10.4 million to invest in their health equity zone initiative. They saw a more than 150% increase in community engagement, and also meaningful decreases in health outcomes for communities that were traditionally underserved or marginalized. So you see lead poisoning was reduced in one community by 44%, which has long-term social, health, and financial implications. So they learned that tracking these metrics at this granular geographic level allowed for targeting of specific local concerns, having clear consensus health equity measures. I think it was discussed earlier, if we all have a different definition of PEI, then how do we know if we're making progress? You have to have an apples to apples comparison, and then providing evidence of specific disparities, and then quantifying that magnitude was able to galvanize policy and funder action, so that they could demonstrate an ROI and give people the why for this investment of their time, energy, and funding. So, I know that California and the commission itself has a commitment to these 7 levers of transformational change, which does incorporate putting data systems in place to create transparency and accountability, and to have clear outcomes that are driving collective action. You know, you've done a lot of thinking about this topic, and we hope that examples like Rhode Island, like Vibrant, like Singapore are able to give you some just thought starters or food for thought in terms of what more the state can do. And in the meantime, we are very inspired by your commitment to improving the state's mental health through data-based transformation. Thank you. Thanks, Melissa.
Thank you so much. And that concludes our panel presentation. And I just want to extend so much appreciation and gratitude to all of our panelists for their wonderful presentations. So thank you so much. And with that, I'll turn it back over to Chair Madrigal-Weiss.
Thank you, Melissa. Thank you, Kenna. Are there any other questions or comments from commissioners at this time?
One quick question.
Please, Commissioner
Again,
Mitchell.
that presentation was just beyond excellent, very informative, because data does inform policy. So it's so important. So thank staff for putting all of that effort into bringing that to us. So where next? Next steps? That's my question.
Melissa, next steps.
I'm so glad you asked. I think that one of the areas that we as staff would like to focus on with the guidance and direction of the commission is to really engage in our own community outreach and engagement to identify what metrics and quality measures different community partners would like to see us focus on as a system. So I think for us, that's one of our next steps, and trying to kind of bring some of these frameworks and ideas and mindsets out to the community to really get our feedback from our community partners.
Thank you, Melissa. Any other questions or comments? Okay, we see none at this time. Melissa, we are very thankful for this excellent panel you put together. I think we've been talking about this for a long time, so you've given us a lot of information and material to continue to review. Again, I want to thank Emily, Dr. Webster, Dr. Olin, Ms. Perez, and Kana. I hope I'm saying that, Kana. Oh, we have one more comment, two more. So please, Commissioners Rolette and Commissioner Gordon.
I would hope that the commission would consider making a bold statement about data and not only the implications to inform policy, but service delivery. And then identifying what is the ideal way to incorporate all the uniqueness that is California, meaning being mindful of evidence-based or typically federally funded practices and practices that are measured or standardized by the federal government, but also what is unique to California in some ways, community-defined practices that are often inculcated in a number of different organizations, managed care entities, and appreciated by the people that receive the service. And then lastly, making sure that this bold statement about what data should look like and how to operationalize a plan that really does result in the commission endorsing something that robustly says, this is how we're going to collect data, California, or this is how we think you should collect data, California, includes the perspective of every person that is a recipient of service that wants to be involved in the developments of such a plan or policy statement.
Thank you, Commissioner Rolette. I think we should absolutely do that, and we'll work with Melissa and also with our commissioners working on the data and research team to start to develop that. So thank you. Commissioner Gordon.
Yes, I couldn't agree more with Commissioner Rolette, but on top of that, I would really urge us to, both in our conversations with stakeholders, but also in the plans we come up with, to really try to focus on, number one, prevention, but number two, prevention from the perspective of working with families, not just individuals in the families, either the adults or the young people, because I think we can, especially with the expansion of pre-K and universal pre-K, we have an enormous opportunity to dive into that space with data which can be relatively uncomplicated, and work with our managed care partners, our managed care plans, and capitalize on CalAIM and the great relationships we're developing with behavioral health at the state level, DHCS in general, the governor's initiatives, because I think we have a window right now where we can really push this, and it doesn't have to be a total revamp of the data system, but picking and choosing, because we're in my county, we're trying to work now with family navigators who are available to the families from 0 through school age and so on. So I think it's just a wonderful opportunity, and I think there's much to be gained.
Yes, now's the time. Thank you, Commissioner Gordon. We will absolutely get on that. And so we have written that down, and staff is going to make sure we take care of it. So thank you both. Other comments, questions?
My one last comment, Dr. Gordon just said, he articulates so well. He said really what I was thinking in terms of the piece to get the families involved, because, the data shows, or I would love to see a study on, how many families are really involved and what that trajectory looks like when we don't include families in the behavioral health system, and particularly, when our kids come through child welfare, because there's this big gap and there's this disconnect, because often families are considered the problem when these kids come into care, but we know that children do better when they are at least involved with natural supports. And so I don't know how we incorporate that into this whole data discussion, but the family is central to the health outcomes. Even the worst family, that kid is going to go back to that family as soon as he is out of care, he or she.
Right.
So we must connect that piece to this data conversation.
Yes. Thank you. And we have Melissa, who is documenting all this, and we'll loop it back in. So thank you for that, Commissioners Rolette, Gordon, and Mitchell. With that, we want to again thank the panel. Melissa, you hear us?
I do, loud and clear.
All right, we appreciate that. We are now now is time for members of the public may request to make public comment on agenda item 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Are there any public comments? Please raise your hand now as the queue will be closing. Mariani, please open the line for public comment on agenda item 5. And we will start with any comments in the room if there are any.
We don't have any comments in the room, but we have 2 comments online. The first one we have is from Mark. Your line is open.
Hi, this is Mark Kremetz. I don't hear.
Go ahead, Mark.
1 second. Mark, are you able to speak?
Yeah, I can pipe in now. Will peer support be available and be part of this data process, and also be available once the changes in the MHSA and the more the to become the Behavioral Health Services Authority or whatever, be there? Would it be when they get the supports into the housing, and when they get the housing, 30% to go to the housing, will certified peer specialists be available, be a part of this at all? And if not, why not? And I don't know how to get the answer on that one.
Mark, we will have more conversations about that later on in the afternoon. So if you want to ask that question then, not ask that question, if you might make comment then, and you can always email the staff for specific questions. So we'll go ahead and move on to the next public comment, please.
All right, thank you. Next, we have, I believe, Steve Leone. Your line is open.
Hi, can you hear me now?
Yes, we can hear you.
Good, thank you. I just wanted to comment that I've been attending some of these hearings, and hold on for a minute because this is about an agenda item later today, but it's relevant to this one because I was 2 days ago, I spent the whole day listening in on the Health Committee, the joint with Housing on the governor's proposal, and a lot of interest, as there has often been, in data and understanding things better. And I think there's some interest in maybe going forward later on, maybe because this could be further additional legislation. But what I wanted to relate was that in their panels yesterday, they were talking about the need for writing data down and doing reporting. And one of their panelists was a supervisor from the county of Santa Cruz. And he pointed out that there was a tension between, in his opinion, if you're doing reporting, you're not doing services. And Councilman Arambola said that at this point, there is, as he put it, a Hobson's choice between one or the other. And it was quite clear that the supervisor from Santa Cruz was saying we can't really afford to do the reporting. Now, every time I've been involved with something, they always say we're going to do a new data system, but we can't collect anything other than what we're already collecting. And I think what you need to do, and I've talked to Toby about this in the past, but we need to have a much better data system. The counties and the state in particular, some of the departments using 40-year-old programming language. There's ways of setting up data warehouses, web tools, et cetera, that allow you to be much more efficient in reporting the data, do it less, like only once instead of many, many times, so that you can collect this productivity gains is what I'm trying to say. In the 20th century factory jobs, people were so well off under those jobs because they weren't just handling shovels, they were handling gigantic machinery. And we need to stop having just shovelfuls of data and processing it repeatedly and have it just go in once and we have it all set up. I can't explain it very well in this short time available to me, but I think we should be looking at that, and so that we can actually collect far more data with far less effort. That would be revolutionary and get us to the goals we're trying to do. Thank you.
Thank you, Steve.
We have our last public comment from Steve McNally. Your line is open.
Very much. I appreciate that. I raised my hand late. I couldn't figure it out. I love this presentation, and for a variety of ways. One, it's what we all need, but we can't seem to get there for some reason. And in California, and people do make a difference. And so a couple of questions I had, and it's similar to, I know we don't get an answer today, but the presentation about the integration of social services and welfare and relative to mental health, how do you replicate that in another county? I mean, if people were willing to do it, is that something that we could just assign a dollar number to it and do it? Judge Leifman in Miami did the study in 08 and 09 about how much it cost of the system by a small number of people, and yet we still struggle to get similar data here. I'm aware of LA being one of the counties that has great data, and for MHSA with Debbie and Gomberg. And, I've always asked, how do we replicate that in our county? And it just goes nowhere. So maybe it's not replicable, maybe it can't be replicated. But I keep thinking everyone's working with the same kind of legacy systems or maybe similarities. What I like about this presentation is the framework for organizational development. When you have matrix management, it's very difficult for people to break out of silos because nobody's over anybody unless they're willing to accept a leadership role and a participation role, depending on what it is. And to Commissioner Gordon's comment, many times we've looked at how are we leveraging first 5 to MHSA or looking at a 0 to 100 age, all the services people do interact with, and who should be the lead case manager, and maybe we pay extra. That's what we would do in the business world in advertising. If I had 15 ad agencies buying the same thing, I'd assign one of them and give them some extra money to manage the whole process. So families, we see it as one system giving us services. And I do think there is an issue of awareness and understanding of even what we do.
Steve, you might have muted yourself. Did we lose him?
1 second.
Oh, I'm sorry. Was I muted the whole time?
No,
Not the whole time.
Not the whole time.
Probably the last 20 seconds.
All right. Thank you for letting me know that. Anyway, I just love it. But I think a mind shift is definitely needed in the state. You all are the most influential of our subgroups, to the planning council, to the local boards. And if we don't establish two-way communication, it's hard to believe we can provide all these services and we don't know if people are even satisfied with them. So a lot of baby steps. It's not that as hard as some people try to make it. At least that's what I think. So thank you very much.
Thank you, Steve. We are a little ahead of schedule, so we're going to go ahead and move forward with agenda item 7. The commission has received $200,000 in the 2023-24 budget to explore avenues for universal mental health screening for children and youth. Staff will provide an overview of a proposed plan to accomplish the goals of this funding. Today, we will hear from Kaylee Patterson, who is a research supervisor for the commission. And we are doing this so we can just have ample time to have discussion for the legislation discussion in the afternoon. So just want to make sure we have enough time for everything. It's fine. So Kaylee, please go ahead.
Thank you, Madam Chair, and good morning, everyone. Thank you for the opportunity to present today. Cody, if you could please advance the first slide of the presentation. Cody, can you please put up the first slide? Thank you. So as Chair Madrigal-Weiss said, I'll be talking about the Commission's plan for an initiative to explore opportunities for universal mental health screening for children and youth in California. Next slide, please. So I'm going to move quickly through this. I think, this is information that we have been sort of, for lack of a better word, sort of bombarded with for the last several years. Just not that it's not important, but it begins to feel a bit daunting just in terms of really the reality of the crisis that we're seeing in youth mental health. We know that the majority of mental health challenges occur before a person enters adulthood, with as many as 75% beginning before the age of 24. We also know that at least 30% of youth in California are currently living with a mental health challenge. This data actually is a couple years old, so it's likely that those numbers are even higher. And yet, as many as 60% of those youth with a identified mental health challenge are reporting that they're not receiving any type of service or support. And I don't have it reflected up on the screen, but I have to point out that we know that within these numbers there are stark disparities impacting some of our most vulnerable, disadvantaged, and marginalized communities. The consequences of failing to support mental health needs of youth are dire, leading to a lifetime risk of increased mental and physical health challenges, reducing life expectancy by as many as 20 years. In California alone, in 2020, an estimated 527 young people died by suicide, and half were younger than 20. So just to really paint the picture of what we're facing here. Cody, next slide, please. So the good news is that we know that if we implement strategies that identify mental health needs early, and if we can support those needs early and effectively, that we can drastically prevent these negative outcomes from occurring and reduce suffering. But in the nation, the average delay of receiving services is 11 years, which to me, and I hope you agree, is just unacceptable. And really, screening, like in other areas of public health, is really seen as a key strategy to help close this gap in services for mental health. In fact, it's even required by in healthcare that any child receiving services under federally subsidized healthcare or Medi-Cal in California is required to be screened. Yet we know that in California, millions of eligible children are actually not receiving that screening. This would not be tolerated for things like vision and hearing and other developmental milestones for youth. And many experts are in both health and education and mental health agree that there should be no exception when it comes to mental health screening. Cody, next slide, please. So as we all are also very aware, particularly through the work that the Commission has led and around mental health in schools, school is just a critical strategic setting for mental health support, promotion, prevention, and really screening is seen as a key component of this comprehensive school-based mental health approach. Universal screening in particular, where rather than screening only youth that are showing signs of distress, universal screening includes screening all children. And so the idea is that if you're casting a wider net, you'll identify more needs, prevent more negative consequences. Also, there's just a tremendous need for data, as we spent the last 2 hours discussing just the critical importance. Screening allows the sort of establishment of a baseline of data that allows effective monitoring over time. So really for, driving this data-driven approach to high quality mental health services, screening just is really part of that robust data-driven approach. It's also incredibly cost effective, and it can prevent the need for intensive interventions that are very expensive and often less effective than early intervention. So despite these benefits, screening, particularly universal screening in schools, is highly underutilized. An estimated 15% of US schools currently implement some type of routine mental health screening. The data is really inconsistent because there's actually a lack of consensus around what mental health screening even means. The data is just very limited. But there are a lot of concerns and kind of, it's not really, the question isn't whether or not screening is effective or needed. It's really has more to do with capacity concerns with our already overburdened education system. There's a need for training and infrastructure to support screening in schools. There's also still just a lot of stigma around mental health. As we know, there are concerns around issues like parental consent, and even down to what tools should be used for screening, and how they can apply to diverse communities. Next slide, please. So under the current administration, California has made just monumental investments in doing a better job in supporting youth mental health with initiatives like California's Youth Behavioral Health Initiative, MHSSA, ACEs Aware, and others that really to build out this full continuum of care that emphasizes prevention, early intervention, to reduce these unwanted outcomes that we've been discussing. And California also recognizes the role of mental health screening, particularly in schools, to support this continuum of care. So in response to this recognition, the legislature has asked the commission to do one of the things that it does best, which is to draw upon its levers of research and community engagement to really bring to the surface what these opportunities are for screening, what the barriers are, and again, with a particular focus on screening in schools. So the legislature is specifically, it wants to understand just what does the research say, what are best practices. It wants to know what is happening in California because, as I said, the data is really inconsistent, it's really difficult to find. But there are some really good things happening in model programs, and so looking across at what those models are, including some of perhaps what is happening with our MHSA grantees, for example, but there have been just a number of other pilots. So that will be a big part of this initiative as well. And within this analysis, really describing the costs, these tensions that I mentioned, and barriers to implementing universal screening, and identifying what it takes to make progress. So from this work, the legislature has asked for recommendations to inform future budget and policy considerations around advancing this critical strategy of mental health screening for youth. Next slide, please. So as you'll see in the next presentation, the commission's budget reflects $200,000 to support the legislature's request, and staff have drafted a plan that identifies key activities for the use of these funds and to support the legislature's goals to understand opportunities for universal mental health screening for children and youth. This process will include a robust research and review process to really set a foundational knowledge of models, tools, best practices as recognized in academia, clinical practice, policy, and government. We will do a really comprehensive outreach and engagement process to engage with a diverse array of experts, community members, educators, providers, and other key partners to understand these opportunities. And finally, the initiative will end with the development of a final report, which will be presented to the commission that will include the recommendations for the legislature. And the ask is that this is all completed by March of 2024 in terms of a timeline. So now I'm gonna, next slide, please. I'll open it up for questions, comments. Thank you.
Could you say more about how you propose to do the outreach?
Like what types of activities?
Well,
Yeah.
yeah. So let me frame the question a little bit differently. In addition to all of the things you mentioned that could be barriers to having students be forthcoming, there's also the issue of if school people see you come to screen, they will expect follow-up based on what you found. And if we're not in a position to provide follow-up, the screening will not only be not effective, it will be discredited. And we've seen that in our community. So in terms of the outreach, well, I would offer up some of the things we're doing here in Sacramento, because we decided that we should try to place a mental health clinician in each of our schools, funded by the Medi-Cal system and sustainably funded, so the school districts didn't have to worry about their paying for it. And the mental health clinician works in the schools, and we've got about almost 40 schools now with a mental health clinician on site. And what we're finding is that young people are coming to that person to report concerns about their mental health, but they're also coming to report that stigma is very much in play, particularly in a lot of our neediest schools. So I just want to offer up in the course of your field work, please feel free to come to us, because I think it would help you a lot, not just to talk to the clinicians, but the clinician is there placed in the school in order to bring the health system closer to the education system, so that follow-up is not at issue. If a student comes forward, the follow-up is built into the system.
I think you bring up just a really important point, and thank you so much for your question. In some ways, I think you answered it yourself, and thank you for offering that up. Certainly, we would love to engage and see what's happening here. So, you know, I think when we're thinking of engagement, there's some sort of key stakeholders that really need to be considered. So you mentioned this sort of tension around it's not just screening, but it's building out that continuum of care that ensures that screening results in services and support, and that we have the infrastructure and provider staffing to meet that need. Because once we start looking, and that's a fear that the more the wider net we cast, we're going to identify more needs, but if we can't support them, then what's the point? Now, you know, just as a side note, that wouldn't be an acceptable excuse in other areas of healthcare, right? So it is both. But understanding what would it take in terms of, you know, incentives, capacity, billing mechanisms, all of these things. So really understanding that from providers' perspective, from the school's perspective, from and then also, you know, parents and students themselves, and what barriers are they're facing, and that's going to look very different depending on the community we're talking about. I know in particular, screening is underutilized more in some certain communities that kind of are still grappling with, the school's role in mental health in general. I don't think that that's a consistent understanding from a community standpoint necessarily, that they're not invested. So it's kind of understanding that, but really leaning into it and saying, well, what would it take to convince you or to be invested? So yeah, really kind of hitting all those key players. But I would love to talk more with you too about some opportunities to support that engagement. So thank you.
Yeah, and I guess the other snare in this is also that part of our approach in putting in the clinician is to build more of a one system approach to building relationships with young people and making sure you're cued into their needs and their issues, whether they're educational issues. So there's a whole body of work on social emotional learning in schools, which ties right into this, but again, has to be linked to the health system so that everybody's profiting from the relationships that are built largely in the schools, because the referral system is in itself a big barrier, because if you take a 13-year-old child and say, we're going to send you downtown for some service, probably not, because the relationships haven't been built. So anyway,
Yeah, really good point.
anyway, I think this is a marvelous opportunity for us as the commission to help work with the state on how to pull this off. So thank you.
Thank you. Yeah, I agree.
And we'll talk after.
Yes, certainly.
Commissioner Robinson, please.
Just a quick thought about how you plan to outreach to kids, the growing number of kids who are homeschooled. Are they going to be, how will you include those in this? Because it's a growing number, and we certainly want to make sure that we're tapping into that population.
That is a very good point. And to be frank, I hadn't really thought much about the homeschool population. But that is something that definitely needs to be considered. And thank you so much for bringing that up. And would love to talk to you more about that too. Thank you.
Please, Commissioner Ouellette.
Last month, and this was more of an assertion versus a question. Last month, we had Sergio, Dr. Galaxiola, who did a marvelous presentation around engagement and engagement strategies that specifically result in the kind of outcome that Dave talked about. And thank you so much, Commissioner Robinson, for talking about kids who are homeschooled or utilizing an educational method that is different than the traditional public school system. And all those strategies that he talked about would be effective in engaging in families, children, and even ensuring that the school systems or the educators don't feel alienated in the process. I'd strongly endorse ensuring that you use some of those methods in order to meet your March 2024 deadline. He highly effective. And then what is additionally important to all of us, I'm sure, is that those methods take into consideration the social determinants that often, as Dave alluded to, prohibit participation or result in people saying, there's too much stigma associated with behavioral health, not going to go there, and I certainly am not going to go downtown to get services because that clearly identifies me as being a participant in behavioral health. And by the way, that takes gas money and time, and I'm not going to do it. And so that is Dave's point. What he is implementing, it helps people overcome those determinants, those barriers. And then again, for the homeschool population, it is just a whole different set of variables that you want to take in consideration as you begin to effectively engage them. And so the importance of making sure that as you draft this, you include people who are going through or have gone through a homeschool experience and their educators as part of taking a look at what you've developed.
I couldn't have said it better myself, and thank you so much. And I think, yes, and this is why the commission has been asked to do this work, because we do lead the state, much of the state in our community engagement. Not that we don't have room to grow and improve, but it's certainly something we're invested in. And I think you'd be happy to know that the plan is to engage with, I'm always going to say his name wrong, so I get nervous, but Dr. Gaxiola.
Yes.
And many others who are already experts in this area. So we're certainly not reinventing.
And he would endorse that he is an expert with a particular perspective. However, families, educators, school systems, and children are even the better expert.
Yes.
And what we also know, and Dave will speak to this, the data indicates that children are responsive to often peers who are in position with, again, to be able to provide them with support and endorsement around, hey, these are individuals in our community that can be trusted ambassadors. And again, Dave's point is well made. Students identify for other students, you can trust that ambassador. That's somebody you can talk to before the adults in their lives do that. And then lastly, I think that I just endorse the eclectic array of ideas that always come out of the commission that help inform the work that you get to do. So thank you.
Oh, thank you.
Great. So, Kaylee, we've been talking about this for a while now, and I appreciate you lifting up this work and look forward to the recommendations, and I agree with everything that's been said. We've also been looking at universal screenings, and a couple things have come up, especially as it relates to schools. You had, one of the bullet points was the tension, and Dave's absolutely right. You cannot ask that which you're not going to address, and that is the biggest tension when and this especially became an issue as we were coming back from the pandemic, because everybody was worried. We need to be asking what is going on, what are the mental health issues, and then right after that, it was like, and then what are we going to do about it? Do we have the capacity to do anything about it? So having said that, we also know that there are students who, even if we have a mental health professional on campus, they're not going to approach. So what about those suffering in silence? And many are. So through a screening, it's going to be ways that we are going to be able to identify. And many of our students are suffering in silence. So we know universal screenings are a best practice. So how do we do it? So that's what your work is going to lead us to. It's the recommendations and the learning. We also know that mental health literacy, right? So it's an and approach. It's a mental health provider on campus. It's the mental health literacy of our teachers. It's mental health literacy of peers, because your peer is absolutely, so it's going to be the learnings, I think, of everything that we've said here, and then informed recommendations. Because we need to build up the whole system of the school, not just a screening tool. We've also have seen, I know I've seen, where we have some districts saying, oh yeah, we do universal screenings, mental health screenings, and they're not mental health tools. They're social emotional learning screening tools. I'm sorry, that is so very different that if I have to say it one more time, my head's going to explode. But that's exactly what it is. So we even set up our students to fail, our parents to fail, because we're measuring things that are not mental health, and parents are expecting change. And so we really have to get this right, because those recommendations are going to change lives and systems. So I thank you for this. I look forward to working alongside with you, because I appointed myself too, so but please join me, Commissioner Gordon. That's right, we all get to do this. So again, thank you for that. So at this time, we are going to move forward and have lunch. So, I'm sorry, no, but we're going to have public comment. I apologize. We're going to move on to public comment, and then we will have lunch. So at this time, members of the public may request to make a public comment on Agenda Item 7 by clicking the raise hand button on your computer or the app, or if calling in by push star 9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. Please limit your comments to 3 minutes or less. Mariani, please open the line for public comment on agenda item 7.
Okay, we currently have one public comment from Stacy. Your line is open.
Thank you. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I really want to thank Commissioner Rolette, especially for his comments. As usual, I can count on him to say things and bring up things that are very relevant to the people and communities that I serve. I want to say, and I think you may have heard this story before, that I am professionally and personally in favor of mental health screenings in schools. When my son was in grammar school in Sacramento, the school did a mental health screening, I believe on all the students in that grade, which was quite young, something like 3rd grade or maybe 4th grade. I received a call from the school letting me know that one of the answers on his screen might be a red flag and that they wanted me to know. To make a long story short, I had a talk with my son and I quickly secured a mental health therapist for him. The therapist saw him for a couple of years, but also had sessions with our whole family. I believe without therapy, very serious issues could have developed for him and our family. My son is now 31 years old and living a happy life in Southern California. So obviously things turned out well. But I do want to mention that while schools are a logical place for mental health screenings and programs, remember that for all students and families, school campuses are not the refuge or welcoming, safe place that they are for others, for many. But this is especially true for some students and families from BIPOC communities and for some LGBTQ students, especially in rural communities. So while for obvious reasons, I strongly support mental health screenings in schools, please remember that treatment and programs may be better placed at community-based organizations or other places off campuses. And I do hope as this project moves forward that communities of color and LGBTQ communities and representatives will be invited to advise on this project. Thank you.
Thank you, Stacy.
And that was our last public. Oh, I'm so sorry. We have one more from Kit Wall.
Thank you, Mariani. I'm Kit Wall. I'm project director of Words to Deeds, a statewide collaborative changing the paradigm for criminal justice and behavioral health. And we've been together for 20 years. So we've been working in this space for a while, and thanks to a lot of help from the MHS-OAC too. I just wanted to basically have a chance to let you know that the state of Nevada, if you don't know already, and maybe Callie, I don't know that we've met, so I look forward to it, and I'll talk with you one-off. The state of Nevada in 2013 started exploring the opportunity of universal screening for all middle school students as they entered middle school. And similar, again, like, you know, the idea of the universal piece, at the same time, I think students there are required to have a certain number of vaccines and medical exams and so forth before they enter middle school. And so one of my good friends who worked for Medi-Cal then went to work for the state of Nevada. And I followed up with her this week, seeing this on the agenda item. She worked with a woman by the name of Christy McGill, who is now director of the Office of Safe and Respectful Learning Environments for the Office of Education in Nevada. And Lori was able to tell her about this agenda item. And so she offered to speak to, meet with, however she could help with this project so that California maybe didn't need to reinvent the wheel or, you know, go through some of the permutations they did. But Clark County, I think, was an initial pilot program. And I think one of the, just in looking at news stories, one of the research folks that set that up also had worked with LAUSD and also a couple of school districts in Georgia. So I'm really just offering to put that on your radar, and I'm happy to follow up with you individually, however I can make introductions for you.
Thank you, Kit. We will have Kaylee reach out to you for that contact information.
My pleasure. Thank you.
And that was our last public comment.
Thank you, Mariani. So at this time, we are going to break for lunch. We will come back at 1 o'clock. We'll see you all then. Thank you.
Oh, tournament going on? It started, yeah. Wow. I can't believe.
All right, welcome back, everyone. We are moving on to Agenda Item 8. The commission will consider approval of the 2023-24 fiscal year spending plan and associated contracts. We will hear from Norma Pate, Deputy Director of Administrative Services and Performance Management. Norma, please.
Thank you, Chair. Good afternoon, Commissioners. Let's see where my PowerPoint is. Oops, sorry. No, it's going too fast. All right. As you're aware, the Commission is presented with a budget 3 times each year. The goal of these presentations is to support fiscal transparency and ensure the Commission's expenditures are in line with the Commission's priorities. Last year's budget included one-time funds that will be spent over multiple years for our schools and mental health grant program. And as you can see, our budget this year is approximately $50 million less than last year because of the one-time funds. However, our baseline budget and ongoing local assistance funding remains the same. So there was no reduction in our actual baseline. And so on our personnel items, we received 2 additional positions this year to support our data and IT office. This will help us make sure that we're in a safe environment as we receive all the data that we discussed about today. That's very much needed, as we know. And then our operating budget covers costs for our core operations and commission priorities. This year we have allocated funding, like in prior years, for communication, innovation, and research. The innovation funds for this is $500,000, and that was approved in May by the Commission for our Innovation Summit. We were not able to negotiate a contract for our Innovation Summit, so we rolled those funds over to this year and used some of our funds from last year to cover costs from last fiscal year. So we are still in negotiation for our Innovation Summit and hope to have that contract approved soon. Our research and evaluation budget includes contracts with UCSF and other related universities for our research and evaluation efforts. And then, as you heard from Callie today, the Universal Health Screening Study is kind of the highlight of our budget this year, $200,000 for that universal screening. So also asking today for Commission's authority to enter into a contract for the universal screening. Each year, we receive FSP evaluation funds, $400,000 each year to evaluate FSP programs. Last year, we negotiated 2 contracts, one with Third Sector and one with Healthy Brain for our $400,000. This year, Melissa will present a plan to the Commission for the additional $400,000 that we received in this year's budget, along with an outline on how we will spend those funds. For our early psychosis program, the early psychosis program is underway. We have contracts in place. What we haven't done yet is our contract for evaluation of that program. And so we reappropriated funds so that we had a longer term to spend these funds. And so the funds will be going to our advisory committee, our early psychosis advisory committee, in the next few months. And we'll be coming back to you with a recommendation on how best to spend those funds. Our Children and Youth Behavioral Health Initiative, as you know, we talked earlier about this, the round 4 and 5, the Commission will oversee those 2 programs. And we received $15 million in our budget. And in May, the Commission approved $5 million of those funds going to Stanford University for the youth to provide technical assistance. And then the other $5 million would go to UC Davis for technical assistance for the early psychosis program. And $5 million, it was set aside for staff to administer the program. So we would be entering into contracts, consulting contracts, and hiring limited term staff to oversee this program. Under our local assistance, we have our Mental Health Wellness Act. And as you're aware, we set aside up to $40 million to provide grants to programs for SUD, maternal mental health, 0 to 5, and peer respite programs. Tom will be coming back with an outline for those funds in the coming months to get approval for those funds. And then we also receive ongoing Mental Health Student Services Act funds of $7.6 million each year. And we are also working on listening sessions, and we'll be coming to you soon with an outline for those funds. And our community advocacy is, continues with the 6.7 million each year ongoing funds. And Tom and his team have held listening sessions over this entire month. And we've heard from six different populations on how we can best allocate these funds in the next round for their advocacy grants. And so Tom will be presenting an outline for those programs in the next coming months. And then just to kind of highlight our procurements, as we mentioned, the Children and Youth Behavioral Health Initiative is underway for in July for round 4, which is about 50 million. In August, round 5, and that will be up to 100 million. In October, you can expect to see something around the community advocacy contracts. November will be the 3rd round for the Mental Health Wellness Act. And January, our Student Mental Health Services Act. In February, we'll have an outline for our K through 12 advocacy contracts. And in March, the Mental Health Wellness Act round 4. We will have listening sessions and engage our community partners with all of these efforts and come back to you with a proposal that includes those voices and the information that we've heard in those listening sessions. Today, we're asking for expenditure authority for 16.8 million. As you know, the last round of triage grants ended June 30th of this year, and we had some remaining funds from those grants, and I worked with the Department of Finance to reappropriate those funds so that we can continue to use those funds. And so the administration and the governor and the legislature approved spending those funds on empath programs. We received more applications than we had funding, and so we could award 5 additional grants to empath programs, and then also funding to further support the TA so that there's enough technical assistance funds to support all of the grantees for this program. And then also, as we are aware, we had K through 12 advocacy fundings that we awarded to organizations that were youth-led. And we had an organization that applied that we did not fund, and so we'd like to continue to fund that program with the remainder of $20,000 so that they receive funding for their proposal that they submitted to us. And then we also heard presentation from Tuolumne County. And as per the chair asked staff to work with Tuolumne County and develop a plan for them. And so they have been in conversation with our staff and are interested in funding for K through 12 and to elevate the voices of youth in their community. And so today we're also asking for $40,000, which is consistent with the other proposals that we received. And then some of the miscellaneous items that we have, we're asking for up to $300,000 for conferences, seminars, forums, and related travel and stipends and other associated costs, including continuing to support the Words to Deeds Conference and a science summit at the 78th Global National Nation General Assembly this year. And then other related costs associated with our community outreach and engagement. We'll be engaging on which you'll hear about later today, our strategic plan and continuing to engage further on opportunities with our communities. So we've set aside some funds for that as well. And that concludes my presentation, and we have a motion for the commission to consider after public comment and commissioner discussion.
Thank you, Norma. At this time, I would like to invite commissioners to offer comments or ask any questions.
For conferences, do you guys have those conferences identified, or is that just?
Not all of them, just the 2 that I had mentioned. And then throughout the year, we have requests to provide stipends sometimes for youth to attend conferences or events. And so as we continue to elevate youth voices in our communities and in our events and at conferences where they wouldn't be able to attend, we like to provide those stipends to youth and other individuals that are interested in attending conferences that may not be able to attend without the support.
That's it. Actually, I'd said that because I'm kind of selfish. I'd like to see the wraparound conference on there.
Oh, yeah.
'Cause that's the mental health, I mean, it's a pretty big conference for services for the youth that we serve.
Okay, I can connect with you.
I would love to see the WRAP conference. It's in June of 24.
2024?
I don't know if the commission has ever attended it.
Not that
I
I'm
think we
aware.
just need to bring it up to staff, and then, because that is kind of a catch-all amount, then just bringing it up to the attention of staff. You can have that.
It's on Ontario.
Okay, great. Yeah, I can connect with you after and get the details.
Thank you, Commissioner Mitchell. Other questions or comments? Okay, seeing none at this time, I will ask members of the public may request to make a public comment on agenda item 9 by clicking the raised hand button on your computer or the app, or if calling in by phone, push star 9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. We would ask that you please limit your comments to 3 minutes or less. Amariani, please open the line for public comment on agenda item 8, and let's start with people in the room.
I have no comments in the room, and I don't see any comments online either.
Okay, so I would then ask if we would have a motion and a second to approve the motion. And the motion is on screen, so if anybody would like to make the motion.
So moved. I move the commission approves the fiscal year 23-24 expenditure plan and associated contracts.
Thank you, Commissioner Tamplin.
I'll
And
second.
thank you, Commissioner Rolette. We have a motion and a second. There were no questions or comments. I would ask then, Jeff, if you could please call the roll.
Commissioner Bontrager. Commissioner Brown. Commissioner Bunch.
Approve.
Commissioner Carnavale. Commissioner Carrillo. Commissioner Chambers.
Approve.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich. Commissioner Gordon.
Aye.
Commissioner Mitchell.
Approved.
Commissioner Robinson.
Aye.
Commissioner Rolette. Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Aye.
Madam Chair, the motion is approved.
Thank you.
Thank you very much.
Norma. Thank you. All right, moving to agenda item 9, Kendra Zoller, Deputy Director of Legislation, will provide a brief overview of the legislative priorities the commission will be considering today and introduce our 3 guests who will be presenting on those items. Before we begin, I would like to note that Stephanie Welch is joining us virtually and has limited time with us today with a hard stop at 3 p.m. We really appreciate her flexibility to present despite her schedule, so we will do our best to accommodate her. Kendra, please.
Thank you. As the chair just said, I'm Kendra Zoller, Deputy Director of Legislation. The Commission has prioritized an active role in policymaking related to mental health policy and practices, and is routinely asked to provide guidance on legislative proposals that would impact the Commission's operations or result in new duties for the Commission. We have 3 weeks left of this legislative session. However, there's still time to take action and make an impact. So today we will hear about 3 bills. And first we'll start with Caleb Beaver, Legislative Aide for Assemblymember Ward, regarding Assembly Bill 599, a bill related to public health approaches for addressing student drug, alcohol, and tobacco possession and use in schools. Welcome, Caleb. Please go ahead.
Hello, and I'd like to thank the Commission for having me here today to consider Assembly Bill 599. My name is Caleb Beaver, and I'm a legislative aide staffing this bill for Assemblymember Ward, who is very passionate about this policy area and is pleased to see the progress and conversations around this bill. AB 599 would amend the Education Code to remove possession of or being under the use of tobacco products as the sole basis of suspension or expulsion. This policy also requires the Department of Education to give further guidance to administrators and school districts to address substance possession and use. The department would be required to collaborate with stakeholders, including treatment providers, public health resources, local education agencies, youth and community-based organizations, in the development of a model policy on supporting students that would be available by July 1st, 2025. While drug possession and use on school campuses is an infraction that requires school involvement, suspensions and expulsions do little to aid a student in understanding the risks and dangers of drug abuse and addiction. According to the data from the California Department of Education, over 60% of drug-related suspensions and expulsions are of boys, over 80% are of socioeconomically disadvantaged students, and 80% are of youth of color. AB 599 is about supporting our students struggling with substance use and giving administrators more options and tools that are not punitive. At its core, this bill is about supporting our students to address the youth behavioral health crisis. AB 599 is also a co-sponsored effort with the California Alliance of Child and Family Services, the California Youth Empowerment Network, Children Now, and the California Academy of Children and Adolescent Psychiatrists. I respectfully ask for your support today and happy to take any questions you may have.
Commissioners, are there any questions, comments? Please,
Yeah,
Commissioner.
Excuse me, I think we had talked about this bill before and it had been amended. It has been amended.
Right, yes.
So what actually does it do? Because I remember it spoke of taking a public health approach.
Exactly. So
That was not specified what that consisted of. So there was an amendment to clarify.
Right. So initially, the bill was much larger in its scope. However, the requirement that California Department of Education create a model policy with youth involvement as well as with public health approaches, that is maintained and stayed in the bill. We have no ideas of amending that. However, by doing that, they would be reaching out to local and statewide organizations to develop the model policy, in addition to speaking with local education agencies to find best practices and uses.
Thank you.
Other questions or comments? So I'd like to make a comment. I think very much appreciate the language around designing the model policy with youth involvement. Who better to contribute? Also, the more options and the fact that, yes, we want to address the use, using language like substance use and not just the abuse, and really trying to get to address the use of our youth in non-punitive ways, right? So we know youth behavior, we know, trying out things and not be punitive and setting them in a trajectory that just creates additional issues is so harmful. And we need to stop. We need to do better. So, and better with them. I just absolutely supportive of this.
Thank you, Chair.
So at this time, if there are no other questions or comments, I would like to introduce our next guest. Kendra, please. Thank you, Caleb. Oh, I'm sorry, did you want to make a comment? Oh. I'm sorry, so we are going to go ahead and listen to our next guest, and then we'll have public comment. I'm sorry, I did not clarify that. Huh? You want to do public comment? No. Okay. And to vote at the end, sorry.
All All right, next we will hear a presentation by Tara Srikrishnan, Legislative Director for Senator and Commissioner Cortese regarding Senate Bill 10 related to opioid overdose prevention and treatment in schools. Welcome, Tara. Please go ahead.
Thank you, Kendra, and good afternoon, Commissioners. I'm here to speak about SB 10, authored by Senator Cortese, also a fellow commissioner. And SB 10 is also known as Melanie's Law. And the bill is named in honor of Melanie Ramos, a teenager that died of fentanyl poisoning in her school bathroom. And we've been working with the Ramos family to move this bill forward. And this bill is focused on youth and schools. And it's a bill that will expand statewide prevention and education efforts to combat the skyrocketing overdoses and fentanyl-related deaths that have plagued youth statewide. As many of you know, fentanyl was responsible for an astounding 1 in 5 youth deaths ages 15 to 24 in California last year. And in 1 year alone, fentanyl overdoses among youth nearly doubled. And fentanyl in particular is responsible for more deaths among youth than all other drugs combined. It's a drug that can be found in fake and counterfeit pills that are sold through social media or e-commerce platforms, making them available to youth. SB 10 seeks to provide necessary intervention, increase accessibility to resources, and provide valuable education and training to protect our youth from fentanyl poisoning and overdoses. It was in part inspired by the work of the Santa Clara County Fentanyl Working Group in the Senator's home district, and that was an effort led by the Santa Clara County Office of Education, Supervisor Cindy Chavez, the District Attorney's Office, the County Behavioral Health Agency, and others in the working group. And since the working group first began, in just 1 month, it already saved the lives of 2 students in San Jose. So SB 10 hopes to bring this model statewide, and it does a few things. 1, it requires local education agencies to embed opioid overdose in prevention and treatment in their school safety plans. It requires CDE to work with the Health and Human Service Agency to develop and distribute opioid antagonist training and school resource guides to all local education agencies. It requires local education agencies to distribute safety advice to families regarding opioid overdose prevention, including through student orientation materials and posting online information. It also establishes a state working group on fentanyl overdose and abuse prevention focused on education in schools. And it also encourages the establishment of county working groups on fentanyl abuse prevention. SB 10 is aligned with the state budget that includes $75 million increase in the state's naloxone distribution project this year alone. And also, the state budget provides $3.5 million of ongoing Prop 98 general fund dollars for middle schools, high schools, and adult schools to maintain at least 2 doses of naloxone on their campus. The bill has no registered opposition and has received full bipartisan support. And support for this bill includes the County of Santa Clara, the Santa Clara County Office of Education, State Superintendent of Public Instruction Tony Thurman, the California Teachers Association, the California School Nurses Association, the California Association of Student Councils, and many more. Thank you.
Thank you, Tara. At this time, please, Commissioner comments. Commissioner Gordon, please.
Yeah, just a brief comment that this is very important here in Sacramento. We have a Sacramento Opioid Coalition, which has done tremendous work, and we've been pushing this out to all of our school districts, and not just to the schools, but to the teachers and the parents and the adults, distributing Narcan widely. And my own son's brother-in-law died of an opioid overdose, but this is very important work, and we just support it tremendously.
Commissioner Hamplin.
Thank you, Chair Madrigal-Wise. I couldn't agree more, Commissioner Gordon, and thank you, Tara, for your presentation, and also to Senator Cortese for his leadership in bringing this to us and for the bills. I just, again, want to echo the support and the importance of this and the need to have this throughout, of course, all our schools throughout California, and just so, thank you.
So I also too just want to comment, in San Diego County, unintentional accidental overdose deaths are absolutely increasing. And we also have Narcan in our schools. Right now it's optional. I think we have 42 school districts. It's still optional, so getting it to all schools. And it's not just in our high schools, it's in our middle schools, and then we have siblings of older students. So we're even seeing, access to elementary school students. So it is a crisis, and we definitely have to educate our parents, our students, community members, and of course, our educators. So the school resource guides, just getting the information out there is critically important. The Narcan, all of it. So I'm glad that we have support from all the groups you mentioned. And I have a son, he's lost 3 friends already to the overdoses. It's just that prolific everywhere. So thank you to those that are bringing this up. And the more information we can get out there, we have to get ahead of this. It's killing our kids, just, 1 in 5. It's too many. So thank you for this. Thank you for the presentation. So at this time, if there are no other comments or questions regarding this, then I would like to, Kendra, if we can continue to move forward. Thank you. Thank you, Tara.
Okay, we have Stephanie Welch joining us virtually. She's Deputy Secretary of Behavioral Health at the California Health and Human Services Agency. She will give us a presentation and an update on the governor's modernization proposal. So welcome back, Stephanie. Please go ahead when you're ready.
Thank you, and I apologize that I couldn't make it over to your offices. I am trying to participate a bit in our NAMI conference going on here in downtown Sacramento. What I thought I would do today is go walk through some of the amendments that were in print on August 15th. And then today there were another set of amendments that were in print. And I also want to provide a little kind of a sneak peek into the next round of amendments that will be coming out that we've been working on with stakeholders. And Kendra, just so that I am timing myself correctly, how much time would you like me to take to walk through these things?
I think that's up to you.
Okay, I just want to make sure there's plenty of time. I do have another appointment that I have to be at 3, so I'll try to be quick and also make sure that both your commissioners as well as all of the stakeholders are aware of where they can find some of this information that might be helpful to them. So first and foremost, some of the key policy changes that were reflected in the August 15th amendments would first start with recognizing that we need to have some flexibility between the categorical buckets. So, and to recognize that there needs to be some phased implementation in providing more flexibility in the beginning of implementation, and then kind of topping out at a regular level. So what we have proposed as amendments, and right now we're clarifying to make sure it's absolutely clear, but we are proposing that in the first planning cycle under the proposed new kind of guidance, which would be planning cycle fiscal year 2026-27 through 2028-29, that counties would have the opportunity to transfer up to 14% of dollars across buckets. That comes with the caveat that only 7% could come from any one bucket. So for example, a county may choose to move or drop their 30% housing intervention bucket down to 23%. And move those dollars into their behavioral health services and supports bucket. And they could also move money, another 7% from the full service partnership bucket into the behavioral health services and supports bucket. And there's a reason for this. And I know that we've had at this point several conversations about some of the major changes, but one of the most kind of fundamental policy changes is building out the levels of care that we envision full service partnerships to be. That's going to be a lot of work. And in these new amendments, we actually propose to do that in partnership with the OAC, leveraging your expertise and commitment to improving full service partnerships. And so this is really just, frankly, being responsive to some of the counties and other stakeholders' requests to make sure that as we make these significant transitions, and also as other major system changes that we're working on come online, for example, the implementation of BH Connect, the next element of our CalAIM overhaul of our delivery of behavioral health services through our Medi-Cal program, where there will be additional benefits available for Medi-Cal reimbursement, like supportive employment, first episode psychosis, et cetera. So I neglected to mention at the top, I apologize, that for the August 15th amendments, we do have, and when I stop talking, I could probably provide the link in the chat, but we do have a webinar and a set of slides that you can both watch or download the slides that summarizes a lot of the things in writing that I'm going to say verbally. And then in the next planning cycle, that drops down a little bit to a 6% from any one bucket, 12% max, and that planning cycle is fiscal year 29-30 through 31-32. And then we really top out ongoing an ability for counties to move up to 10% across the buckets, with no more than 5% from any one of the three buckets. Sorry, that's a lot of technical information, but I really think it underscores a very important amendment to be responsive to our stakeholders, to make sure that we're creating flexibility for counties to be more responsive to their local planning needs. The next major change that we are proposing, and actually this is, I believe, aligned with one of the recommendations that the OAC is putting forth, which is to shift population-based prevention work to be directed at the state level. This is truly taking a public health approach to prevention, which is really about addressing the drivers of behavioral health challenges and the social determinants of behavioral health issues. We have recommended that the California Department of Public Health and their expertise in doing population prevention be tapped in consultation with the OAC and the Department of Healthcare Services. And how we are proposing to do this is to bring the state directed services bucket to 10% from, I believe it was it at 8%? But let me walk you through it. There would be a max there's a must requirement of 4% for population-based prevention. We continue to have 3% for a workforce initiative, an ongoing workforce initiative. And the way in which we're going to help finance this is to reduce the amount that's available for state administration from 5% to 3%. I think we may talk about this a little bit more. We're also currently working on some additional amendments with some really excellent suggestions from experts in the prevention and early intervention field, including our own at the California Department of Public Health, to really clarify that our intent and what we think are many of the things that people do in the overall prevention and early intervention bucket, including community defined practices, really does fit nicely in the our definition of early intervention. And so we are working through some details right now for the next round of amendments to make sure that we're being responsive to some of the comments that we've heard from a variety of stakeholders, because it is absolutely our intent to ensure that in the prevention and the early intervention bucket, as well as the rest of all of the buckets, that we're doing due diligence to invest in community defined practices. So that being said, wanted to also acknowledge that 51% of that bucket has to be for efforts targeting individuals who are 25 years or younger. Moving on to kind of the three big local assistance buckets, or buckets that are administered at the county level. First would be our behavioral health services and supports bucket. Now that there's no longer a local requirement to provide to dedicate 5% for population-based prevention, we're able to move the behavioral health services and supports bucket from 30% to 35%. And also really wanted to include, and I think it was always our intention, but it certainly was a huge oversight that we weren't clear about it, but be very clear that outreach and engagement efforts are part of the BHSS bucket. And this is really important. We heard so loud and clear from our peer and family-run organizations and our small CBOs that they're doing a lot of outreach and engagement to peers, families, and to BIPOC and LGBTQ+ communities. And so really hope that that is something that is very clear that that's what that is intended for, even though much of the work that those groups do also would most adequately fit in the early intervention bucket as well. It is still the case that in the behavioral health services and supports bucket that 51% needs to be dedicated to early intervention. The additional change in this round of amendments is that of that 51% that has to be used on early intervention, the majority, or 51%, needs to be directed towards youth who are 25 years or younger. Not a ton of changes to the full service partnership bucket, other than to be clear that there are some additional services that we would like to see in that bucket, including adding to the supportive services requirement, psychosocial rehabilitation, as well as supportive employment. And we've also added high fidelity wraparound in that bucket for our children and youth programs. I think where there have been significant changes and maybe not talked about as clearly as they could have been has been in the housing supports and homeless definition. First and foremost, we heard loud and clear, and again, fortunately wasn't our intent, but we really appreciate the guidance on making improvements, that using the federal definition of homelessness would really not work well for what we were trying to accomplish, especially since many of the people that we want to see in high quality housing have had long stays in institutional settings, whether that be carceral or hospital settings. And so DHCS we've given the authority for DHCF to craft a definition of chronically homelessness so that we can make sure that we get the right one with all of input from our stakeholders. We also make clear that small counties have an exemption process to ask for more than 25% to be used on capital from the get-go. So that starts in the first planning cycle of 2026 through 2029. And probably the most notable change, which we haven't talked a lot about, is that flexibility with this bucket based on DHCS guidance commences in the 2032-2035. So that would be the fourth cycle of planning. I think it'd be the fourth, maybe it's the third. I apologize. I'll do the math in a second. And so DHCS will be developing criteria for exemptions for those counties who just simply don't have that high level of need for housing interventions. So I'm going to keep going. I know it's a lot. The next section really focuses on improvements to the 3-year plan and fiscal transparency and data pieces. We wanted to make sure that we were crystal clear that a county needs to submit a budget that identifies all of their funding sources, and then that needs to be attached to their integrated plan. We also add language requiring counties to ensure that those expenditures must align with the 3-year approved plan. And then also just clarified some of our corrective action processes to make sure that counties were having due process. And one of the other major changes is that we remove references to the Bronson-McCorquodale Act and instead align all of the criteria with our CalAIM definitions. This is really important because, as some of you may have been tracking under CalAIMS, we have been creating more flexibility to ensure that people who need early intervention services do not have to have a diagnosis or meet medical necessity in order to access services. And so I think that was a really positive change in the overall implementation. We also made significant changes to what has been in the proposal related to the not only the role of the new BHSOAC, and I've known you guys for a long time, so I just call you OAC for short, but also tried to clarify where there needs to be areas of collaboration and input that the OAC provides for different pieces of the initiative. So first and foremost, making sure that it's clear that you shall receive the data that you need in order to fulfill your obligations. A few minor changes consistent with some of the feedback we certainly heard in the last meeting to make sure that the number of peers and peer representation was aligned with family representation. We also felt that it was important to have an additional seat for a transition age youth behavioral health peer. We also added a seat for a disability or aging perspective. The commission selects their own executive director. We also really want to lift up things that we feel are our incredible strengths that you have that you can bring to this process. So first would be really to provide and be the technical assistance provider to support quality change management. We've talked about that quite a bit and how much of a massive endeavor this is. So that would be training around implementation planning, capacity building, and then also considering your expertise in innovation to provide technical assistance on innovation and to compile a list of innovative approaches across all of the program buckets that are occurring, and to do some evaluation of that work. And part of it is because, as we've mentioned before, our hope with some of these innovative proposals is that we can identify what is the most effective and find ways to scale it on a statewide basis, potentially even, if appropriate, becoming a part of our Medicaid menu of available services, of course, if they are supported by CMS. The OAC will play a critical role consulting with DHCS on 4 major areas. The first would be the biennial list of evidence-based practices. As I mentioned earlier, helping to develop those FSP levels of care, also to develop statewide metrics and statewide behavioral health goals and outcomes measures. Those are some of the really big ones from August 15th. They are fairly significant. I just wanted to real quickly highlight some that came into print today. And we discussed these on Tuesday in a hearing that we had on the bill. And so I just wanted to walk through some amendments that we negotiated with the legislature. Probably the one that is most notable is a pretty significant oversight component of which the OAC participates in as well. And it would require the California State Auditor to no later than December 31st of 2029. So that would be just shy of 5 years of some of these changes, to issue a comprehensive audit on the progress and effectiveness of the Behavioral Health Services Act's implementation. And also require 2 subsequent audits, with the final audit being due to the legislature December 31st, 2035. And I think this is really important because, and we'll be doing this in partnership with all of you, I cannot stress enough how much we want this to work. we do deeply believe that this is really about expanding services in California, maximizing every funding source's muscle from Medi-Cal to the BHSA. And I think this is going to hold us accountable to make sure that what we envisioned and what we're proposing here today is what we're actually able to achieve. And I think that we were very open to this as administration and think that this is a wise thing to do with such a significant change. So I thought that that would be something that would greatly interest this particular body based on some of the comments that you've provided us before, including, potential concern about how we're going to manage such significant change all at once in the course of the next 10 years, so to speak. There's also just some clarity that DHCS will consult with the OAC in the development of priorities for the use of early intervention funds. There are some other changes specifically to make sure that we are tracking spending on children and youth services. Some of them are very boring and technical amendments around drafting errors or typos and things like that. And then added a few additional changes to our housing intervention bucket, making sure that we are including master leasing in our project-based housing and a few other pieces. This will also be up in Housing Committee on Monday. We also included some additional representation that was was overlooked through the local planning process. So making sure that local areas of education are represented, that when we say public safety partners, we're inclusive of county juvenile justice agencies, and that we make sure that our local emergency medical services partners, who often do so much work in the crisis space, are included in planning processes. Wanted to clarify that in the population-based prevention bucket, that work can be done statewide, countywide, or focused on a particular community. So if there is a population-based strategy that we want to focus on, for example, with the Hmong population, we know that Hmong individuals live in different parts of the state. They don't just necessarily live in one community. Or maybe there's a very large statewide suicide prevention campaign for older adults that makes sense to do at the state level. Or maybe there's a high concentration of a certain kind of population at the county level, and then that would make sense. I think there are some other things in there. They're not incredibly interesting, but I can, or they're very detailed. They are interesting. I think there's so many different stakeholders. I don't want to say that one amendment's bigger and more important than the other. I wanted to say, lastly, before I open it up for questions, that we have been meeting with lots of different organizations. Some of the major amendments that we're working on now include, as I mentioned at the top, some clarity around how we describe community defined practices and how that kind of fits into the prevention and early intervention buckets, to make sure that we're not unintentionally dismantling a program that may be really focused on cultural affirming and community-led efforts. And we're also doing a lot of work really making sure that in our early intervention buckets, that when we say children and youth, we might need to be a little bit more specific in certain areas and be inclusive of children who might be younger and not necessarily school-aged yet. And for our transition age youth who may no longer, obviously be in school, but certainly are a part of that targeted bucket. I am sure that there is something that I am forgetting. By far, I'm sure there is, but that's what questions are for. Wanted to just say thank you also to your staff. We are in the process of reviewing and appreciate some of the suggestions that were made in some amendment suggestions from all of you. We continue to process those, and I think several of those we're very much considering. So with that, I think I'll pass it back over to the chair or to you, Kendra, whatever works.
Thank you, Stephanie. I'll go ahead and take it from here. So our guests from the legislature can go on with their day. We're going to go ahead and take public comment on the two bills first. So AB 599 and SB 10. So at this time, members of the public, and then we'll come back, Stephanie. So just at this time, members of the public may request to make a public comment on AB 599 and SB 10, and by clicking the raise hand button on your computer or the app, or if calling in by phone, *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. So, Mariani, are there any public comments?
Yes, we have two public comments in the room. First, we have Danny.
So we will come back to.
He has one.
Me clarifying, Danny. No,
sorry.
Please come forward. So just to, we're just moving things around to accommodate for people's time. So just to be clear, we're making public comment on AB 599 and SB 10, and then we are going to come back and have public comment on what Stephanie just presented. So please go ahead with that. Thank you.
Turn your mic on. Thank you. Hello, my name is Danny Theracul. I'm with the California Youth Empowerment Network, also known as CAYAN, and on behalf of Mental Health America of California, MHAC. We are co-sponsors of AB 599, and we ask for your support today. Through our IM Collaborative, we've been able to work directly with youth of all backgrounds. We've engaged with them. We've asked about solutions regarding substance use and tobacco use, and this is their answer. This is the bill that they have been asking for, and so we hope to get this legislation passed and take the first step to addressing the inequities that are harming so many youth of color and low-income youth as well. Thank you.
Thank you, Danny.
Thank you. Next, we have Adrian.
Good afternoon, Commissioners. Adrienne Shilton with the California Alliance of Child and Family Services. We represent nonprofit community-based organizations across California serving children and youth and families in public systems. And we wanted to note our proud co-sponsorship of AB 599. The California Alliance is coming to this issue of the substance use crisis among our young people from the fact that we have a public health crisis, and that cannot be fixed with punishment and punitive measures. So we believe that we can do something about these troubling trends that were highlighted by Assemblymember Ward's office earlier today, and that is to provide our students with support and resources in early intervention and education. So we ask for your support today. Thank you.
Thank you, Adrienne.
Now we have two virtual comments. First, we have Stacy.
Good afternoon again. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. We are in strong support of both AB 599 and SB 10. We would like to thank the sponsors and the author for carrying this bill. It's very important, and we hope that you vote to support that. Thank you.
Thank you, Stacy.
And then our last public comment, John, your line is open.
Thank you so much. Just wanted to say on behalf of the California Council of Community Behavioral Health Agencies, CBHA, we are incredibly supportive of the goals of both AB 599 and SB 10. Also, thanks to the authors and to the sponsors for their leadership on these issues. Incredibly important, and we're happy to be in support. Thank you.
Thank you.
That was our last public comment.
Thank you. Now that public comment has closed, I would entertain a motion on AB 599 that the Commission supports AB 599 and directs staff to communicate its position to the Governor and the legislature. Thank you, Commissioner Mitchell. Do I have a second?
Second.
Thank you, Commissioner Alvarez. We have a motion and a second to approve the motion. Any additional questions or comments from commissioners? Seeing none, I would ask Jeff if you would please take the roll.
Commissioner Bontrager. Commissioner Brown. Commissioner Bunch.
Approved.
Commissioner Carnevale. Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen, Commissioner Cortese, Commissioner Danovich, Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Robinson,
Aye.
Commissioner Rolette, Commissioner Tamplin,
Aye.
Vice Chair Alvarez,
Aye.
Chair Madrigal-Weiss.
Aye.
Madam Chair, the motion passes.
Thank you, Jeff. Next, I would entertain a motion on SB 10 that the commission supports SB 10 and directs staff to communicate its position to the governor and the legislature. I would like to make the motion. Could I have a second?
Second.
Thank you, Commissioner. There's a tie on seconds. I would say I saw Commissioner Gordon, so I'm sorry. So we have a motion and a second. I see no questions, comments, so I'm going to ask Jeff if you would take roll.
Commissioner Bontrager, Commissioner Brown, Commissioner Bunch,
Commissioner Bunch, we can't hear you, so we're going to continue.
Commissioner Carnevale, Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen, Commissioner Cortese, Commissioner Danovich, Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Robinson,
Aye.
Commissioner Rolette, Commissioner Tamplin,
Aye.
Vice Chair Alvarez,
Aye.
Chair Madrigal-Weiss.
Aye.
Madam Chair, the motion passes.
Thank you, Jeff. All right. Moving on, then, we are, Stephanie, thank you for your patience. So, please, Commissioner Rolette.
I just wanted to, Chair, and thank you for allowing me to interrupt. I unfortunately have a prevention and early intervention responsibility today with my grandson. He's getting out of school and I'm picking him up, but I will be listening to the discussion, but certainly have not had a chance to read the new amendments that were referred to by Stephanie. I want to tell everyone in the audience, in person and online, that this, what is referred to as, again, the modernization of the Mental Health Services Act, is of utmost importance to all of us. I will be listening, but again, wanted to acknowledge that that's the reason I'm leaving and didn't just want to leave given the importance and significance of the discussion today. Thank you, Stephanie, and thank you everyone in the audience and online, and commissioners, again, prevention and early intervention. My grandson, he's not driving yet. I got to go pick him up.
Thank you, Commissioner Rolette. Appreciate that. Yes, of course, please. So I just want to, so Stephanie, you're still there, and we are back to the item. So we are going to invite commissioners to make questions or comments. So at this time, Commissioner Chambers, please.
Thank you. And I want to say thank you to the administration, to the commission, for bringing up this important issue. There were peers that did come to the Capitol to express their concerns, opportunities, needs for amendments. So I'm happy that the administration, from what I'm hearing, has listened, particularly about the community-defined practices and culturally defined practices, and the need to include peer services. But one of the issues particularly that has not been addressed by the administration, and I'm hoping that the commission can take this on relative to the implementation of SB 803 and its relevance to the current legislation. Currently, with this proposal, even though peer services are included, a lot of peer organizations will not be able to participate, particularly the small BIPOC CBOs, because currently we do not bill Medi-Cal. I don't see any amendments or anything relative to providing technical assistance to CBOs, particularly BIPOC, small organizations, to include them in this new system that will heavily rely on Medi-Cal billing. So if it as stands and we don't do anything to CalAIM to bring peer support, Medi-Cal, peer support specialists into the fold, like community health workers, we will not be included in this. Our workforce is at threat of expansion because we are only limited to specialty mental health right now. We've been referred to as community health workers on a number of occasions. We're not. We have a certification, we have a test, we have a certification process. Why aren't we not included in CalAIM? Why are we not given technical or a promise of technical assistance to be a part of the fold and address the mental health crisis and the workforce shortage? That was a lot.
Thank you, Commissioner Chambers. Commissioner Tamplin, please.
Thank you, Chair Madrigal Weiss, and thank you, Commissioner Chambers, for bringing up those important issues. And thank you, Stephanie, for your presentation and, of course, the administration's work and trying to update things. There's a lot of stuff to go through. So I think finding those slides is going to be really important to try to digest all the changes. But I'd love to put like extra emphasis on the and add my agreement to what Commissioner Chambers said about our respect for community health workers and our advocacy and wisdom and sharing throughout the state by peer support specialists throughout our state and peer-run organizations, that we're not under an umbrella of community health workers and needing that separate recognition, our unique roles and the fact that this process, it emphasizes having lived experience and prioritizes that. So that's really important to pull out if there's a way, and we hope there is, with the administration, of emphasizing again that a Medi-Cal peer support specialist certification and specialists are unique and important, as is community health workers, but part of a team. And so, again, a unique role and classification. In addition to that, I think one of the things that maybe the state can benefit from and add, and it's come from many of our peers throughout the state, is about establishing a lived experience advisory board that consults the on behavioral health policy. In addition to, what is already at the state, there seems to be a feeling of, again, we're at the end of the decision-making process where the ideas come up and those that have lived experience with our services and system are informing it afterwards. So if that is, that can be elevated, that would be wonderful. I didn't hear that, Stephanie, so I'm not sure if that's on your plans for next edits. But the other piece also is, again, really wanting the state's support around peer respites and calling that out and calling that as an important piece and where that fits under these resources and how we can get more support to increase these. And for the populations we're talking about, even for youth, these are, these kind of services will give peers that are, transition age youth and trained certified peer support specialists the opportunity to work with other youth in peer respite centers, work with our also homeless population and people experiencing homelessness, getting them employment and training and to become peer support specialists and provide then peer respite to the community and help prevent crises. Those are critical services that are missing in our continuum of care. We don't have enough in our state. We should have one really ideally in every city. Because they're much more accessible than and welcoming and warm than locked psychiatric facilities. So, thank you.
Would it be possible, Chair, just to make a few comments based on their comments? They were they were kind of couched as a question, but I just wanted to acknowledge that we received some communication that there will be some amendments sent to us sometime today, and very interested in seeing and thinking through, especially with our partners at the OAC, who you have done, a lot of incredible work bringing lived experience voice to your forum. But how do we do a better job making sure that that is reaching, I'll speak for agency and all of the various different departments we have, including the Department of Healthcare Services. Like, I think we're very interested in exploring that, and it's very valuable. And then, as the secretary also acknowledged in committee this week, we absolutely agree with you. This issue around supporting our smaller CBOs, whether they be a peer-run organization or a culturally specific organization or a family-run organization, is really critical, and it's not necessarily even just a behavioral health issue. So we're really deeply examining, like, how do we make the most of that Medi-Cal dollar, but also do not medicalize the great work that some of you do in a medical model. So just wanted to say that we've learned so much in this process, and feel, continue to be really committed to trying to work through that big problem that we have. And it is system-wide across Cal-AIM. So we're very, very excited to think through how to fix that.
Thank you.
Mhm.
Other questions or comments? Okay. So at this time, we are going to ask members of the public may request to make a public comment by, clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Are there any public comments? Please raise your hand now, as the queue will be closing. We would ask that you please limit your comments to 3 minutes or less. Amadiani, please open the line for public comment on the agenda item, and let's start with people in the room, please.
We have one comment in the room from Danny.
Hello again, my name is Danny Therical with the California Youth Empowerment Network and Mental Health America of California. We stand in opposition to SB 326. We are facing an affordable housing crisis and access crisis here in California, and thus we believe that the state should find other means of funding those housing interventions without diverting funds from mental health services. Additionally, this bill should also include a set-aside for TAYS in all funding buckets, not just the PEI, but also in the FSPs as well as in the housing bucket. Data has shown that when set-asides for TAY happen, there are significant results in reducing the homelessness population for our TAY population. Additionally, we also believe that this bill should include a minimum spending requirement to ensure community and stakeholder engagement at the local level. Just to quickly add, one of the amendments includes a TAY member on local mental health boards, and for TAY, engagement barriers are extremely high. And so in order to ensure the participation, not just for TAYs, but for all stakeholders, including peers, a minimum spending requirement should be included in this bill. Thank you.
Thank you, Danny. So Stephanie, I want to thank you again, and Secretary Ghali, for listening to our thoughts.
Oh, sorry.
I'm sorry.
Sorry.
There was just one comment.
Yeah, one comment in the room. Sorry. We have 6 virtual comments.
Yes, I apologize.
No worries. First, we have the number ending in 718. Your line is open. I believe that's Steve.
Yes, hello, can you hear me?
Yes, we can.
Good, thank you. I just want to check. This is Steve Leone, long-term advocate. I have a comment that is actually a hoped-for amendment. Since there's another round coming up. And what I'm about to say may be a bit controversial with some people. I hope I'm not touching an electric third rail. But bear with me, I don't think it's as controversial as it may sound at first. Basically, in that huge amount of paperwork that is the bill, there is a section dealing with 5806. 5806 originated as part of the AB 34 language back in 1999, and of use within the current MHSA for defining the nature and the running of full service partnerships. In the revised version of this, in the original version, they included psychoeducation and support for family members. In the new version, they've added to that and said that family members shall be involved, and as like a mandate, basically, they will be involved with treatment and service planning. And I'm not anti-family. I mean, I know that families have been crying out because they can't get help that they need. But this bill, this section, is not dealing with 5150 situations. It's dealing with people who presumably are already voluntarily in a full service partnership. And as such, the mandated intervention of family members is not appropriate. I think, family members, I understand that if they let go, it's like something bad happens. But if they're running the full service partnerships the way they should, I would ask everybody to trust the process. And again, I think since this deals with a voluntary situation in which people have already volunteered to be part of it, it is appropriate. I would say furthermore that it might even be disruptive to some people. I certainly am not opposed to an amendment that said, or an idea that said that if the consumer so wishes it, the family member could have that kind of participation, not be excluded. But that's if the consumer wishes it. So having said that, there's one other quick thing that Dave Pallon, and and he used to be the second in command of the village under Richard Van Horn. And he made the comment that among the things that were the starting points, not just ACT, but the clubhouse model was part of Mark Reagan's, who was the presiding psychiatrist in that 10-year experiment of making the village happen. Now, the clubhouse model was one of the things, and I understand that we're just now making the clubhouse model refundable under Medi-Cal. So maybe you might want to add in that new section about full service partnerships, a clubhouse model, as well as the ACT among the models to follow. Thank you.
Thank you, Steve.
Thank you. Next, we have John. Your line is open.
Hi there, John Drebinger here with the California Council of Community Behavioral Health Agencies, CBHA. Just wanted to say thank you, Stephanie, for the presentation and your ongoing collaboration in refining this proposal. We've previously submitted a letter with our members' concerns and recommendations to the relevant legislative committees. Just wanted to say we are grateful to the amends from August 15th, which address some of our concerns. We'll continue reviewing the latest amends. Just wanted to also drop a note of thanks for the update to FSP implementation specifically. And we're just really looking forward to continuing to work with the administration to refine the proposal and make sure that it's as impactful and mindful of the community's needs. So thank you.
Thank you.
Next, we have Stacy. You may go ahead.
Stacey Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. We had a good meeting less than a week ago with the governor's administrative staff and provided extensive amendments on Monday to them after this meeting. I know why I'm stumbling. I don't have my reading glasses on, sorry. We were very grateful for this meeting and felt that our concerns were heard. We are hoping that our amendments are accepted as they ensure, among other things, that it is clear that CDEPs are eligible for funding in both population prevention component, as well as the early intervention component under the BHSS bucket. I was happy to hear Stephanie mention today that the bill will be amended to make it clear that an individual would not be required to have a diagnosis to receive early intervention services, as this removes confusion. We look forward to seeing the next set of amendments and thank Stephanie and Michelle Boss for their willingness to collaborate with us. Unfortunately, we must still retain our oppose unless amended position. Remco is compelled to say, and I don't mean to direct these comments personally to Stephanie, that the way this broad initiative has been introduced and rushed through the legislative process is a travesty and an insult to the spirit of the MHSA. I actually believe that administrative staff understand these concerns and have done their best within their constraints. I think they've been working probably day and night to address our concerns. While Remco has focused primarily on saving CDEPs, there are so many serious issues with this bill. For example, the issues highlighted by Commissioners Chambers and Aslami regarding problems with CalAIM and Medi-Cal. Remco had to depend on other allies, such as the children's communities, to handle the returning the 51% guarantee for children and youth, and we're grateful when they made progress on this. I truly believe many of these issues could have been worked out in compromise in a better fashion. However, the way in which this entire initiative has been handled has broken trust with the behavioral health community at large, and it will take a long time to mend this relationship. But thank you.
Thank you, Stacy. Mariana.
So sorry. Thank you. Next we have Steve. Your line is open. You can go ahead.
Hi, I'm Steve McNally from Orange County. I'm at serve on a behavioral health advisory board. My comments will be my own. And thank you, Stephanie, for being here. I really appreciate your openness when I see you present. And I guess my big concern is that the people that we look to for leadership at the state agencies are talking more like our electeds. Like, I'll give you an example. CalAIM is pretty much handled by managed healthcare in our county, CalOptima. However, a lot of people still are very unaware of what's going on in the community. So there's 40 million of us in California sitting on the sidelines, and the system users, families, and loved ones haven't really even had access to a lot of this information, nor have even the 900 plus board members across the state for these behavioral health commissions. The second thing is I think there's a possibility of a liability of the Medi-Cal claims process for federal funds participation. So payment reform started on July 1, but we talk about is that it's completely operational and going smoothly. So if it takes 10 years, this is off Mike Geist's presentation, our board, if it takes 10 years to solidify or ensure all the claims are cleared through all the state and federal and all that, what are we going to do for the liabilities for fiscal year 15-16 forward in this plan? And then the last thing is just the unintended consequences of the proposition. No Place Like Home. We lost $800 million of future mental health service, direct services, so we would have access to money. We're taking 2.8 million, 2 billion out. We allocated or awarded 2 billion, but let's not talk about awards. Let's talk about speed of implementation as our loved ones get sicker and sicker each day. And if we have a homeless problem, or we have an SUD budget problem, or we have a mental health budget problem, why don't we present the business case? How much money is needed to solve it? And then ask them, if you want to go proposition, ask the voters if they want to solve it that way. Because right now, I'm expecting that the 13 city mayors are all signing up for those behavioral health facilities in the bond. So I expect them to be in Irvine and all the other different cities. And when I saw the county of Sacramento be completely opposite, the housing czar, Sacramento mayor, it's very hard for us to look at the sidelines and feel good.
Thank you, Steve. Your time is up. Please wrap up.
Okay, so all of this requires silo breaking and presenting the information across the boards. And if we can't find safety where people can speak in public without fear of retribution or just fear of speaking in public, this is never going to work in California. So thank you for all your hard work. I don't mean to be a Debbie Downer. I'm just trying to be a realist. And thank you very much.
Thank you. Next, we have Avery. Your line is open. You can go ahead.
Thank you so much. Avery Hulag Vicente, California Association of Mental Health Peer-run Organizations, CAMPRO. Thank you, Stephanie and commissioners, for allowing us the time to speak about this. I would like to echo the comments from Commissioner Rachel Chambers as well as Commissioner Katara Tamplin. We're in alignment with their comments regarding Medi-Cal billing. The peer support workforce needs to be provided support and technical assistance to sustain their work and have equitable access to any opportunities to expand and build upon the great work that they're already providing to serve our communities. And I also want to mention that we agree with Commissioner Tamplin's other comments to include a lived experience advisory board that consists of mental health peer consumers with lived experience, really defining that lived experience, what that means from the many peer consumer perspectives, including BIPOC communities, LGBTQIA+ communities, transition age youth populations, and of course, peer support specialists and all the intersections within that. And include that language to create a board like this. That would be an opportunity for the administration to show respect and uplift our voices with intention. CAMPRO is still in opposition of SB 326. Despite these amendments, this bill has been moving incredibly fast, and we, along many of the ally organizations, some represented in this room, we've been organizing and advocating within these limiting structures of public comment and commission meetings, legislative hearings, meetings with legislators. We've been working within these structures as fast as we can with the limited amount of time that we have. And it shouldn't be this way. We should be at the table with you, working hand in hand to address the needs of the communities, which is how the MHSA was created from the beginning. So this expedited process contradicts the intent and the structure of the MHSA, which was designed for the communities by the communities. We ask that you slow down and delay putting this on the ballot in March. There's still so much more that needs to be addressed beyond these 2-minute limits. So please delay this proposal. Thank you so much.
Thank you.
Thank you. And then next we have our last comment. Due to time, we will have to end here at our last comment. Thank you. We have Tara.
Good afternoon, Chair and Commissioners. Really great to be here with you all, and thank you for the opportunity to comment. Target Boa Eastman with the Steinberg Institute, we're proudly in support of the initiative, which we think provides really great clarity in terms of setting statewide priorities and really strengthening our outcomes and accountability framework to make sure that we're all rowing in the same direction and able to achieve the original vision of the MHSA. Also really want to acknowledge the amendments that have been made, really appreciate the flexibilities and the buckets, including the off-ramp from housing for those counties that are able to demonstrate they're able to address the homelessness issue. I think that'll go a long way in ameliorating a lot of concerns among stakeholders. Really appreciate all of the work on the administration's part to work with the partners at the table and continue to make amendments, but also really want to thank the commission, the staff, all the stakeholders at the table for all of your valuable feedback. I think I speak on behalf of the Institute when I say we think that each version gets better and better, and we're really excited to continue our partnership with everyone here. Thank you so much.
Wait, so there was one more person who was in the queue, so.
Oh, okay, sorry. Tiffany, your line is open.
Thank you. I wanted to also elevate the comments of Rachel Chambers and also of Commissioner Champlin, as well as those of Avery that spoke just a couple of people ago. This is going so fast. And we, as peers, have not been brought to the table in a way that would be really beneficial, I believe, to this entire process. There should be an intentionality to reaching out and gathering the voice of people who are going to be directly impacted by this, bill, by these kinds of measures, and reaching out to people who have this specific experience with the kinds of conditions that are mentioned within this bill. There should be also, more time. There's no reason to rush through this in this way. We can come together, a lot of people with lived experience, are leaders in this community, with nonprofit organizations, with peer-run agencies, and have a lot of great ideas for how to make changes that are going to be impactful and really, make this something that's not going to harm, but to support. Again, nothing about us without us. It's an important central tenet to peer support and to the laws that impact us as peers. So I would very, very strongly encourage that this, be extended, the timeline be extended, that we have more of an opportunity to make our voices heard and not to be silenced in this process. Thank you so much.
Thank you, Tiffany. So I want to thank Stephanie and Secretary Ghali for listening to our thoughts and concerns, both before the commission and in our separate ongoing conversations. We also appreciate the time you've spent coming to multiple commission meetings and providing us with updates. We are still working through the amendments, but they address many of the concerns that have been raised by the commission. The proposal highlights areas where we have failed to do enough and where there are opportunities to do more: housing, addiction, early intervention, prevention, early psychosis intervention, and leveraging the opportunities to tailor care through full-service partnerships. We continue to have concerns that we do not yet see addressed in the amendments, including behavioral health reform, not tackling the opportunity to ensure Californians' commitment to school mental health is sustained, for example, when SYBHI sunsets. It's also unclear how the state will ensure that innovation will happen without fiscal mandates. And we're still unclear about the focus and restatement of a commitment to accountability, how that would be implemented. Fiscal categories for state operations may not be sufficiently flexible over time to address evolving needs, especially considering the amount of technical assistance this proposal will require to be successful. We want to be 100% certain that the governor and the legislature can amend and adjust the language over time to account for unanticipated challenges rather than going back to the ballot. Details matter, and how the state and the counties implement these reforms will determine if more Californians can access care and achieve recovery. And finally, the concerns my brilliant colleague, Commissioners Chambers and Tamplin, brought up today. We want to ensure the state has an implementation plan that matches the scale of the statutory reform. And more importantly, we want to ensure that implementation sufficiently engages the clients and the families served by the behavioral health system. We'd like to see one of the goals of this reform to eliminate disparities in behavioral health outcomes, and the best way to do that is to improve how we engage and listen to California's diverse communities. In light of these outstanding concerns that the Commission is still seeking clarity on, I propose we do not take a vote on a position today, but rather call a special virtual Commission meeting in the next 10 days before the end of this legislative session. This will provide additional time for the administration to respond to the Commission's concerns and will allow the Commission to vote on the final product, as we understand there are still more amendments forthcoming. Again, I want to thank Secretary Ghali and Stephanie and the team for the time they have spent with the Commission to understand our concerns, and we look forward to continuing to work together to ensure that we get this right. Stephanie, again, thank you for being here and for just continuing to talk with us, spend time with us, and answer the questions that we have along the way. So having said that, we are going to go ahead and continue to move on. So to the next agenda item, please.
Okay, thanks for having me, and sounds like we'll be back in 10 days.
Thanks, Stephanie.
I will relay your comments up the chain. So thank you very much for being very specific. I appreciate it. And thanks for having us, and good luck with the rest of your meeting.
All right, take care. Next, we will move on to agenda item 10, the Commission's 2023 to 2024 strategic plan, where the Commission will hear an update on recent community engagement efforts and draft plan components for the Commission's 2024 through 2027 strategic plan. I'd like to welcome back Boston Consulting Group, who previously provided us an update at the June Commission meeting on the development of our strategic plan. They are here again today to provide another update. So BCG.
Thank you, Chair Madrigal-Weiss. Can you hear me all right?
We can hear you just fine, thank you.
Great. I'm going to share my screen as well. Can you confirm you can see the pages here?
We can see the slides. Thank you.
Fabulous. All right. Well, let's get started. Pleasure to reconnect both with the Commission and with the community partners and members of the public who are joining today in person and on the phone. For folks who weren't on prior meetings, I'm Anna Silk. I'm joining from the Boston Consulting Group, and we've been engaged by the Commission to help support the strategic planning process, particularly to help collect community input to be reflected in the strategic plan, which we'll share an update on today. Just to set the context, the Commission is still in the early stages of developing the strategic plan for the coming years. And in that process, there's an opportunity to reflect on the Commission's work to date and the lessons learned, to articulate how the Commission's work fits into the broader context, which I recognize you all have been talking a lot about today, thinking about the broader behavioral and mental health landscape, as well as looking for opportunities to catalyze the transformational change that the Commission is committed to. So today represents one of many opportunities to engage. I also want to acknowledge that this process was designed as a learning and collaboration exercise with a diverse set of community partners. We've conducted a very focused effort, particularly in May and June, but will through when the report is released publicly on November 30th, to a focused effort to engage the community. We've had 30 engagements so far, everything from connecting with community partners to CBOs to counties, providers, peers, academic institutions, government leaders. I don't mean to talk so quickly through such an important list, but it's been a great opportunity, as well as to talk to Commission staff. And today we'd like to share some of the early inputs that we've received as you all start to shape the plan. I also want to acknowledge there will be additional public input sessions in the coming months, and we'll save time at the end of this conversation to highlight what those opportunities will look like. Two quick disclaimers before we dive into the details here. The first is just to acknowledge that this process is in flight, but not complete. So there's more work to come. This is a conversation to workshop, but we want to do that, with open doors and not behind the scenes. And then just want to acknowledge an extra thank you for folks who have engaged in the last few months on this process, and recognize that the work will continue to evolve over time. So consider this a starting point. With that, we'll dive into the content here. One of the core benefits of a strategic planning process, which the commissioners engaged on in our first conversation on this topic in May, is that it's an opportunity to really reflect with your community partners, with your staff, and as a commission on how you bring about transformational change to the mental health ecosystem and how that influences your strategic direction in the coming years. But that question of, is our strategy delivering the change we want to see? It can be challenging to answer, right? It's a bit heady. And so what we've done is break down that question into a detailed set of building blocks that make up the Commission's strategy and strategic direction. And as we've engaged with this broad swath of stakeholders and community partners, we've asked them to reflect on the commission's mission. So why does the commission exist? What impact is it trying to achieve? We've asked them to reflect on the guiding principles, of which you had some in the last strategic plan, which we've taken the opportunity to reflect on. You know, what do we stand for? What beliefs sort of underpin our action? Opportunities to reflect on the commission's role. So how do we really contribute to the landscape? What's the unique function of the commission among many peer organizations? And then how do your capabilities, priorities, and initiatives ladder up? And commissioners will recall from the June meeting, we spent a brief moment discussing a decision-making tool to help guide your priorities and initiatives in the coming months. We will, and years. We will return to that discussion today when we have a bit more time to engage. So what we'll do in the next, let's say 30 minutes here is talk through some key findings or insights that we've heard from the input that we've collected across some of these topics, and ask for your input to evolve and update as you all move towards drafting the strategic plan. With that, I'll move us ahead into the topics for discussion. So first, I'm going to give folks a moment to read the mission statement on the left-hand side of the page. We solicited input on the commission's mission, and we heard a significant amount of resonance and support with the commission's mission to catalyze transformational change and to focus on the fundamental need to ensure culturally competent care for everybody who needs it. When we had conversations about the commission's mission, we often found those conversations steered quickly towards guiding principles or values of the commission, which you can't fit every value into a mission statement, but folks, you know, recognized and helped articulate or helped build on some of the guiding principles that the commission articulated in the last strategic plan. And the way I would describe the guiding principles is the lens with which the commission looks at the world. And that should be a lens with which you make strategic decisions. There's sort of two areas of input that would be helpful to collect today. The first is on the mission statement, which we heard sort of no recommended changes from the input collected. Are there any reflections or changes that the commissioners see that would be valuable? And then second, we can talk through the guiding principles and take your input and reactions. But let's start with the mission statement. Commissioners, any thoughts or questions or reactions?
I'm just curious, is there any reason why we weren't specific and say that transformational changes across service systems so that everyone in California who needs mental health care? I mean, because we're not talking about the entire United States. Are we also talking about visitors? I mean, I'm just why we weren't specific with that.
Yeah, it's a good thought.
When I read it, the other thought I had was it says to catalyze transformational changes across service systems. What about within service systems? I would think it would be both.
I think that's really reflective of the last conversation you all had as well. So appreciate that reflection. It does feel like your work to date has been both within and across. Appreciate that contribution.
Please, Commissioner Chambers.
Just so I know that we're going through changes potentially, stuff has to go to the ballot. So I just have a question. Would this potentially need to change from the sentence who needs mental health care to behavioral health care at some point. So we'll be going through this again, but potentially, or are we just still focused on mental health right now? Or are we emerging with the behavioral health?
I think we
lens?
decide.
Because I mean, if this thing goes through, then we're gonna be back here. Maybe just that edit then.
Yeah, no, I think it's I think we decide.
It's an important piece of input, so thank you for elevating it. And I recognize you all have, more work unfolding there, but I think that applies across the set.
Commissioner Templin and then Commissioner Gordon, please.
Thank you. Thank you, Chair Mothergell. I'd love to see the individual's recovery and resiliency journey reflected in our mission, so that everyone who needs mental health care has access to and receives effective, culturally competent recovery and culturally competent care that supports an individual on their recovery and/or resiliency. I think that's our ultimate goal, is that people are getting better, not just everyone who needs care has access to it and receives it, but that we're examples of recovery, and then children are, going through our systems are examples of resiliency, and that we're getting better, not just accessing care. Yeah, thank you.
Commissioner Gordon.
Yeah, the only other thing that struck me is it doesn't speak to a prevention approach, and I was trying to figure out how to change the wording. It's a little difficult.
Mm-hmm. Mm-hmm.
But I think somehow it ought to
include it.
Yeah.
Address it.
Yeah.
I think Chair Alvarez on the phone as well. Maybe you want to chime in.
Thank you, Commissioner Alvarez. Sorry, we don't see the.
Sorry about that. No problem.
Oh,
Thank
it's
you.
our fault. Sorry, please.
Actually, following up on Commissioner Gordon's comment, I completely agree and was curious if there was opportunity to not only emphasize care, because that does tend to imply a more medical model of care and treatment, but services and supports, right?
Mhm.
That emphasizes prevention and the type of environments we want to create to help ensure we are preventing crisis where necessary. And whether that's in someone who is living with mental illness or with babies and toddlers and young children, I think across the board. So maybe something along services and supports to broaden it out.
Mm-hmm.
And I'm sure we could also wordsmith this to death, Anna, so I appreciate your patience.
Absolutely. No, I think what I find so valuable and interesting in the conversation so far in the comments is the reality that many of those are starting to be reflected in the guiding principles or could be infused with them as well. That there's the mission statement, which is the overarching, creed for how the commission engages, but that there's also a set of sort of core tenets or values that you all are articulating around prevention and early intervention, around recovery and resiliency, around services and supports that need to be reflected. I think some of those are showing up on the right-hand side here around the guiding principles, and a few are meaningful additions. The others that folks haven't raised, but I heard in the conversations with your community partners and also with you all as commissioners in May and in June, are around the focus on reducing disparities and on health equity writ large, and the need to protect vulnerable communities. The need to be data-driven and metrics-driven in decision-making, and the role that the commission plays in advancing that effort across the state. And then I think I recall Commissioner Brown sort of elevating the need for agility and responsiveness from the commission in how you make decisions and how you sort of show up in the broader mental health ecosystem. I welcome folks' sort of reactions to the right-hand side. Your your comments on the mission, I think, flow through here, but if others stand out to you, additions, changes, welcome thoughts.
Anna, I'm a question.
Yes,
So
absolutely.
where it says mission and it says no change, when was there no change? So, because today we're having, seems like a lot of change.
Yeah, we're having
So-
exactly. Chair, it's meant to indicate that what you're seeing on the screen is no change from what your current mission statement is. So we're discussing whether a change might be needed.
Okay.
We can rewrite that when we came to the discussion. What you're seeing on the right-hand side, alternatively, is these guiding principles are in addition. They're updated from the last time you saw them in the 2020 plan to reflect the conversations that we've had to date. I think what you're heading towards is perhaps the commission is ready or interested in changing and updating the mission statement along the lines of what the commissioners have just shared. Does that clarify for you?
It does clarify, and I think based on what we've shared here today, I think there is room for change, modification to the mission. I think those things that have been brought up between resiliency, recovery, I think prevention is core to what we have been talking about for the better part of, few years now. So I think it is, time for the consideration to the mission beyond the guiding principles, for sure. Thank you for clarifying that.
Absolutely.
And to your question, sorry, about the guiding principle, gonna bring up again the whole piece about recovery. And I think when we talk about children and youth, it's also resiliency. Those are, when we're looking at anything we're doing, are people experiencing recovery, and are our youth resilient in their act, in what they're struggling with, and just seeing that throughout. Recovery and resiliency should be in every area that we are part of. Yeah.
Thank you. Other thoughts or additions before we move towards roles? I think incredibly helpful to sort of take a next iteration on both of these topics.
Is it, I have a question regarding the guiding principles and bullet number 1, 2, 3, 4, 5, transparency. We had the data presentation earlier, transparent.
I think the mic has perhaps dropped out. I'm not sure those on the phone can.
I'm sorry, it wasn't on.
There we go. Sorry, we missed your comment so far.
No worries. The data presentation earlier today really shed light on the importance of data informing decision-making and even principles of the way we practice. So, I think this is bullet number 6, transparent, data-driven decision-making. Can we include something regarding families in there? Because data-driven decision-making, family, natural support involvement. It's something that includes the family. It's key to what we do in this business.
Thank you for elevating that. And I love the connection to the work that you are already doing today. I'm going to sort of charge ahead here so we get the opportunity to collect your input across a swath of areas where we've heard feedback, but welcome folks to revisit these topics as we go through the discussion, and I'm happy to flip back. I want to also have a conversation this afternoon on the input we received around the commission's roles. So we asked community partners and staff of a broad variety of backgrounds to provide input on where the commission is most unique and differentiated, where the commission has the highest impact, and where there's opportunities for the commission to continue to advance your work. You'll recall that the last strategic plan did articulate the commission's authorities and responsibilities, which have evolved over the course of the last 3 years, and I recognize may continue to evolve as you all navigate the next legislative process. What we've done is collect input from community partners on the ideal role of the commission, and I wanted to highlight a few sort of representative excerpts here. I think the first is around, and I'm just starting from the top left, is a focus on the commission's work in innovation, and particularly the role that innovation plays in the commission's support of counties and counties' ability to then think differently and experiment, and especially for counties who may not have the budget or support to experiment, if not for multi-county approaches where the commission has meaningfully invested. Going down the left-hand column here, there was recognition that the OAC is doing meaningful work to gather partners and community knowledge and really engage with communities, recognizing the 8 populations you all engage with through advocacy, and that's a huge strength, but also an opportunity to more systematically share out what you're learning from those community engagements, and also to demonstrate how that's integrating into the work that you all are doing in a continued and ongoing way. There was recognition in the bottom left here that the commission plays a critical role in sort of celebrating wins across the ecosystem, and sort of being a storyteller and a champion for the proven approaches, whether those are community-led or evidence-based or both. In the top right, there was a recognition that the commission, when it's at its best, or as it, in its ideal state, is a repository for best practices across the state for clinical innovation. There was also, significant recognition of the commission's role in scaling interventions. There was recognition that the commission brings discussion on mental and behavioral health topics to the public, and the critical role you play in creating an opportunity to engage in the system design process, which this commission meeting is a representation of. And then lastly, there was recognition that the commission is playing a critical role in demonstrating the success of community-based alternative strategies. And I think this interesting that the feedback that we were collecting from your staff and community partners, I heard echoed in the prior conversation around capacity building, around innovation, around sort of community defined and culturally affirming or community-led best practices. So what we've worked to do is capture all of this diverse and valuable input and take a initial sort of straw man pass at re-articulating or updating the commission's core roles, including your role in catalyzing innovation, whether that's supporting or incentivizing partners to test ideas, whether that's creating a culture of innovation in policy and practice, and just a recognition that's both within their innovation funding, but also more broadly in the ecosystem. The second is around accelerating adoption of best practices, both evidence-driven and community-defined, and disseminating those learnings, and also an acknowledgement around the technical assistance role that you play today and may continue to grow in. There's a recognition around convening and influencing partners, the role the commission plays in mobilizing action and creating opportunities to sort of improve the systems. That's the within and across systems for transformational change that we talked about in the mission. And then also the advocacy work that you all do to support target populations, to promote collaboration across a broad set of systems and agencies and localities. And then lastly, the role of building public trust and ownership in the behavioral health system, and the recognition that sort of increasing transparency and reducing complexity and increasing legibility are critical to the end users of the mental health system getting access to the care they deserve, and ultimately being able to get to that place of recovery and resiliency that you all talk about. So that there's a lot there, I think, for folks to react to. I'm curious if this feels like it resonates and reflects how you think about the commission's unique contributions in the landscape, and particularly interested, given the prior conversation, how you think about the commission's role in innovation over the coming years.
Commissioner Gordon, please.
I just had one suggestion in the first, the catalyze innovation.
Mm-hmm.
I might suggest we speak to a culture, not just of innovation, but of early intervention and innovation, so that we highlight innovation around earlier intervention.
Mm-hmm.
Thank you. Other ideas or comments? Did you want?
Well, definitely, I think a culture of prevention is important, early intervention. And it really feels like maybe we need a better or a clearer definition throughout our state, and this could help, of the culture of recovery and resiliency. I'm gonna say this again, and at the end of it all, you know, if life puts us down this journey of needing services, needing to access it, whatever settings it is, we need to know that someone is being supported through that journey, and that the ultimate goal, again, the culture, is we understand what recovery is and what resiliency is for people to fully, and we don't have, you know, confusion about that, where you know, even if something comes in as innovative, if it's not supporting someone's recovery journey and resiliency, then that is not part of our efforts, right? So that's just kind of blanket statement again.
So I think to that end, Commissioner Tamplin, what you're saying is kind of what we had talked about when we speak of the cultural competence piece, that everything we do should have that lens. It should be just a natural part of the process. So through a lens of always of cultural competency, resiliency, and through inclusion of families and natural supports. It's like everything we do, that should be just our baseline of operation. And then we build on that, but it has to include those basic tenets. It's probably more it. So in all of these categories, we have to look through that lens.
I agree with you.
Absolutely. That feels like you're articulating what those guiding principles need to look like, that regardless of what role you're playing, that you're always looking through that lens, or guided by those.
We're guided by those basic principles of recognizing and respecting those basic tenets of fairness, of family, of seeing families, of through the lens of equity and inclusion. That's as basic as the air we breathe. So it should really be on that level. And we shouldn't have to carve it out over here, carve it out over there. It should just be.
Thank you. Chair, are there other comments in the room before we continue on? Thank you. Incredibly generative input so far.
No, I think we're just kind of looking at it from our-
Processing. I know there's a lot there.
processing, exactly. And we're reading it from, we can see it on the big TV screens, but we're also looking at it from our computers.
I don't know how to put this, I don't know how to put this in writing, but it's come up several times, and it's been something we've struggled with this, the connection with schools. It's how do you merge the interests of systems, not just by saying you're responsible for this, you're in charge of this, you're in charge of that, but to where the people that they serve get common messages, and the people who serve them have common messages about what's important to support their mental well-being, their physical well-being. So the idea of a school, a kid spends a lot of hours and a lot of years in a school. So take advantage of that. The workplace, the family. How do you express the need to infuse all of those things with common messages and common understandings?
Yeah, incredibly important point there on shared understanding. And I think that shared understanding also builds shared buy-in, right? And shared commitment and ownership, which creates some empowerment from communities.
I think when we're talking about like the wellness, it's those that are, I'm thinking of school.
Yeah.
Those that are, you can't just promote wellness and not be well. So it's, we're constantly talking about this. So I know, for example, in our county Office of Education, we're going to be implementing the mental health workplace standards. How, because again, and we've talked about teacher self-care, but that, self-care is starting to get really used. And if you tell teachers to self-care one more time, they're not going to care about you it's dangerous, right? So we have to be really intentional. And so I think that it's that language. It's not just whole person, it's whole community. And, right, so when we just talk about whole person or whole child, it's whole community. We all have to be well together. And so I think that that's kind of what we're talking about. How is it that we are saying the same messages across all the systems, across, if it's the early ed, or the TK providers and the parents and the after-school programs, as again, talking about schools, how are we all saying the same messages? And I think here, as a commission, ensuring that when we talk or work with across the systems, how are we doing that as well? So I don't know how to say that either in a very articulate way, Anna, but that's what we're trying to talk about.
Yeah, I hear you talking about your role in sort of integrating or advancing sort of a unified message, or maybe even identifying the places where that is not connected or unified and helping find a solve for that.
And I think as what Commissioner Templin's saying, this is how I'm hearing it. When you talk about recovery and resiliency, it's not enough just to get care. I think our lens should always be towards getting better, right? It's great that you get access and you get the services, but isn't our end goal always towards getting better?
Lasting.
Just getting access to services, but we could do access for services for 20 years. Our end goal should always be about somebody's life improving and getting better. Like that should always be the goal.
Absolutely.
That's how I hear Commissioner Tamplin wanting it to be part of guiding principles always.
Yeah.
Thank you. I agree and appreciate that.
I agree with that.
I think, our role also is advocacy. And I don't necessarily see that stand out as much. We are ourselves advocating to elevate the whole transformation of our system to ultimately support an individual and their families to achieve wellness and resiliency and recovery. And so that advocacy piece, you know, is one of our roles. And, you know, it's clear, this is just a comment in terms of the overall piece, like even from the comments about our stakeholders about the innovation and then our role about innovation, that this is still really core to our role and what our community sees us as. And so hopefully, from the previous agenda item, we really can still keep on advocating for keeping innovation uplifted through this process. And so that's just a comment.
Thank you. No, meaningful. Thank you for taking some time to share it. Perfect. I want to make sure that we save just a little bit of time to talk about how this integrates to the commission's priorities and your initiatives, which is a conversation that will extend beyond the strategic planning process to how the commission, you know, makes decisions day to day. But one of the goals of the strategic planning process was to develop a decision-making framework that helps the commission think about how you prioritize across initiatives, but really to focus on, and I think, you know, Chair and Vice Chair, you were just emphasizing, how do we maximize our impact? And that it's that long-term recovery and resiliency as the outcome that we're targeting with the available time and resources that you have and the broader community partners that you collaborate with. You know, the goal of the decision-making framework is also to clarify your focus across the portfolio, to think about trade-offs between the current challenges that you all are working actively to contribute to and the new emerging threats that we talked about all the way back in May, the transformation that is expected in the behavioral health system over the coming months and years. And then also to give you a way to continually design and monitor programs to maximize the outcomes that you're getting for target populations. So the purpose of the decision-making framework is to help you decide what the commission should be focused on and how you can best deliver on those topics. And the input that we captured from community partners and staff on this topic were interesting, and I wanted to share just a few, again, a set of representative excerpts for you. I think there was a meaningful amount of emphasis on the commission looking for opportunities to think critically about where your focus is positioned, given the limited resources that the commission and community partners more broadly have, and really focusing on growing the things that you do well and articulating a clear focus, so that, you know, every nail is not one you need to hammer, is how one community partner sort of communicated that. I think there was real recognition that the commission's impact is incredibly valuable. And so how do you direct that impact? So there was recognition, you know, you could work on just one issue and have your plate be full. So how do you really focus? I think I remember, Chair, perhaps in June, you sharing, you know, the concern that, you know, if we sort of stand for nothing, we fall for everything, or the risk that the commission may have if there's more and more competing priorities. And so how do you utilize a decision-making tool to help focus where you spend your time, very similar to what you all did in your exercise to set priorities this year. So I wanted to just elevate the work that you're already doing to set priorities and emphasize some of the sort of divergent perspectives on this topic. I also wanted to just take the last few moments here to revisit the decision-making framework that you all or those who were available provided input to in the June commission meeting. The goal of this framework is not to make, analytical decisions without the context or without the broader input of the commission and community partners, but to give you all a set of guidelines or criteria to consider as you think about new opportunities related to the need, related to the impact of the programs that you're considering, really using your roles and your guiding principles that you all are continuing to evolve to think about the fit. So is this a topic that the commission is best positioned to contribute to? And then lastly, thinking through the feasibility so that your partners and your grantees and the commission are well positioned to fully deliver towards the outcomes that you're seeking. There's a few meaningful changes that were made as a result of your input in June, reflecting existing needs in addition to growing and emerging needs, as well as reflecting the need to not just think about individual impact, but also to think about the systems impact that you all are creating with the work that you do. I do want to take just a moment here to collect any additional feedback or reactions that commissioners have to the decision-making framework as it relates to the strategic planning process, and want to acknowledge that there, is more work to come from the OAC staff and team on how this gets operationalized as you consider new opportunities in the future.
Yes, thank you, Anna. Commissioner Tamplin has a comment.
I do, thank you. This goes probably 2 or 3 slides prior, back, and it's to elevate the committees of the commission. Because I saw somewhere where it said policy projects were, part of the, on the right-hand side on one of the slides. A lot of our efforts has, right there, needs to always include our OAC standing committees, and the 2 that I will just advocate for always being around is the Client and Family Leadership Committee and the Cultural Linguistic Competence Committee. Those are some of the committees where we get our partners active in our work and involved in the strategic planning and continuously guiding us and working with us around the work of the commission. So elevating those committees, please.
Thank you. Go back to this one so folks can react.
Other comments?
Yeah, I think on the one on page 7, I guess, what you have in the box is policy, project, strategic partners, data. Those are not outcomes. those are ways to get to
Agreed.
And I think the priority setting ought to focus on what do we want to do differently or in addition to what we're doing now, and then figure out what's the best way to get to them. Should it be an innovation? Should it be a policy change? Should it be a combination of the 2? I mean, a grant sort of goes without saying. It's an incentive, but the other thing with innovation is every innovation is kind of a startup, and what percentage of startups actually succeed? Probably 20% would be a big number. But I think in government, somehow we assume that it's going to be foolproof, and people are so smart that whatever they start up is going to be great. Well, it's not the case. So maybe you ought to start up more things than you think you necessarily could take to conclusion. But anyway, I'm just thinking of it from an outcome perspective. might be more helpful.
Yeah, incredibly valuable. And I think that goes to the sort of impact piece. You know, what is the outcome that we're trying to get to? What is the impact that we're trying to achieve? And then what are the proven models, or what are the ways that we could test this? What are the individuals or systems that we need to address? So I really appreciate that. And I think, well connects to the roles discussion on innovation and that culture piece as well, that you have to test and learn a lot more than you would in other areas. So appreciate that. And welcome folks to add, but I'm just going to sort of close out here and pass off to the OAC team to share a few next steps. But what was discussed in June is the power of a decision-making tool to help you look across the portfolio and think about opportunities. So I think to your point, Commissioner, what's particularly valuable is also to be able to say, okay, we're going to start a lot of different startups or ideas. We're going to look at those opportunities and see how they're doing as it relates to their outcomes. And look at the outcomes of our existing programs and be able to say, what are the areas where we want to continue to be high touch and be very focused, given, they're well in our wheelhouse and we have a lot of impact if we continue to contribute, and where are there areas where you may review or reduce focus or pass to another partner to continue to develop in the long term. So there's a lot of different ways that a decision-making tool can be used, not just to look at sort of idea by idea, but more broadly at the portfolio level. Any other sort of thoughts or contributions before we move on to next steps? And I pass to Norma and Anna.
I just have one quick comment. I'm not sure where it fits in, whether it's page 7, where we talk about clarifying focus across our portfolio and understand opportunity. No, I'm sorry, the next one, trade-offs between addressing current challenges and new emerging. That's not it either. I'm sorry. Let me see. Hold on, give me a second.
No problem.
I guess I'm just looking for, again, outcomes. There was one on here that it was real clear when I took a quick look at it. But the question is, how do we really measure? Again, I'm going back to outcomes, because we do so much work, and yet I don't know if any one of us can really identify change. I know we have the dashboard, we've started so much work, but when we just look across the landscape of our community just at a glance, I'm just not seeing, and this is a horrible statement, but it doesn't seem like things are getting better. And so I guess the measurement, where do we see, maybe programmatically, where we've made an impact in the lives of those we serve? So that's, all of this is beautiful, but where do we actually see change? And how do we measure that? Do we measure it program to program, or from program to program, or from zero to startup? Because that's better than nothing. Again, because we have a dashboard. But how do we show that we are truly making an impact in the lives of those Californians whom we serve?
So, Anne, if I could, I think that's something that we've been talking about for a long time as a commission. And I think that it's one of the things that's come up with the whole modernization, right? So I see this as our strategic plan about, I don't know that that's going to be answered through our strategic plan, but, and I'm just, I agree with you 100%. I see it when we have the Evaluation and Research Committee. I see it when that team is trying to say, hey, what does a dashboard look like? How can we get data? And then the next question is, wait, we're not getting the data. And why aren't we getting the data? And the systems aren't sharing the data. And so it's hard to see, are we making a difference when we're not necessarily getting all the information that we need to get in order to create something like the transparency tool, right? So that's one of the things that we were able to do. So I agree with you 100%. How can we do that better? And I don't know that until we can get the pieces of information that we need, that we can tell the story. And earlier, when I was talking about when we had the data presentation, and I just go back and I'll never forget when we started to count PEI, and we don't even have common definitions. So even if we got data, how one county looks at PEI and another looks at, they're not even defining these things. So we're so, in my mind, we're so far behind because we can't even agree on how to define.
Yeah.
If we can't even agree on definitions, how can we begin to count? So it's so much more systemic to me that I don't even know what the answer is. So
I know through site visits, those are a very tangible way that we see progress, that we see success. And yet the programs that we saw the most success through were mom and pop programs that were making the biggest impact. So there's a gap somewhere. And I scratch my head with this all the time regarding the impact, closing the gap, because clearly money is not the answer. So, and that's almost an unfair statement, but I never get an answer.
Yeah. Can I also jump in? Because this is like perfect. I think I agree that there's a need for more change and more improvement of people's lives and seeing more of it. And to your point, Commissioner Mitchell, that when we go and see and we go to the programs, we see the actual impact the services are making, right? And then there's a piece of things we don't have any control over, and it has come up in this MHSA modernization, and our communities are calling it out, the housing crisis in California. No matter where you are in your recovery or your life, if you end up losing your home in California, I will end up homeless and in crisis. And so all that we're putting into the services and uplifting our providers and our CBOs to do this great work becomes even more difficult and more in need if we're also not in our advocacy role calling out what we don't have the control over changing, but needs to change in California, right? Like the more housing prices go up, the less low-income individuals have access to that and end up in our, end up homeless. And the research has shown that. And it keeps on putting a spotlight on mental health and not on the housing crisis. The cost of living in California is why we keep coming back and saying, why are we not seeing the changes in our communities? Because we're not also able to address in our role that piece that requires everyone else to be at the table and not stigmatize mental health and substance use as the blame for all of it, but as looking at, well, what's going on with those prices that our communities aren't now welcoming change where people have low-income housing available, supportive housing, permanent housing available in every community. Why are we not seeing that, right? So I think there's this piece that we don't have control over that maybe in our advocacy, we could shine a light on what needs to change outside also.
Thank you. Incredibly important conversation to be having. And I think Chair Madrigal-Weiss, what you shared that, this is a topic that the strategic plan maybe can touch on, but isn't the only venue with which you tackle both the commission's ability to contribute to tracking your outcomes and your contribution to those outcomes, as well as more broadly the system really demonstrating for the money that's being put in the outcomes that you expect to see. I think what the strategic plan can do is demonstrate the commission's commitment to moving towards a more standardized approach to making decisions and setting up programs to demonstrate the outcomes that they will achieve. And also to recognize that this is both an art and a science, that looking at things sort of data line item by data line item or county by county just from the data, you may miss the work that's being done or the importance of the actions. And so as you continue to refine the decision-making tool to be able to give you all room to bring all those considerations together. I'm going to pause and pass it over to the colleagues on the OAC staff to give a picture on next steps here, but just huge appreciation for the contributions today and the comments. I think there's a lot that can go into the drafting process. Thanks to your inputs. So incredibly valuable. Thank you.
Great. Thank you, Anna, for presenting the first draft of the Commission's strategic plan and framework today. Cody, excuse me, Cody, could you bring up my slide, please? Excuse me. Okay, I asked Boston Consulting to present the draft goals today so the Commission and the public see them for the first time at the same time. I appreciate your time today, Commissioners, and the discussion on the value and process for setting priorities. And I'd appreciate getting the Commission's feedback on the remaining elements of the outreach plan. The goal of Anna's presentation was to help the Commission and the public better understand the extent, breadth, and value of the community engagement aspect of the process so far, discuss the criteria to assess the adequacy and quality of the engagement process, and the draft framework for the Commission's strategic plan. Next, I'd like to present opportunities to gather more feedback on the themes in the draft framework. The subsequent public outreach activities would focus on specific audiences to get feedback on the draft plan, including the proposed goals and objectives and the questions regarding priority setting. And what we're going to be doing next is we'll be gathering the input is currently being gathered in multiple ways without time limits, allowing people from the public to provide their comments to us without setting the 2 or 3 minute time frame. Staff will report what was heard and how it was incorporated or considered in developing the plan. Diverse perspectives will be engaged on reducing disparities. Anna discussed how we engage the community in what we will call phase 1 of our plan. And we've had 2 commission meetings, and then today is our 3rd commission meeting and discussing the draft strategic plan. As Anna mentioned, we've already conducted interviews and public meetings. We've interviewed 30 partners across the landscape, and public meetings with approximately 40 community partners were represented in those meetings. And Tom's team also held listening sessions for our community advocacy contracts, and we got feedback during the month of August. And who did we interview? Interviews in public meetings included people from our peer organizations, our community-based organizations, community partners, California associations, counties, state, and academic institutions. And as I mentioned, Tom and his team held listening sessions with our client and consumers, our diverse racial and ethnic communities, families of consumers, LGBTQ populations, parents and caregivers, and veterans populations. They gathered information, and this will also be incorporated in our plan. We'll provide that feedback on what we learned during these sessions to the commission. And then next steps, and what we'll call phase 2 of our community engagement plan includes additional interviews and public meetings during the months of August through November, additional focus groups in August through November, and social media activities. We have on our website a list of questions, and so we're taking written feedback on our draft strategic plan and framework, and hope to share that information. If anyone, the public's listening or commissioners are listening to, or would like to share what we have on our website, we'd appreciate that so that we can expand our reach on these engagements. And as you're aware, each person on the commission represents an important population by design. Commissioners are committed individuals who see the challenges of our mental health system from every angle. And staff are going to be reaching out to you over the next few months and interviewing commissioners and getting feedback from you on the draft plan so that we can have a more in-depth conversation and we can meet with you individually. And who are we going to engage? We will continue to engage our community partners and engage opportunities across the lifespan. Community partners are valuable experts in the community. Collaborating with partners will help to gain different perspectives on mental health issues and help us better understand the needs and priorities of different groups in our communities. When we think about who we need to engage with, it's important for us to hear from those who are served. And those who are, we will reach out to consumers, families, age groups, underserved and marginalized populations, at-risk populations, including groups of people and perspectives that have been underrepresented and marginalized and or left out of decision-making in the past. We also need to gain the perspective of those who serve them. And that is our providers, our volunteers, our peers, and our insurers. Where services are provided, it's also important for us to hear from private, county, and state organizations, jails, prisons, schools, and community-based and nonprofit organizations. Those making policy, it is important for us to involve decision makers, those involved with shaping policies and systems, as well as those who regulate, including federal government, state agencies, and regulatory boards. What comes next in our strategic planning process? Like I mentioned today, you were presented with the first draft of the strategic plan. Now that we've presented that plan to you, we'll begin to engage further with our community partners during the months of August through November. We'll present a draft plan and incorporate the feedback that we heard from our community partners to you in November. And the goal is for us to adopt our strategic plan in January so that we can begin that work with the new year. I'm happy to answer any questions and welcome any feedback or any groups or any other organizations or individuals that we should be reaching out to during this process that I failed to mention today.
Question. Norma, we're probably going to have more updates on this, right? Presentations.
Yes, the next update will be in November, but if you would like to get more updates, I'm happy to provide additional updates to the commission in the next, over the next few months.
No, I'm fine. Just curious.
Yeah, definitely. Yeah, we would definitely incorporate everything that we've heard, and so that you're hearing those voices. We want to make sure those voices are heard, and that we present what we've heard from our community partners to the commission, and how we've incorporated that into our draft strategic plan.
Thank you.
Thank you, Commissioner Mitchell. Commissioner Campbell, did you have a comment?
Just, no, thank you.
Well, thank you, Chair Madrigal Weiss. Maybe an invitation for Norma and the team working on the strategic plan, again, to the CFLC, Commissioner Chambers, and myself and our Deputy Director, Tom Orick, will be working on the next dates for that. And I think it'll be really great to include, again, the CFLC's input on the work.
Happy to present that.
Thank you.
Yeah, definitely. Okay, so seeing no other comments or questions at this time, members of the public may request to make a public comment on agenda item 10 by clicking the raise hand button on your computer or the app, or if calling in by pushing *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. Amariani, please open the line for public comment on agenda item 10, and we can start with comments from the room if there are any.
We have no comments in the room, but we have 2 comments online. First, we have Stacy. You can go ahead.
Stacy Hiramoto with RAMCO, the Racial and Ethnic Mental Health Disparities Coalition. Once again, I would like to compliment and give kudos to the people that are facilitating this process. I found it to be a much more meaningful. I liked the people before, but I really like this group. They seem to really know, and they listen to stakeholders and are able to present in a way that I feel is more meaningful to the commission and to the connections to the community. The only thing that I wanted to comment that I had a little bit concern is there was a meeting on August 3rd that I attended for racial ethnic communities. And I thought that that was for the stakeholder advocacy grants, but it was listed here, so I was confused. But regardless, those meetings, if for the stakeholder advocacy grant, I know that's not the topic, but for the stakeholder advocacy grants, I was disappointed that the only people that seemed to be there were people that were connected with the current providers, which I think is problematic. And that if this was also to collect information on the strategic plan, I feel like that should be separate, because that's very different. I mean, it's obviously related, but it's very different to what the stakeholder advocacy grant should do. So anyway, that's my comment. Thank you.
Thank you, Stacy.
Next, we have Steve. Your line is open.
Hi, this is Steve McNally from Orange County, speaking as an individual. First, I just want to thank the commission. I think you model the behavior that we're all hoping for the state agencies, and that's to have a safe space that people can talk and let people talk the way they talk, and collect the information and post your videos online, easy access. All your information is easily available, and I think you should be commended for that. Some of the things, the frustrations I heard you all speaking about are things you can't really control, and I don't think openness and transparency and wanting community engagement is really part of California's makeup from the different state agencies. And until that can change, it's just going to be very difficult. And it shouldn't be this hard with all the money we have and all the resources. I was also encouraged by how so many people had jumped in earlier to add their names to support the project that was discussed earlier. And I would just hope that you continue as you fight silos in your own areas of work, that you can help model those behaviors to help empower us to break them at other levels, because there's a lot more of us out here, and we can make change if we're all on the same page. So anyway, thank you very much. I guess more will be revealed between now and September 14th. And I guess we'll see how that all works out. So thank you very much.
Thank you, Steve.
That was our last public comment.
Thank you, Mariani. Next, we will move on to agenda item 11. Thank you, Norma. Sorry. Next, we will move on to agenda item 11. Commissioner Chen has shared this effort, and I would like to ask her to introduce this agenda item.
Thank you so much. Can you hear me okay?
We hear you just fine.
Perfect. Thank you so much to everyone. I know it's been a agenda and content packed day, so thank you so much for staying all the way until this last agenda item. It's a very important conversation, and we're so pleased to continue this conversation focused on the anti-bullying social media project. As everyone likely has become aware from past meetings, that according to AB 1134, the California State Legislature has allocated $5 million to develop a peer social media network for children and youth who have an emphasis on students in kindergarten and grades 1 to 12 who have experienced bullying or who are at risk of bullying based on race, ethnicity, language, or country of origin. This project began in 2020 during COVID as a response to increased levels of race-based bullying, especially directed towards the AAPI community. To respond, we quickly put together a youth-driven advisory committee and identified key priorities for the social media strategy. Since then, Media Cause has worked with youth to build a digital peer support network through social media. And today we'll hear about the social media strategy and lessons learned from this project. So without further ado, I'd love to welcome the Media Cause staff, Melvin Carcenti and Clara Campbell, who have joined us today to present the latest findings and their report. I'll pass it onwards to the Media Cause team. Thank you so much.
Thank you so much, Commissioner Chen. And let me know if everybody can see my screen. I think so. Well, yeah, dear Commissioner and members of the public, it's really a pleasure to be here today. My name is Melvin Carcenti. I'm a Senior Account Director at Media Cause and the lead on this project. And today I'm joined by Clara Campbell, who is our Senior Director of Advocacy and Campaign and has led the strategy behind the Write Our Story campaign. Our goal today is to give you an update on this campaign and also look forward to what its future might look like. Now, we know you've been in this meeting for quite some time already, so we're going to try to make this presentation as engaging and as to the point as we can. We're going to start with the stories. So the stories we've been hearing and collecting since we launched the campaign in February. Then we'll move to kind of describing the campaign ecosystem, talk about some of the results, and then talk about any ideas that we have on how we can build on what we've already done so far to create more impact for youth in California. And I'll pass it off to Clara. We'll get us started by telling us why stories are so important and central to our efforts.
Thank you so much, Melvin, and thank you all for being here. One of the things that I wanted to talk about, and the reason why we're starting with stories, is exactly what we've heard some of you speaking about already, and that is the importance of hearing from the actual people that you're serving. We have some very intimate, painful, and powerful stories to share with you, since that's the nature of this work. But however Write Our Story has grown and whatever it's become, it has always had the experiences and lives of the young people we've engaged and supported at its heart. As you all know, we are our stories. Those stories are the lines of our past, our present, and future selves. They're also how we understand ourselves and one another. That's the simple but profound truth behind this campaign that is called Write Our Story. And that's why we are also starting off our time together today by sharing some of the stories we've been honored to receive by the young people who have bravely shared with us. And Melvin and I are going to read them on their behalf. In elementary school, my friend and I were sharing a lunch. We both brought common Korean snacks to trade and eat. The kids at the table next to us complained that the food smelled horrible, telling me it was ching-chong food. Throughout all of elementary school, I was called names, shoved, ignored, left out, and the school did nothing to stop this. It's not just a joke when it hurts people. For the last time, hate is not born with, it's taught. We need to end these stereotypes and realize we are all human.
At my last school, it was predominantly white. I was one of the few Black girls. They would call me and say the N-word, and when I would tell someone, they wouldn't do anything. They kept doing this for months and nothing would change. They would also comment on how dark I am and my hair and say, go back to Africa, and no one would do anything.
And finally, a lot of times from elementary school all the way up until my freshman year of high school, I was bullied for being Middle Eastern. In 4th grade, some kids went through my backpack and tore everything apart, and they said that they were looking for a bomb in my backpack. In 5th grade, I was called a terrorist almost every day. In 6th grade, I experienced some of the worst bullying of my life. After falling out with a group of girls, they made me out to be the bad one after I stood up for a friend who they were bullying. From 6th grade all the way up until the middle of 7th grade, I was bullied in person, iced out from every girl in my grade, cyberbullied, and the worst part, no one did anything about it. I was utterly alone, and it led me to have some serious mental health issues. So those are just a few of the stories that we've received, just a fraction, honestly. And I have read each and every story of the hundreds that have come in to us. And it's clear that bullying is more pervasive than ever. And the modern life's full spectrum of being always online means bullying behavior is all the easier to practice and is all the more widespread. If you have read, if you would read all of the stories that we've received, you might be surprised at how serious the things are that these young people are experiencing and at such young ages. Write Our Story is a unique campaign and community actually bringing up the topics of race-based bullying and mental health, a discussion and forum led by youth and for youth. And I know some of you who have been involved in the campaign are here right now, so shout out to you, and this one's for us. And I say Write Our Story is unique because we often hear from young people that these topics aren't something that they've had a chance to, or a space to talk about or share safely and connect about on this topic. Another common theme from our research and our direct interviews with young people and educators is that the only time or place they can ever remember bullying campaigns or anyone trying to do anything about it is posters that go up in the hallways and then fade away. We cannot afford to treat young people like that and break their faith in this movement by suddenly just dropping off of a ledge. They trust us and we're accountable to them. And the reason we included some of these faces here is because these are just a few of the faces representing the young people who are leading this and to whom we're accountable. The Write Our Story campaign has over 8,000 members and is growing every day. During our short time today, Melvin and I want to bring you along on the journey of we, and that includes all of you in this room, have built, and also make sure that we can continue this important work. So we want to begin with the way all of the activations in Write Our Story have begun, with the words of one of our youth advisory committee members named Asha. And I think Asha is actually here herself as well. So it'll be fun for her to see herself on camera, I'm sure. But I'll let Asha lead us off. Oh, I can't hear the sound.
We can't either. Let's see if we can get that fixed.
I'll stop sharing and I'll just reshare just 1 second.
Sorry about this, folks.
Creating campaign when trying to focus on race-based bullying, especially for youth. It's important to have perspectives of youth. I also think I learned a lot in terms of how powerful stories can be and how powerful a community can be when they come together and they become vulnerable to share their stories and ultimately realize that they're not alone.
hear that?
Yes, thank you.
Okay.
And thank you, Asha. Sorry about the sound trouble, but I think we got the important idea of how critical stories are and what this campaign has meant to people who have been part of the leadership team. So as we move into what we've done, I think, the very founding of this campaign by you all, you recognize the need for this campaign during the pandemic. And what we've repeatedly found over the past year, not only through our stories and other inputs, but also in the news, we see how the need for Write Our Story has only grown and only become more severe. I included a few of the headlines that we've tracked that I'm sure you've seen as well, that just show how this urgency and need have really grown. And I'll turn it over to Melvin to get into sort of how we've begun addressing this.
Yeah, so slightly shifting gear, we wanted to outline the movement that we've created. So we built the entire Write Our Story ecosystem from scratch. We started with creating a home for the campaign. So the website, writeourstory.com. If you haven't visited it yet, I encourage you to do so. The website provides our audience with the purpose of the campaign and invites young people to share their stories and experiences of bullying in a safe and more importantly, in an anonymous way. We also designed the beating heart of the campaign, the Write Our Story community. And here young people can access our full library of stories and experiences of bullying, provide support to one another, have meaningful conversation, and share ideas on how to have a positive impact in their own community. We also had to meet our audience where they were to get them to the website and to the community. And what that meant is creating a social media presence, leveraging partnerships and advertising, both online and offline, via multiple different tactics and platforms, ranging from paid social media to influencer marketing to even out-of-home advertising in community centers, in malls, and even in Major League Baseball stadium across the state. We need to make sure that we were able to create what we call a surround sound effect around young people to catch their attention. Once we had that attention, we offered them multiple ways to get involved. As Clara was talking about, we already talked about the stories that we got. We talked about the community a little bit, but we also hosted a week of action in May with multiple panels featuring really inspiring young people and partners like the Youth Leadership Institutes. I believe some of you are on the call as well, AAPI Youth Rising, and some other partners as well. And during these panels, we're able to discuss ways to cope with bullying and some of the mental health effects, but also talk about solutions to race-based bullying. Finally, during the week of action, at the end, we launched what we call the Bullied Button. The Bullied Button is an online tool where someone can log a bullying incident quickly, safely, and anonymously. It helps us understand and get the data about where and when bullying is happening in the States. And also, it helps us develop potentially future solution to bullying. It's also another way in for young people to share their voice if sharing their stories is too big of a step for them to take. Before we dive into some of the numbers, we wanted to mention the central role that was played by the Youth Advisory Committee and also by YLI in the creation of this campaign. All of the elements I just described were either workshopped, proposed in some instances, and or approved by the Youth Advisory Committee. Alexis, which I believe is also on the call, is one of our most active members of the YAC, and she recorded a message for you about the importance of the Write Our Story campaign. And hopefully the sound should work, but let me know if it doesn't.
Hello, my name is Alexis Zuniga, and I'm one of the youth leaders with the Write Our Story campaign, and I'd like to share a little bit more about why I feel this campaign is important. Many of us have experienced bullying, but when it comes to racial bullying, I feel we kind of push it aside or neglect the fact that these are very hurtful, especially since it is used in a jokingly manner or to express stereotypes. With this campaign, it has allowed us to share those stories of racial bullying so others can learn and understand that maybe the things they've said or maybe the things they've heard are racial bullying and are hurtful. I really appreciate that we have created a program that allows for people to be anonymous and share their stories because it can be a little scary. So the Bullied Button is a really nice source for people to share what's happened in their life and find resources while staying anonymous. And for myself, I have been able to be vulnerable with my other youth leaders. And I think that's such a great resource for myself because I never really identified how much racial bullying has affected me and maybe my own experiences and the mistakes I've made in the past. But hearing other people's stories and what has been shared with us, it has been very educational, and it helps me move forward as a person to be very cautious of what I say and how I interact with people, and maybe also allows me to send a resource to people if I see racial bullying happen.
Thank you, Alexis, for that. All right, so now we wanted to talk about the numbers of the campaign, and wanted to make sure that through these numbers, you're able to see the user journey we've tried to build. So numbers are going to appear on the slide as I talk through those. So as I explained a few minutes ago, we used a range of tactics and platform to create momentum. And so these resulted in over 200 million impressions. So impressions is the number of time our ads or content was seen online. 1.6 million clicks on our ads, and close to 150,000 engagement on social media. Engagements meaning when someone comments, if someone shares the content or reacts to these posts. We've also engaged 14 partners. Some of them were involved by sharing the resources that are featured on the website, or also just working with us on a pro bono basis because they just simply wanted to help our efforts because that issue is that important to them. All of that helped drive over 400,000 visitors to our website, where we collected almost 300 stories. So the stories that you've heard some of those examples, and also close to 500 bully button incidents. And finally, at the end of July, we kind of just shy of 9,000 Write Our Story members across both our community and our social media channels. And our efforts have been noticed. More and more organizations started to reach out to us directly to ask how they could help spread the word or how they could be involved in the campaign. One story that I wanted to share was the one of the San Diego Padres. This is the Major League Baseball team that's down in San Diego. They reached out to us after seeing one of our ads in the San Francisco Giants Stadium while they were playing a baseball game there. And now we are working with them on a few activation on sites in their stadium, but also at multiple family events that they host until the end of September. We also have a few activations that we're working on for Bullying Prevention Month in October. We are working with Cayenne, that was on the call earlier today, and also with the California Association of Student Council on new content and new resources that we can share with young people. And with all of that, we hope, give or take, that we can double the numbers that were on the previous slide and are here as well by the end of 2023, which we're really excited about. But we also wanted you to look further than that and to imagine what we could do if we continued this campaign in 2024.
Sorry, I was on mute. Yeah, as you all have been talking in your discussions, we've heard you echo this theme, but wanted to drive home that, you know, we've built momentum and a strong foundation for growth that Melvin has just described, but changing behavior and actually impacting society does take real time. It's not a light switch, as we all know, or our world would be a lot better place. Behavioral change takes roots, consistent care, trust, and relationship building, and dedication. And if we are serious as a group about writing the story of race-based bullying, and its impacts on young people's mental health, we need to be here for the long haul. We have a chance, but we have a chance and a choice between confirming young people's expectations that these types of efforts are just a blip on the radar, or we can prove to them that we're serious about allying with them to create change.
And really, again, it's really all about young people and all about the future. It's very basic, but it is true and fundamental to our campaign. Young people are the people who will set the next standards of how we treat one another. And we've heard a lot of ideas and a lot of momentum, and we have, I think, a lot of hope from what we heard during our Week of Action panels. Young people are the people who will choose to support and give to some causes and not to others. They are the people who will age with the repercussion of the choices they make. We know that Gen Z cares and acts on a higher rate than other generations. And action takers today who mean to have a lasting impact know that lasting change deeply involves young people. And we can give them the tools and commit to change alongside them. By continuing this campaign into 2024, we can help them build a better world, not only for themselves, but also for the generation that would follow after them and that will look up to them and to the behaviors that they have with each other.
And to give you a glimpse of what we have in store, among the many other things, for 2024 and beyond, is moving into gaming. I know Commissioner Chen and others on your team, we've had conversations about sort of the innovative world of technology and how that intersects with what we're doing here. So one major vision we have is looking at young people's mental health, forms of bullying, and gaming. Gaming is really interesting because unlike many social media platforms today, people are relatively anonymous, right? They're represented by avatars. But still, games are one of the social media platforms where cyberbullying happens most. Yes, games are social media platforms, so just making that that connection, but also some of you may remember Gamergate and how it brought our attention to the way young people, young women were being treated online. Young people go to games to enjoy and entertain and be creative, and sometimes to compete and form connections, and sometimes to escape the things that are happening in their lives. Games are often thought of distinctly from social media, but as we just pointed out, that's not the case, and this is an important space we need to be in. If we want to talk about it, how do we address the digital experience and really life experience young people are having overall? One thing that's become really abundantly clear in this campaign is that if you think about it, there's not really any divide anymore between online and offline life, right? Nobody's really offline, we're always online. And I think we need to start responding to that and adjusting our strategies to reflect that reality. So if we want to address mental health and bullying, including race-based bullying, we know that one of the best places we can do that is in the gaming sphere.
Thank you, Clara. And to wrap up, we wanted to finish on mental health. As we saw on earlier slide, the news has documented the rising trouble that young people are facing and reporting when it comes to mental health. And we already know that all of you know how important it is to the future of young people. One thing we've learned, working not only on this campaign, but across multiple clients, multiple different causes and audiences, is how hard it is to really build trust and earn trust with your audiences. Earning trust is a huge indicator of how successful your campaign and aims will be. Building trust is a very long game. However, breaking it is very short and quick. And building trust is so important if we're going to make a real inroads with the young people that we started to have our audience during this campaign. We've come so far, and all that will just feed into the negative, skeptical narrative if Write Our Story just comes to an end at the end of the year. You heard the few stories we had time to share about what young people are facing right now. Imagine if you had a child, and I'm sure some of you already had that experience, when they come to you with this type of experiences and concern, remember how that felt. It has never and still isn't about, those of us that are on the call or in the room today. It is and always has been about the young people who are feeling outcast, feeling put down, feeling desperate, and more importantly, feeling alone as they face these issues today. This campaign is an investment for sure, but an investment that pays off richly both right now and more importantly for the future. And we hope that you see it, because we don't believe we can stop this campaign right now. And with that, we wanted to thank you for your time today and open the floor for any questions.
Thank you. We want to thank you, Clara, Melvin, and the youth who participated in this and who are with us today. Thank you for taking the time. Commissioner Chen, Andrea, all your leadership. I know this is a very important topic, very near and dear to my heart. I got into bullying prevention. Gosh, I think I got certified in South Carolina, Clemson University, when I was pregnant with my 19-year-old now. I was hormonal and I was on fire and I was gonna stop, put on my cape and address bullying all over California. And there's certain things that never left me. One of the ways that we identified or defined bullying, and it was an acronym, it rips your heart out. It's repeated, intentional, and there's a power imbalance. So it really does rip your heart. I want to thank you for the work. I want to thank you for putting it up front and center, because there are young people who are suffering at nothing that they did, right? Just being targeted. And this has to stop. And you're exactly right. It is going to be our youth who flip the script. This is not okay. And nobody has permission to hurt somebody else for no reason, for any reason. So thank you for the work that you're doing. Thank you for coming to us, sharing it. I'm sure I speak for many of my commissioners. We are honored to be supporting this work, and I'll stop ranting and raving. I'm super excited with what I saw here today. So I'm going to open it up to my fellow commissioners for comments. I see Commissioner Mitchell, please.
Great presentation. Quick question though, what is your website? Did I miss that? Or where are you guys on social media? And second, your messages are about anti-bullying and anti-racial bullying, but do you guys do messaging regarding just anti-hate, period? Because if we could deal with anti-hate, maybe we could get to some of that anti-bullying behavior or racial bullying, because these behaviors are taught. So if we can be taught not to hate someone because they're different, another group, and then just this, I don't know how you guys are dealing with the use of the N-word, because that's a part of this too. So, it's all of that. It's a problem. I can use the N-word, you can't. I can call you a name, but you can't call me. So what's the messaging regarding anti-hate and respect? And I want the website.
Yeah, do you want me to take it, or do you want to go, Melvin?
I'll just share the website for you. So the website, you can see the name of the campaign right here on the slide. It's called Write Our Story. It's a little bit play on word on writing and write like wrong or right. So if you go to writeourstory.com, you'll have all the websites. And then on the websites, you also will have links to our social media. We're on Instagram, TikTok, predominantly. So you can check us out there. And Clara, if you want to respond on messaging, I'll let you do it.
Great. Yeah, feel free to check that out. And if members of the commission want to also explore the website, the community, it's primarily for young people right now, because we wanted to create a separate space distinct from social media. But you could let us know, let Andrea and Anna know, and we can make sure you get access. But to respond to your question, that's really thoughtful. And I think one of the things that we found as we began and dug in research and talked to young folks is that there's a huge deficit in terms of actually acknowledging a definition to bullying. So one of the things that we've needed to start to do as part of this campaign, which you alluded to, is begin defining what is a bullying experience. And we did a bunch of research around that. We've been talking about it. And that's one of the reasons why we have led with showing stories that show what is included in the anti-bullying, race-based bullying umbrella, right? Things like acts of hate, using offensive words to address somebody, being hostile, and isolating somebody, being aggressive, all of these things that have come together. And our stories that we show, which is, as you saw, part of our fundamental components of our campaign, really help to define bullying by showing, right? So a lot of the times we like to show rather than tell, right? But then also on our end, when we receive these stories, we have a whole bank of them, and we do we take the time to like classify and tag them into different categories so that young people can also start seeing what are all the different facets, like you mentioned. So I think there's a lot, I mean, we could go on forever about that, but that's a little bit of how we've started to think about the use of language and the intersection of acts of hate and hateful language.
This is incredible. Thank you so much, Clara, Melvin, and Commissioner Chen, for all your leadership and work on this. And my question is, this is just so impressive again and needed. And I really appreciate how you framed, obviously the messages to let the youth know they're not alone. And then even defining it by showing versus telling, all of that is just, we need so much more of this. So what is it that we can do? What are the next things that like you would say, what's your ask that we can advocate for also and see how we can grow this?
Yeah, thank you for your comments and thank you for the question. I think for us to ensure that we continue this question, we need, I think, more time. I think in the previous discussion, someone was talking about change and how we can measure change. And as Clara mentioned during our presentation, change takes time. And if we stop this campaign that would have run from February up until the end of this year, this is not enough time. So we need more time, because building trust, like we said, take time. And we started doing this with young people, but we need to do more. And so we need time, and we need additional funding as well to be able to, to continue this work, to engage with other partnerships. Like we said, I think what we wanted to do as we started everything from scratch was really building momentum, building credibility behind the campaign, and making sure that there was buy-in from youth. And from that, we want to go after, gaming industry or, social network, but we also want to be more embedded in schools and with educators. We didn't reach out to, schools and educators at first, but we knew that if we had nothing to show them, no momentum, no members, they were not going to take us seriously. So now that we're really starting to build this, we'd like to, to use that momentum to continue to build and reach out to different, stakeholders so that we can continue this work.
And can I just add, Melvin, too? I feel like, we want to be able to make inroads with educators. And while we wanted to start with the youth as our core, because that's really, right, like this is about them and it's for them. We have managed to find other ways to engage educators. For example, one of the partnerships that we've created, and that's going to be important for what we're doing in the fall this year, is the California Association of Student Councils. So I think I got the acronym right, but we love that too, because once again, we're going through the youth, right? Like this is not just happening from the top down, which has always been another really important component of this effort. Is, the last thing young people want is to sit around and be lectured by the above, as all of you with kids, I'm sure know. So, that's one thing we love is like the youth, the young people, finding ways for them to bring it into their schools. And yes, through partnership with educators, but also always maintaining and protecting that core of really having young people step up to be the leaders, because we know that they are also the ones who have the greatest impact and influence on their peers. And so there's a lot packed in there, but like Melvin said, we've just been so excited to see, and moved really. Like you heard just a few of the stories, but it is insane what young people are going through right now. And just the idea of turning the lights out on the campaign, I cannot imagine having to do that and having to tell people who have told us when they came in the door, thank goodness this is the first time I've actually been able to process and share my story, because there is no other place like this. And I could go on and on, like I said, but like, I hate the idea of having to be like, well, you know, it was great and meaningful, but goodbye.
Yeah.
So, yeah.
Thank you, Clara. Thank you, Melvin, again. Thank you, Commissioner Chen. We're at this time going to take members of the public and see if they have any comment on this agenda item. And if they do, please do so by raising your hand and clicking *9. Pushing *9.
Okay, so we have 2 public comments. We have Laurel. Your line is open. You can go ahead.
Hello, I'm Laurel Ben Hamida, and I am a founding member of Muslim American Society Social Services Foundation in Sacramento and a member of REMCO. And I'm very happy to see and hear about this project. I don't know how it got by me in the last year, but I do recall that at the beginning you said that the list of bullying the list of reasons why a person might be bullied, and you did not mention religion. And I think that's the 800-pound gorilla standing in the corner of this room. I was happy to see that you cited the story of a person of Middle Eastern background, but I think we have to be clear that religious bullying is a big problem. And CARE, the Council on American Islamic Relations, the California CARE, has reported over the years and done reports on bullying and other issues that affect children. And it also comes from teachers. Sadly, very sadly. I would encourage you to share with us what input you have had from children who've been bullied based on their religion, no matter which religion it might be, and whether you're able to include children whose first language is not English on your websites, because that's of great importance too. And I might add also that I'm the grandparent of Algerian, Pakistani, and or South Asian, Indian, Pakistani origin. And so this touches us all.
Thank you so much, Laurel.
Yeah,
Are we
thank
supposed to respond or?
Oh, thank you, Clara. We're going to go to Stacy Hiramoto. Thank you.
Hi, Stacy Hiramoto with REMCO, the Racial and Ethnic Disparities Coalition, and I'm going to cede my time because Commissioner Chen was trying to say something, and this was a fine presentation. I have so many questions. I'm not surprised to see that this is the last thing on the agenda that ends at 4, because things that have to do with race and ethnicity often get put to the very end. I'll try to reach out to you, Commissioner Chen, because I can tell I can't even tell if there's any other commissioners left besides you two. So I would really like to talk with you, because I would like to see this project continue, but I would like to hear what you had to say. Thank you.
Really appreciate that, Stacy. Is it okay if I take a quick minute to do a quick add-on to what Melvin and Clara have shared earlier?
Please, Commissioner Chen.
Thank you very much. So I just wanted to share briefly in addition to the last question, and thank you so much to Laurel and Stacy for your comments as well. I wanted to do a quick add-on because I know we've spoken a lot within the Media Cause team, and even since the very beginning of the project, we talked about wanting to engage more stakeholders beyond youth. We definitely wanted to stay with youth at the core, but absolutely engaging teachers, parents, engaging peers, engaging really anyone in the ecosystem that play a role. I know in the context of this project, we haven't had the time luxury to get into what materials do we put in front of parents, what do we put in front of teachers that can help facilitate these conversations. And certainly, to Laurel's comment as well, expanding to conversations around religion is an important role in all of this. So I hope that this is the very beginning of what can turn into a much longer and larger project, because it is incredibly important, particularly at this point in time, for us to be having this conversation. But I do think the numbers that the team has presented has shown a lot of early success, and I hope that that gives us really solid foundation to continue the conversation. So even the last time when we presented to the commission and had gone back to the team, we've talked internally about being able to showcase better data so that we can continue to get further support in expanding the scope of the project. So would love to have everyone's support in doing that. So thank you so much.
Thank you, Commissioner Chen. So at this time, we are going to conclude our meeting. Again, thank you for your presentation. We want to thank everyone for joining us today to continue the work and discussions around mental health. We would especially like to thank members of the public. We value your input and participation. Our next commission meeting will take place on September 28th in Los Angeles. We look forward to meeting with you then. Today's meeting is adjourned. Have a wonderful day.